of hands from all the delegates asking that, what is your priority when you choose an anti-seizure medication? Is it that the patient, it should be very efficacious? Is it that it should be without side effects, or any other? And one is not surprised to find that I found that 90% of them said that it should be without side effects. It's not the efficacy that matters. The patient is already having a seizure. He can sort of dwell with it, but then he cannot fight with the side effect of that particular medication. Monotherapy is preferred, we all of us know. So the things that I would, and I have put it out in this slide here, is that I would try to see first the seizure type and the syndrome from there. What is the frequency of seizure? Is he getting in clusters? It is very severe presentation. So a rapid versus a more gradual one. What are the other comorbidities that the patient has? Is there any teratogenic, which I wouldn't be talking here because there's the next panel discussion on that. Side effect profile, obviously, which is a short term as well as a long term. How the patient will tolerate that particular anti-seizure medications. Is he on any other drugs, drug interactions? Obviously the cost, because that would be the retention rate for that particular individual. And then we know that we are in this era of genetics. So pharmacogenetics is absolutely needed in certain particular epilepsy syndromes, which I would come across. So looking at seizure type, so we have so many guidelines, but then if you just look at it from 2019, we have just randomized trials, we have reviewed data, but then this is just a slide which shows from 2006, we have the ILA systemic review, and then we have the MPA, that is the Swedish Medical Products Agency guidelines, which was in 2011. Then in 2012, we had the NICE guidelines. 13 had an update of their own guidelines. 16, NICE had an update of their own guidelines. 17 came out with the Cochrane guideline. And then American Academy came out in 2018. And 19, again, MPA, that is the Medical Products Agency, that's the Swedish guideline has come. So this is where we will be floating between our Indian guidelines. We know that we have a G-Mind, which is from the Indian Epilepsy Association and the Indian Epilepsy Society. But then one might want to float over and take any of these guidelines. For me, I would be just quoting the 2013 International League Against Epilepsy updated guidelines on my further slides. So the first thing is how I would take forward with the seizure. That's a patient with a partial seizure. So how many classes of studies we have? Class 1 is 4, class 2 is 1, and class 3 we have 34. So you can see here that level A, B, C, D, level A, we have partial seizures, we have a lot of medications, we have level A evidence. But when I come to the generalized seizures, you'll find that level A, B, C doesn't have anything because nobody is doing a trial on a generalized epilepsy syndrome. So if you look at those slides and an overlay between the Swedish medical products, there's a Swedish guideline and these guidelines, more or less the same. It's carbamazepine versus eslicarb, levetiracetam, lacosamide, phenytoin, and zonisamide. And more or less the Swedish guidelines also states the same way. And these medications as carbamazepines, esli, levetiracetam are in alphabetical order. They are not in their area of importance. So one can choose depending upon the other comorbidities for that particular agent. So we have an elderly adult group also, not only the adult, we have an elderly adult group in which we have the level A evidence for levetiracetam and lamotrigine, which we very commonly use for these patients. We have patients with adult onset. We can see that generalized tonic-clonic seizures, level A and B, we hardly any. Class 1 and class 2 study, we hardly have any. As far as the Swedish guideline is also concerned, we are sticking on to lamotrigine, levetiracetam, and sodium valproate as the classes of monotherapy in that particular individual. Juvenile myoclonic epilepsy, you can see there are hardly any studies on class 1 and 2, and level A, B, C are none. And we the level D are only for topiramate and sodium valproate. We use levetiracetam also for the patients now. So as I said, orphan drugs. So when you already know that you have an orphan disease in a patient, particular patient, so you should quickly tune yourself, your treatment pattern also to using that particular agent, which has been approved for that. Like if you're looking at a PME patient, you may want to use a brivaracetam quite early. Cannabidiol, we know that it's floating in the market and is recommended for every epilepsy syndrome by some of our colleagues who are still sitting here. So infantile spasms, neonatal HIE, Dravet and LGS. Dravet and LGS, it is being more commonly used. But then from our Indian scenario, we still need to have literature out how the patients are tolerating. Clobazam, we know for LGS. Felbamate, we know for LGS. Dravet syndrome, fenfluramine. Stilipentol, we know that it's for Dravet syndrome. Vigabatrin and salthiamine for benign epilepsy, which are centrotemporal spikes. So the next we come to seizure frequency and severity at presentation, rapid versus more gradual. So titration is very important. So you don't keep a drug patient with a slow titration like carbamazepine, oxcarb, lamotrigine, topiramate, phenobarbital. If you have a patient who has had a cluster attack of seizures outside, he had a seizure while he was waiting outside, so you cannot initiate a carbamazepine or any of the drugs which needs a very slow escalation of anti-seizure medications. It's not possible. But you would obviously be wanting to have a patient on a fast titration where you could put a levetiracetam or sodium valproate, or for that matter, clobazam or lacosamide, phenytoin immediately, and ensure that this is given a chance that you might want to keep him in the emergency and bring up his blood levels with an injectable. That's another way, but most patients are really not. As Satish Chandra sir knows that we are now the Indian Epilepsy Association moving forward for insurance with patients with epilepsy because patients don't want to because they are not insured at all. So you want to take a call on how I want to, if I put a patient on carbamazepine and send him off, would he come back again to the emergency? Probably with a status. So do I want to choose the drug with a fast titration? You should also know have a fair idea of the free fraction of the anti-seizure medications, because if you are initiating a particular patient on a particular agent and you know that his serum creatinine, especially we are talking about an elderly with multiple comorbidities, you know that his free fraction, if the patient has got a renal impairment, his free fraction levels might be different, and then you might have a free level of the drug which is very high and can lead to a toxicity. So the drugs which are very highly bound are more than 88%, and that's why in a clinical scenario, probably it is very less and less used now, like carbamazepine, phenytoin, phenobarb, on most of the drugs like valproic acid. But the minimally bound drug and very minimally are the ones which are lacosamide, levetiracetam, topiramate, and lamotrigine, which are easy to handle in a particular patient who has got comorbidities, and we are not we're not much concerned that how much is free bound would be there. Say, for example, the patient is on dialysis and you really cannot do a levetiracetam level every time. You cannot do a phenytoin level every time. So you need to be ensured of that. Second is comorbidity. It is pretty easy because nowadays when we keep seeing, so you really keep that in mind. This also helps us in a long run for the ensuring that the patient retains the tablet. So it's not just diagnosing the patient, keeping him on a single anti-seizure medication is also very important, that he takes the medications for 3 to 5 years, because we know that retention rate of many of the medications who are excellent drugs without any side effects in the early stage tend on to develop so many other awful side effects, and the patients just stop it and come back in status epilepticus. So the ones that are avoid, and there are certain drug profiles with advantages. So the patient is obese, you may want to have a topiramate or a zonisamide. The patient has sleeping disturbances, you could use the anti-seizure medication to its benefit by using a benzodiazepine agent. Patient has got concomitant migraine, we know that many of them have. It's very useful to use a sodium valproate and a topiramate. Patient has neuropathic pain. We know that patients can be diabetic, especially we're talking about the adults and the elderly ones. You can use one of those medications. Mood stabilizers, we know it is lamotrigine, sodium valproate, the sodium channel carbamazepine, and the oxcarb. You should definitely be avoiding cardiac conduction abnormality medications, especially in an elderly who is already on some of those cardiac medications, and you know that you're going to push him onto that. Lacosamide is one thing which you should be pretty careful. It's not that very commonly a drug, but then we know that they have got rhythm disturbances. One should be careful while you are using the drug. The patient has got a history of renal stone. So it's very good to just ask if you are initiating. You might not wanting to ask a history of renal stone for every patient, but then if you're initiating that particular anti-seizure medication like topiramate, zonisamide, you might just want to ask, is there a history of renal stone in the past, so that you're not going to push the patient with a minimal dose itself. Aggression and irritability, we know phenobarb, levetiracetam, and perampanel. Osteoporosis, all the enzyme-inducing anti-epileptic drugs. In a postmenopausal female, but you would be, again, very cautious of using that particular agents. Hepatic, the ones which are hepatic metabolized, renal impairment, again, levetiracetam, topiramate, and phenobarbital. So any of these medications can be used to our benefit, as well as one can be also very careful. So the next is, I clubbed together the short and long-term side effects and the tolerability. So we know that when we initiate a patient on a particular anti-seizure medications, it is, one is, we know that because of the metabolic, because of the inherent characteristic of that medication, patient's medication, you have a type A adverse effect. Second, we have a type B adverse effect. That is because of the idiosyncratic. It is not related to the drug. It is related to the patient inherent characteristics. So we know that we have genetic testings now, and that I will come later, that we can predict whether the patient can have particular idiosyncratic reactions. So I will not give that particular agent. Then we have other drugs, other side effects, which are prolonged use, long-term use, and tachyphylaxis. So the patient, particular after a period of time, the patient loses, I should say, the medicine loses interest in the patient and does not work for the patient. So that we have those. So all of these side effects we should keep in mind. So you know that a benzodiazepine, clobazam, after a particular period of time, I might not be sure that that particular anti-seizure medication might work as well as it worked in the initial stages when I initiated to the patient. So we know that enzyme-inducing anti-epileptic drugs decrease the bone mineral density on chronic exposure. So a particular group of patients like postmenopausal women and any of them, you would definitely not be having. Advances in genetics have really helped us in doing that. Like we have the HLA phenotypes and other ASM-related dermatological abnormalities, where we can see that the patients, especially the Asian countries, where you have the facility and the patient is also wanting to get it done, is okay with that. And also you're wanting to initiate that particular anti-seizure medication. You don't want to, you don't do it. But if you want, we have no other way. All the other side effects are there for the newer anti-seizure medications, then particularly you may want to. So you can get an HLA-B 1502 and you can predict, no, this patient is not going to have a horrible Stevens-Johnson syndrome, and it 10 for that matter. So other dose related, which are reversible, we may always want to consider. You don't want to have a patient who is a high strung patient who's already has got a personality issue. You already know that he is going to be irritable with any of those medications. Definitely don't want to introduce a levetiracetam for that. You already see that the patient is anorexic. You do not want to. As I said, you use the side effect to your advantage. In women, obviously, even if it is an adolescent girl, it is advisable not to initiate an valproate at that particular setting, because we know in our country, patients take the medication, they do very well on a 200 BD dose of sodium valproate, especially the JMA, they lose to follow-up, and then they just get married and get pregnant and come back. So probably during that adolescent stage itself, it is wise that we do not indulge in taking a sodium valproate for that, because we may not sure that you cannot, unless you have a registry where you keep calling the patients and finding out whether they are taking that particular and that needs to be changed. So it tics and insomnia, lamotrigine, metabolic acidosis, topiramate, language dysfunction, photosensitivity, zonisamide. There are more of them. They have just coupled some of them which might be a little more relevant to the setting. Again, idiosyncratic reactions. We know that hepatic failure, aplastic anemia, hyponatremia, especially for carbamazepine and oxcarb. One should be very careful again in using an elderly people. Acute closed angle glaucoma for topiramate, renal stones again for topiramate and zonisamide. They may be once in a blue moon, but when it happens, it's very difficult, and it's always wise that we keep it in mind. Tell the patient, drink plenty of water. If you get some abdominal pain, come back. If you're putting on topiramate, get your intraocular pressures checked every 6 months, jot it down in your file and see that it is well maintained and you have a good patient and clinical rapport there. Next is the drug interactions. So that in general, the drugs that may induce the metabolism are the enzyme-inducing first-line drugs. So when you are using a sodium valproate and a phenytoin, you know that the sodium valproate might tend to increase the phenytoin levels, and the patient may land up in toxicity. It's such a gradual one. The patient may just come with a gait disturbance, and the patient might feel that it is because of ASM related, and then either he may stop the medication and go into a status epilepticus. Anti-seizure medications that inhibit the metabolism of other drugs are sodium valproate and felbamate that are highly bound. As I said, they might tend to displace, that is sodium valproate, phenytoin, tiagabine, carbamazepine, and oxcar. The other drugs that may alter the metabolism of protein binding, especially the antibiotics, the chemotherapeutics, the oral contraceptives, the oral anticoagulants, have to be especially kept in mind. So if you are initiating in a patient on any of those enzyme-inducing drugs and the patient has any of those symptoms, then one should be very careful. You should slowly taper and take the drug off. Cost, we all of us know. There's just a chart. This is an old one. Probably there may be a new one with multiple drug companies in the market. We know that some of the new anti-seizure medications are also less expensive now. There are several generic variants of all of those medications. So one needs to keep that in mind. I'll just have 2 slides extra. Genetics, we know that there is a pharmacogenetics in epilepsy, and with artificial intelligence in place, we know that there are a lot of studies and they have been extremely useful for us, especially in certain clinical settings as well. You can see from 1997 till 2012, the number of studies, especially on phenytoin serum levels. We also have a study with polymorphism on phenytoin serum levels, which we would be publishing because the alleles of those particular agents helps us for that. So where does that help us? The mutations of SCN2A and SCN8A genes, it helps us because these are the conditions with benign familial neonatal infantile seizures to epilepsy of infancy with migrating focal seizures or the severe epileptic encephalopathies. Phenytoin may be very helpful in these particular patients. SCN1A mutation, we know the Dravet syndrome, phenytoin and lamotrigine have to be avoided. So you have a particular patient with that mental subnormality. You have a patient with refractory epilepsy. You are considering a patient with Dravet, then you want to send that particular gene. You want to avoid these particular agents in that way. We know that we have the everolimus, that is a mTOR, that is a mammalian target or rapamycin inhibitor, which has a demonstrated efficacy in patients with focal epilepsy in tuberous sclerosis, especially in the SEGA. That is a GLUT1 deficiency. We know that it is, again, a genetic metabolic encephalopathy. It is, again, a genetic mutation to SCL2A1, in which the glucose-1 transporter is encoded in these conditions. You are giving a ketogenic diet and you're giving an alternative diet for the mammalian brain. So you know that this is going to work so very well for those patients. Obviously, the polymorphisms of CYP2C9 and CYP2C19, especially for phenytoin, because if you know the polymorphism, you know that that particular genetic variants which have been identified, CYP2C19, the phenytoin dose can be affected. KCNQ2 related is, we know that there is a epilepsy for that, and epileptic encephalopathies, reticabine is important in that particular patient. Couple of questions, I just leave it to the audience, whether the new ASMs are better in efficacy, are better tolerated, are less potentially life-threatening adverse effects, pharmacokinetic and pharmacodynamics, and they fare well in view of titration, formulation, and frequency of administration. Do patients with new ASM have better chances of sustained remission after drug withdrawal compared to the traditional ASM? So the conclusion is that you need to use an intelligent use of anti-seizure medication, and you need to individualize the treatment. Drug selection is a complex decision-making. Patient and family counseling is important. There's a future strategy. We know that it's going to be a precision and a personalized treatment. And I'm not sure whether AI is going to help us, because we already have an AI tool in the market. It's called EpiFet. If you put in all your patient data there, it says that I don't think this is epilepsy. This is non-epileptic attack disorder. Then you have another area where you say, no, I think it is epilepsy. Then it still gives you an answer for that. So I think, no, it's possible that given the way things are going, we might be using an AI tool to guide us for anti-seizure medication, a proper, appropriate anti-seizure medication. Thank you very much.
Thank you. Thank you, Dr. Bindu. We have about 5 minutes of discussion time. So any questions or comments from the audience? Any questions? If you can please use the mic.
A very good lecture Dr. Bindu have given on how to choose the drug. what is happening is now the whole area is changing. Understanding of the mechanism of epilepsy itself has changed. So we started from neurotransmitters. We went on to look at channelopathy, and now we moved on to network theory. So I think understanding of the mechanism of epilepsy itself, whole thing will change in the years to come. Just to make a comment on that. So maybe, as she rightly pointed out, the genetics is a very important, and the targeted medicine or targeted therapy will come into the picture. We are talking about the pharmacogenomics, both from the side effects point of view, as well as from the efficacy point of view. So we maybe replace what we choose is on the basis of pharmacogenomics. I always fond of saying to our students that when a person comes in future, like you will have a horoscope before the marriage, they will come with a chip, and that chip you put it on in your computer, and the computer chooses depending upon your pharmacogenomics. And that is the day is not too far away. It is not a fiction. I'm sure with the targeted medicine, it is going to happen soon. Thank you.
Thank you. Any other comments or questions? One last comment or question. Yes, sir. If you can use the mic.
Thank you for a wonderful talk. One of the things coming up recently is a lot about medical legal issues. You talked about the Stephen Johnson's with carbamazepine. You made your statements. Same problems we face also with now TPMT and azathioprine and all. So one of the problems in public is a lot of doctors tend to backstab others. And so the question now becomes is that how are we medico-legally safe if we do not do these tests? Sometimes it's not available to us. Patients do come and ask, we could have prevented a Stephen Johnson's if we had done the testing. So any comments on that?
That's an excellent and relevant question in the clinical scenario, I should say. If you are initiating the patient on a carbamazepine or any of the drugs which you feel that has an HLA haplotype available, it is better to tell the patient that this can have a side effect, which can include a simple rash where you can stop and it doesn't escalate. Or even if you stop, it just goes on to Stephen Johnson syndrome and all. So the second question, he will immediately ask, doctor, why don't you put me on any other medications which is available? Then you can say, okay, I'll put you on the other medication, but that might be a little expensive on your pocket. And if it's out of pocket, then it might be difficult for you to retain. That test is available, and there are several outsourced labs are there. You can always tell them, you can tell them the cost. I think it is always better to let the patient decide that he doesn't have the money to pay it, rather than we deciding that he doesn't have the money to pay it. In that way, I think we are scientifically sound. We are asking and telling them what is there. The government doesn't have ways and means to have that HLA typing done in a government setup. It is only available in the labs, which are very expensive. So the patient can also choose out of that. Or we can say gently that we have a clinical experience, that you immediately see the rash, you come down, because we're going to do it in a very slow manner. We're going to start from half tablet or so, let us say 200 milligram. So it may not be that way. So quick decision, putting the patient on his goal, I think, is also very important.
Thank you. Thank you, Dr. Bindu. We move on. Our next speaker is Dr. Sujit Kumar, who is part of the organizing team and is from Apollo, Bangalore. And he will be speaking on the topic of Semiology of medically refractory epilepsy. Over to you, Dr. Kumar.
Thank you, sir, for the kind words of introduction. Respected teachers, I'm indeed honored here to be amongst my senior teachers, my colleagues and friends. Now we move to a very clinical topic, Semiology of medically refractory epilepsy. I always like to start with an anecdote. So this was the famous writer Fyodor Dostoevsky, who wrote various books like Crime and Punishment. He suffered from a very peculiar malady. He had complex partial seizures with an aura of happiness or ecstasy. And he lived in a very embittered time of Tsarist Russia. And so he often said that my most happy moments were those before a seizure. Before I start, we are what we are because of our teachers. And if I have seen further, it is by standing on the shoulders of my teachers Professor Vivek Lal and Professor Dinesh Nayak. 50 million people suffer from epilepsy. A large number are in India. Coming to what is medically refractory epilepsy, Professor Patrick Kwan has defined it as failure of adequate trials of two tolerated and appropriately chosen and used anti-epileptic drug schedules to achieve sustained seizure freedom. The sustained seizure freedom should be at least 3 times the greatest seizure-free period of the patient. And as we know, intractable seizures are not good. They lead to neuronal loss. There are consequences in the morbidity, quality of life. Progressive loss of brain functions have also been shown. Coming to the landmark trial, which popularized epilepsy surgery by Professor Samuel Weeb in Calgary. So here they randomized about 50-odd patients to undergo medical treatment and epilepsy surgery, which was anterior temporal lobectomy and hippocampoamygdalectomy. And they found an overwhelming superiority. 58% was seizure-free in the surgical group. So this set the tone for epilepsy surgery. There is a separate talk by Dr. Anand Iyer on the pre-surgical evaluation. So clinical part and interictal and ictal video EEG form a very important aspect to narrow the lateralization and localization of epilepsy. So here I will not bore you with theory. So we will discuss a few classical cases. So this was a patient who presented to us with a history of febrile seizures at 3 years of age, focal seizure with impaired awareness since 12 years of age. He was on 3 anti-epileptic drugs. I'll show you the... As you can see, the seizure has started. There's a behavioral arrest. There are oro-elementary automatisms. As you can see, the left upper limb and lower limb are relatively free. The right upper limb is immobile. And progressively, it becomes dystonically postured. There's a classical temporal lobe epilepsy. Dystonic posturing is on the opposite, so-called lateralizes to the left hemisphere or the opposite side. And as you can see, there's a profound impaired awareness. He's not able to answer. The technician is testing. And as you will see, this is called, you can see some rhythmic movements. There's a ringe, rhythmic ictal non-clonic hand movement. And one more sign that you will see is that he has a post-ictal nose wiping, which lateralizes to the same side. So this is a left temporal epilepsy. Mesial and this is what we saw on the video EEG. As you can see, this is the F7T1. And you can see this is interrupted by his oro-elementary automatisms. And it evolves in frequency amplitude. And this is what we saw when we did this patient was operated subsequently. So this is a classical dominant temporal lobe epilepsy. Coming to another case, this is a 19-year-old lady, more recent, seizures only since 1 year. So no perinatal early childhood insult, which is classical of MTS. There are other pathologies which can affect the mesial temporal lobe. Patient again had an epigastric rising aura, behavioral arrest. There was left upper limb posturing and right upper limb automatisms. This time probably from the history lateralizing to the non-dominant temporal lobe. Ictal speech was there as well, no clustering or secondary generalization. So this seizure starts from sleep, and now she becomes aware. She's realizing something, the epigastric aura, and trying to reach out to mark the seizure. As you can see, it's different from the previous seizure in the sense that she's more aware. So there is ictal speech. This is a hallmark of non-dominant temporal lobe seizures. And she's partially responding as well to the conversation that is going on. So this shows the onset from the right temporal, anterior temporal leads. And what we have is a tumor, mesial temporal tumor. This turned out to be a DNET. Another non-dominant seizure, this was a 29-year-old male, again had febrile seizures at 1.5 years of age, habitual seizures from 20 years of age. He had an aura of giddiness followed by behavioral arrest and bimanual automatisms. What is unusual is that he had ictal spitting. Normally, ictal spitting localizes to non-dominant temporal lobe. In this case, he had a left MTS. So you can see the spitting that's happening. So we've seen mesial temporal epilepsy, something about neocortical epilepsy, temporal again. This is a 10-year-old girl who was the elder of 2 siblings, seizure since 4.5 years. She had a very bland kind of seizure with just a behavioral arrest and slight movement of hands. Towards the end of the seizure, she would slightly move the head to the right and have some upper limb jerky movements. She had only occasional secondary generalization and she had a postictal aphasia. However, here one can see this is the T5 electrode and we are seeing posterior temporal spikes, not the usual F7 T1 spikes that we get. And this is the video EEG. So the seizure has started. There's an abrupt change in behavior. It happens so subtly that it's not noticed by her mother who's around. See, the right upper limb is very stiff. She's hardly moving it. And then she has a version, post version to the right, followed by secondary generalization. So this again started in the left. The entire temporal chain was involved. Left temporal chain, F7, T1, T3, and T5. And there was a rapid progression and generalization. So this we had to do a grid and we actually found that it was coming from the basal temporal region and the language areas were in 36 and 37. So this was an example of neocortical epilepsy. Another interesting semiology, this was a temporal lobe epilepsy which presented with salivation and vomiting, indicating involvement of the insula. So as the seizure starts, it is triggered by eating, and after that, once the seizure starts, he has vomiting. He is not able to respond. He has a behavioral arrest. Only partial response is there. We'll move to the next case. This was a 35-year-old male. So we finished with temporal. Temporal forms a big chunk of refractory epilepsy. This is a 35-year-old male who had seizures since 5 years. And he had a behavioral arrest followed by tongue automatisms. So something like an elementary motor seizure. Very brief episodes. And what we saw was a focal cortical dysplasia. This is the precentral gyrus. You can see the hand knob. This is the facial area where he had the the focal cortical dysplasia. So this we had to do with awake craniotomy. In the interest of time, I'm not going to show you. We were able to lateralize, localize the jaw area and the hand area with motor stimulation that Dr. Ravi will address in his talk. So, and then the patient we were able to operate without any major deficits and he remained seizure free. This was a 10-year-old boy who presented with seizures since 3 years of age. So this was a gelastic seizure characterized by laughter lasting about 1 minute, 10 to 12 episodes per day. Initially had frequent secondary generalization. On 4 antiepileptics, the secondary generalized seizures reduced. So what we are seeing here is a left frontal interictal discharge. And this is the seizure. You see, our technician was initially confused. She thought this could be a pseudo seizure. She's trying to talk to the boy, but he's not responding. She's trying to induce. But the patient had a fast activity coming from FP1, F3. And this was the focal cortical dysplasia, which was seen in the left middle frontal gyrus. We used intraop ultrasound to operate this patient. A few interesting semiologies. So you can see the downturning of the angle of the mouth. This is a classical Shepard gendarme, which is seen in anterior cingulate epilepsy. This is a classical example of an insular seizure. So she awakens from sleep. Then suddenly she develops a choking sensation, as if somebody is suffocating her. And then you can see there is a twitching of the right side of the face. First, deviation of angle of mouth, followed by twitching. So classical insulo-opercular seizure. You can see the twitching which is happening. So I'm just showing various examples of frontal plus seizures. This was another lady who had a inferior frontal gyrus dysplasia. So she starts with a stiffness of the right upper limb and lower limb, followed by secondary generalization. This was very close to the language area, and after surgery, she had some period of dysphasia which recovered completely. This is an example of medial frontal semiology. As you can see, there is shouting and hyperkinetic seizure with pelvic thrusts and gyration. He was MRI negative but PET positive, showing a left mesial frontal focus. A very brief seizure, recovers very quickly. Coming to the next case, now we have finished various frontal semiologies also. So coming to the posterior quadrant, which we see quite often. So this was a 19-year-old gentleman who had unprovoked seizures at 8 years of age and habitual seizures since 9 years of age. So he had an unusual aura of movement of a cube of colors from the left half of the visual field to the right. He had behavioral arrest and staring, secondary generalization quite often. As you can see, there are O2 spikes. Not very clear, but there are. So this is the seizure. Starts with the aura, then there's a deviation of gaze to the left. You can see there is an epileptic nystagmus, probably involving the parietal eye field. And then you see there's a forced version to the left. So this indicates a right posterior quadrant, probably starting from the right occipital seizure. As you can see a very fast activity coming from the right occipital. It's very focal. It lasts like that for nearly 10 seconds, 10, 15 seconds, and then starts spreading. So he underwent a right posterior quadrantotomy. We had several challenges because he had bilateral gliosis. However, the side which was operated, he had a complete hemianopia on the opposite side as predicted. The other side opened up after a while with low visual aids. Coming to the last case in our series, sometimes we get hemispheric pathologies also. This was a 4-month baby who had a history of jerky movements since birth, several times daily, involving both the upper limbs. There was a paucity of right-sided movements. No milestones were achieved. Sorry, this is an old case, more than 10 years old. As you can see, there's a right hemiparesis, and the left side, there are jerky movements. If you see the video EG, you see that the right side is almost flat, and you're seeing some epileptiform discharges, which are time-locked to the jerks coming from the left hemisphere. So this was a case of hemimegalencephaly. As you can see, there is an enlarged brain on the left side. Gray white matter is poorly differentiated. This patient underwent a hemispherotomy and recovered completely. So coming to the end, I have only chosen clinical cases rather than talk about theory, because I'm sure the august audience will be well aware. So good history is very important. Very often it helps us to narrow down the possibilities, and we can find out which side it is, which lobe is involved, what structures are involved. Home videos are very important because most people have mobile phones and they come with home videos. That helps us to identify the seizure quite well. Aura and semiology will yield clues about lateralization and localization. Electrophysiology, interictal and ictal video EG will confirm the localization. So from the history, video EG, electrophysiology, we can localize quite a bit, and other investigations will help shape the surgery. So this is our neurosciences team. And I'll end with Sir Winston Churchill's words. If it is improbable, it should be done. If it's impossible, it still can be done. Thank you very much for your patience.
Thank you, Dr. Kumar, for finishing in time and giving us 9 excellent cases of semiology of medically refractory epilepsy. It's now open for discussion. Any questions or comments on any of the cases from the audience?
Very good presentation, Sujit, and
Thank
it
you.
was very clear and understanding the various semiology of epilepsy. In our preclinical practice, most often we have the mixed type of seizure. The patient comes with genuine seizure, and they also develop the psychogenic seizure or non-epileptic attack disorder. And that is a challenge really for the patient to doctor to identify and also to plan for further things. How do you do that? That is number one question. Second, just a comment I will make. This is regarding the home video you are talking, and I had some very interesting experience wherein the public videos have become useful now for analysis of epilepsy. You know that every house has got videos now outside for security reasons. Every street has got. So I had cases wherein the public videos were used and they got the clippings from there and then showed us a person who was in a gym and had a video there and brought the videos and showed. Another person, as he was entering the staircase, he fell down from the staircase. The whole event was captured on the video, which was there on the roof. So this is another advantage now. We can ask the people to bring the videos from the surrounding area, like a policeman now using the public videos. We could also use for the epilepsy semiology and understanding of the epilepsy. Thank you. Your
Thank you, sir.
comments on the first.
Yes, sir. Sir, that's a very good. We have also had experience once when a person had a seizure. He brought from the neighboring shop public video wherein he was driving a motorcycle and collapsed there. So the shopkeeper's video showed us clearly what type of seizure he had. Coming to the first question, sir, we have paroxysmal non-epileptic seizures or PNES that we say. Very often they complicate regular seizures also. In fact, recently we did one surgery in a patient in whom we had to undergo psychiatric evaluation because in addition to the habitual seizure, patient was developing some bizarre events which did not have an electrophysiological correlate. Usually history will show this because of the burden they face from the seizures. They sometimes have pseudo seizures or non-epileptic events, just to play the role of a seizure person. So they require a psychiatric evaluation and appropriate treatment. Very often they might be having an affective disorder like depression. Unless that is treated, then truly the quality of life will not improve. And sometimes we get patients who have purely non-epileptic event without any seizures as well. So this is a tough area, sir. I think video EEG is a gold standard for determining which patients have these events, sir.
Thank you. So I think the message is to have a very good multidisciplinary team for all your cases. Not only is the neurologist, but there are other various specialists that also help to advise and assess a patient.
In fact, this combination of non-epileptic and organic seizure is a real issue. I do not know. One video which you have shown where the patient had a pelvic thrusting, I think. I'm sure he had an abnormal EEG, I think. That was mimicking like a non-epileptic seizure. It looked like a non-epileptic seizure. I think he had an abnormal EEG.
Yes, sir. Patient had seizures because we recorded the electrophysiology also. That's the problem with frontal lobe epilepsy. Very often it is diagnosed as non-epileptic event. Especially some patients will have something like distal stereotypy where they may be playing a tabla, and we have seen such patients. They actually have a frontal dysplasia, and that causes gestural and naturalistic automatism sometimes. And sometimes in medial frontal and orbitofrontal epilepsy, there is screaming, shouting, and bizarre and violent movements which look like non-epileptic events. So usually the video EEG helps us to differentiate this.
Sujit,
Yes,
as usual, an excellent talk. I enjoyed seeing all your videos. Hard work has gone into preparing these things. The value of serum prolactin levels soon after seizure, within 30 minutes, if you draw a blood sample and see for serum prolactin, is it being practically used now?
We used to use it earlier, sir. Now we just use video EEG. I mean, that's described in literature and it can be used. Very valid point, sir. Thank you, sir.
Any further questions or comments? If not, we can move on.
Thank you, sir.
Thank you very much, Dr. Sujit. So our next speaker will be Dr. Anand Iyer, who is a pediatric neurologist from Apollo Ahmedabad. And his topic will be pre-surgical evaluation of drug-resistant epilepsy. Dr. Anand has done his CCT from the United Kingdom. Over to you, Anand.
Good morning, everybody, and thank you very much to the organizers for giving me this opportunity. So, this is the overview of my talk. I'm going to discuss about when to refer patients for pre-surgical evaluation, what are the different pathways and investigations, both in terms of first line and second line investigations, and hopefully we'll go through some case studies to keep it interesting, concluding with new concepts emerging in the field of pre-surgical evaluation. So we've looked at this already. Dr. Sujit has elaborated about what is drug-resistant epilepsy. And from a pediatric point of view, any child who has a drug-resistant epilepsy would qualify for evaluation. Be mindful that just referral for a pre-surgical evaluation does not necessarily mean that they'll end up having surgery, but the process is very important to establish what are the types of epilepsies and what is the conclusive diagnosis. Any child who does not have any control within 2 years of treatment, a child who's less than 2 years of age and the etiology is unclear, if they have a unilateral structural abnormality like megalencephaly, hemimegalencephaly, as Dr. Sujit pointed out, if there is no clear electroclinical syndrome that we can identify, and of course in specific genetic structural disorders like Sturge-Weber, tuberous sclerosis complex, these would be ideal candidates to be referred. Now, epilepsy surgery pre-surgical evaluation is a teamwork, and all of these professionals involved play a significant role in making this successful. But most importantly, there is a significant role of a network coordinator so that all the appointments, all the scans, everything is done on time, as well as in Western countries, epilepsy specialist nurses play a very important role in ensuring there is effective communication between the different investigations and the patient. Epilepsy is moved away from zones and lobes to being called now a network disease with default mode networks and hubs and microhubs. But I still feel that this theoretical construct is useful. So the goal of pre-surgical evaluation is to identify what we call as the epileptogenic zone. This might comprise of a lesion and a pacemaker area from where the seizures originate. And then it spreads to an area where it causes the symptoms. For example, insuloapicular symptoms would be where the seizure spread. There is a surrounding area outside, which is called the irritative zone. That's what looks at intrictal spikes, both in the EEG and other investigations like MEG. And then you have a wider area around that, which is called the functional deficit zone, which shows up as hypermetabolism on some of these scans. And what we have to identify is where is this lesion correctly, and what is its relationship to the eloquent cortex that can be mapped through cortical mapping or other non-invasive functional imaging studies. So once the child or a patient is referred into the pathway, realistically, there are 4 initial investigations that happen. So the first is the detailed clinical history, a 3 Tesla MRI, video EEG, and neuropsychology or psychiatry evaluation. And then these children are usually discussed in the epilepsy case conference or epilepsy multidisciplinary team meeting, after which one of these options are available. If all the data is concordant, they would proceed for surgery. If it's discordant, you would go on to have further investigations and possibly invasive EEG, or you might conclude that there is no resectable hypothesis, and then you can consider palliative surgical options or neuromodulation. So the clinical history is the most important part and the onset of the journey. So this is usually an information gathering exercise, and a lot of debate occurs about what is the exact clinical semiology. the onset, progression, what are the current types, and video recording has made this very easy for us to determine as clinicians. More importantly, we also need to know about birth and early developmental milestones, current medications, previous medications, what is the impact of epilepsy on the child and the family, the school, independence, occupation, what are the comorbid disorders? If you have somebody with autism and ADHD, doing a video EEG might be very difficult in such cases. And what are the comorbid disorders, as well as the examinations, so if they have a focal neurological deficit or neurocutaneous markers. All of this is important as the first step of the journey. 3 Tesla MRI has been simplified with the protocols recommended by ILA with the harness protocol and giving emphasis on 3 major sequences. One is the 3-dimensional T1 weighted images looking at anatomy and morphology, 3-dimensional FLAIR looking at signal intensity, and 2-dimensional coronal T2 weighted images looking at hippocampal structure. The lesion is the most important bit. I think we all agree when it comes to pre-surgical evaluation that be it temporal or extratemporal epilepsy, if you have a lesion, the chances of seizure freedom are significantly higher. And as you can see that although there are different pathologies involved, you have the maximum yield by looking at the 3D FLAIR and the T2 weighted images, but the cumulative yield of getting a successful lesional scan increases when you use all these 3 sequences together. Video EEG is an integral part of the pre-surgical evaluation. Usually you would think about using higher sampling rates like 512 Hertz for better resolution, 2 camera views we've seen in Sujit's slides, with infrared capability for nighttime vision, SATS monitoring and audio monitoring. Most of the units would use 10-20 montage with some extra temporal electrodes. EMG is an essential part to record motor activity. And often there is a protocol for medication withdrawal and doing this procedure safely with continuous monitoring and plans for rescue medications. You would think about doing 48 hours minimum, but more for 5 days until you capture 3 to 6 seizures. And formal testing is very important. An example is here, just nasal testing, looking at, tell me your name, do you know where you are, remember the word cat, looking at postnatal testing and seeing if they can recollect these things. Neuropsychology evaluation requires time and a lot of expertise. This is useful to see for hemispheric dominance, working memory, executive functioning, adaptive behavior, and attention. And these are the scales that are used in children. An example is, so in this child, you can see there is a discrepancy between verbal comprehension, visuospatial skills on intellectual functioning. And the same is reflected in the memory testing, where the visual memory is better than the verbal memory. And of course, the Vineland scales look for adaptive behavior. So maladaptive behavior, particularly communication and social domains, are an important factor to assess. So let's look at some examples. This is a very classical example of a 14-year-old right-handed girl who has a very clear temporal seizure. She stares straight ahead. She's not responsive to verbal commands. She has some oral automatisms. And really, when you do the EEG, you can see spikes in the right temporal region. And during the ictal phase, you can see this nice, slow, rhythmic theta arising from the right temporal region, building up in intensity to a recruiting rhythmic pattern, and involving the entire right hemisphere before slowing down and involving only the right temporal region. And you can see a very clear lesion in the right temporal lobe. It's probably a low-grade tumor. The visual memory is weaker than the verbal memory, and she is identified in neuropsychiatric evaluation to be at risk of depression. So that's important to know around surgery. But she's a very good case for right-sided temporal lobe lesion resection. Another case, a 2-year-old right-handed boy has episodes where his eyes deviate to the left. He has epileptic nystagmus. He has slow head deviation to the left. We saw one of these as an adult patient in Dr. Sujit's video as well. He's drooling, he's not responsive, and sometimes he has left hand clenching and left foot stiffening, which are the lateralizing features. And intraictal EEG shows clear rhythmic, sharp and slow waves in the right occipital region. And during a seizure, he has diffuse attenuation with the recruiting rhythm in the parieto-occipital and posterior temporal region on the right that evolves and then gradually slows down. And he has got a clear dysplasia involving the right temporal, parietal, and occipital region. Very difficult to do more detailed assessments at this age, but he seems to be bumping into objects easily. So that might imply that he has some visual dysfunction, and he's a good case for right temporoparietal occipital disconnection. But all cases are not so simple, and many cases might be non-lesional. So this is a girl who has spinning seizures, and we'll look at the seizure semiology in a bit, but she has one seizure every hour, both in the daytime and at nighttime. I don't know if this will play. Let's see. So she knows that it's coming, and she screams out. And there's a complete versive deviation of her head towards the left. Head, body, everything. Imagining having this one every hour. Her EEG showed right frontocentral spikes, and the ictal rhythm was again coming from the right frontocentral region. But she has a normal MRI. So how do we proceed in these cases? Although we think there's an epileptogenic network in the right frontal region, we can't take this forward unless we have more investigations. So when you have discordant data, non-lesional MRI, or dual pathology, we need to take help of these functional imaging studies to decide whether invasive EEG is useful and whether a tailored resection with some amount of intraoperative monitoring might yield results. And in terms of functional imaging, you have interictal PET looking for hypermetabolism, particularly in non-lesional cases. There are advanced PET studies like AMT PET looking in multifocal lesions like tuberous sclerosis. You have ictal and interictal SPECT. So ictal SPECT is where you give a dye immediately after seizure and do a scan, and you can see increased hypermetabolism or hyperperfusion or a hotspot in those cases. And you have a MEG, which shows cluster of spikes around the irritative area of the brain. Functional MRI has virtually replaced more invasive techniques like WADA for lateralizing hemisphere. You can see this is a storytelling lighting up the Wernicke's area and a verb generation lighting up the Broca's area in the brain. So this girl had hypermetabolism in the right frontal region and a cluster of spikes in the right temporal region. So she went in and we did subdural grids. So this is the inferior aspect, this is the anterior aspect, and this is intraoperative MEP mapping, which shows arm and hand area, which has been applied on the surface of the brain so that we can know where it's coming from. And then she has grids placed, subdural grids placed of this. So this is the inverted brain. This red one is this big grid over here. And this is how it looks when you do a CT scan after the implantation. And this is how the whole grid looks like when you see it. So this is this red one is the most important because this is where our hypothesis is. And now during a seizure, you can see a very clear focal onset of epilepsy coming from this area, this red area. And this then spreads to the rest of the brain. So we know that this is the area that is involved. How do we ensure that this is far away from the eloquent cortex? So we do some cortical mapping where we send electrical signals through these wires. And when we send signals through these two electrodes, we could trigger a habitual seizure. But not only that, we could see that the face is over here, the tongue is over there, the hand is over there, and the leg is over here. And we could offer a neat resection. Now, it's very well looking at surface subdural grids, but now we're going into the era where we put EEG into the surface of the brain, and that's called stereo EEG. You can have a three-dimensional view of the EEG in these cases. I won't go into the detail of this case, but this is a left frontotemporal stereo EEG. So this is the entry point from the lateral neocortex, and this is the last point in the mesial neocortex. And you can clearly see, for example, the electrode is entering the superior temporal gyrus and going into the hippocampus, or the electrode is entering the inferior frontal gyrus going into the orbitofrontal gyrus. So you can sample both the lateral and the mesial aspects of the brain well. So this requires a lot of planning, a lot of software, a lot of precision planning. And this is how it looks like when you plan this on the computer. And you use a robotic interface to do precision drilling. I'm sure that will be touched upon in more detail by the neurosurgeons. This is how it looks when it is all connected. And post-connection CT scan can now show you the electrodes very neatly. So you can see these many contacts are in the mesial surface, these many contacts are in the lateral surface. And in this case, we could see a seizure originating on this contact and gradually progressing and gradually ending afterwards. So we could say that the seizure is originating from there, it's going there, there, there. And with functional mapping, we could make out that the legs and hands are located in these areas, and hence we can give a neat resection to enable seizure freedom. So this is what is being done predominantly, but there are so many advances occurring within the field of pre-surgical evaluation, and a lot of these embark on high-density electrode analysis, electrical source imaging, magnetic source imaging, high-frequency oscillations, functional connectivity with diffusion tractor imaging, and a lot of stimulation. So all of these things are occurring in very highly advanced centers to make us sure that we are able to identify the epileptogenic zone accurately. So this is an example of somebody who's had a non-lesional temporal lobe epilepsy. 7 Tesla MRI is now used more and more in Western countries. It's not the first portal of contact. It's mainly used to guide invasive EEG implantation. But in this case, you can see the 7 Tesla MRI showing a small lesion. That is the lesion. The PET shows hypermetabolism. So that is the blue area. When you do a video EEG, the light green is where the seizure onset zone is from. These are cluster of spikes on the MEG and intrathecal EEG. And then when you do invasive EEG recording, you can see the seizure onset is much more accurately starting from this area, so very anterior frontal, whereas the surface EEG showed it was much posterior temporal. And then it is spreading to this area. And you do some functional mapping and you see that this area is also involved. So based on that, you can do a much more tailored resection. So this is the concept of multimodal imaging and information accruing before we can go ahead with surgery. Okay, this is a similar episode like what Dr. Sujit suggested. It's a child with gelastic seizures, waking up from sleep, laughing, and then going back to sleep. And when you see this, you think about a hypothalamic hematoma. And hypothalamic hematomas are, clear-cut surgical cases where you have a combination of seizures, behavioral difficulties that warrant neuropsychology and psychiatry assessment, and endocrine problems which might require endocrine review. But usually the video EEG in hypothalamic hematoma is non-informative. The lesion is so deep-seated that often you don't find anything. And that kind of begs the question that is video EEG a mandatory investigation in all cases where you think about epilepsy surgery? If you have a huge hemispheric lesion, if you have seizures coming from that area, if you have intrathecal spikes from that area, then ictal EEG recording may not be mandatory in all cases, particularly in hypothalamic hematoma, is what I feel. And this is a study in epilepsy research that confirmed that many of these cases with large hemispheric lesions can proceed directly for surgery with good outcome. So in summary, if you have drug-resistant epilepsy or a structural etiology, then epilepsy surgery evaluation is warranted. Clearly, you need a team and multidisciplinary team discussions in order to make the right decision. The clinical history, 3 Tesla MRI, and video EEG in the majority of cases is sufficient to come at a conclusion. You would think about invasive epilepsy monitoring in a selected few cases if you're not able to come to a concordant data with all the information. And I think I want to end with this question that we always have to ask, is there any reason why the lesion should not be resected? Is there any, if it's a hypothalamic hematoma, just because the family cannot afford video EEG or video EEG is expensive, can we not go ahead and resect the lesion if we have all concordant data? So I'll leave you with that last sentence. Thank you very much.
Thank you, Dr. Anand, for a comprehensive talk on pre-surgical evaluation, talking about multimodal imaging, a multidisciplinary team, as well as giving us some recent updates on how to treat hypothalamic hematoma. Any questions or comments from the crowd, from the audience? If you can use the mic, thank you very much.
Dr. Anand, an excellent talk.
Thank
You covered the whole pre-surgical evaluation with the recent advances very well. One practical doubt which I had, which we always come across, is that very often we have lesions which are small, quite close to eloquent areas. Do you suggest, I mean, of course, it has to be individualized in every case. Do you suggest extraoperative, mapping, or intraoperative if the patient is cooperative? And again, the type of surgery, whether lesionectomy or lesioning itself can be done if it's a small. What is your experience?
So you have two school of thoughts here, and I'm coming from a pediatric neurology perspective. If you have a very young child, you're not going to be able to do any form of functional, imaging in these cases. And if there is a lesion, even if you feel that this is the dominant hemisphere, it's very likely that the language or other motor functions may have migrated to the other hemisphere. So in younger children with early onset seizures and a structural lesion, we wouldn't worry too much about doing all this imaging. But if you have an older child with later onset of epilepsy, if it is around the language area, and if you're not able to delineate the margins, or if you feel that this is impinging on areas of speech, then definitely they would need to have invasive monitoring. And language mapping is much better done with subdural grids, or perhaps even the hybrid method, which I think Sir will talk about, because stereo EEG is not the best modality for doing language mapping in these cases.
Yes.
Similar question. If you have a clear-cut lesion,
Yeah.
and if there is a lesion in the brain, and the clinical picture of the seizure is corresponding to the type of lesion, and a simple EEG corroborates with that, do they need any elaborate this investigation?
So the purists and the epilepsy surgery centers would often say that it is always important that we do all these investigations, including the video EEG, and then come to a conclusion. But as I said, that there are cases where if I had a boy who had a huge hemispheric lesion, involving the motor cortex. He had a hemiparesis from start. He had severe autism and ADHD, which were not controlled even with medications. So in those cases, what we did is we did an intrathecal EEG, we did an ambulatory EEG rather than a video telemetry. We got the video recordings, and we were able to prove on the ambulatory EEG taken at home that the seizures were coming from the hemisphere. And then we made a case for hemispherotomy with very good outcomes. Similarly, in hypothalamic hamartoma with significant behavioral issues, if you're confident that the seizures are coming from the lesion, then we can go directly for either resection or laser, whatever is available at the center, without doing all the other investigations.
Any questions? Please use the mic.
Thank you very much, Dr. Iyer. That was a really crisp talk.
Thank you.
You made it quite clear that with sophisticated MR and video EEG and going into the history and semiology carefully, you can, in the majority of cases, find concordance. And that it's only in a few selected cases that you need invasive monitoring. To be able to plan on establishing resources and infrastructure, could you give us an idea as to what percentage of patients actually do require those invasive monitoring methods? And if surgery is then performed, are the results good to really warrant those extensive studies?
So I think, I can't remember the exact percentages, perhaps somebody can help me, but approximately 30% of them would have discordant data, or you wouldn't be happy with the data. So you have a lesion or possible lesion. Remember, sometimes the radiologist would say, we can feel there's a possible lesion, but we can't definitely comment so, and we would correlate. So say for example, it's an anterior temporal lesion, and you have EEG showing posterior temporal or occipital onset seizures. In those cases, if it's discordant, we would then go in for more invasive investigations. And I was talking to Dr. Sujit about this recently, there is a case for having a network of people who are doing this repeatedly and regularly and discussing these difficult cases so that we make the right decision for such children or patients, in which case the success after doing invasive monitoring would be good, would be at least at the rate of 70%. For non-lesional cases, and if you don't have a clear hypothesis or clear evidence from invasive monitoring, the chances of seizure freedom is less. It's about 40 to 50% in frontal lobe epilepsy. So it's always a case-by-case discussion, but I think if I was having a doubt, I would usually go and ask a couple of other neurologists who are doing the same work, whether this hypothesis, the investigations are pointing to the same area of epileptogenic network that I want to remove. I hope that answers that question.
No, you're absolutely right. I think in most large epilepsy centers, you're overwhelmed by the vast majority of patients who have concordance, that the amount of time and energy you spend on these 30% of patients,
Yeah,
I'm probably they should be referred to a few centers.
true.
And in that case, this Apollo conclave that we have probably should try and arrive at such a possibility.
Absolutely. Yeah.
Actually, I came in for that comment only. Thank you for stimulating that question. See, the major problem with epilepsy surgery is extensive investigation, what is required. And as he pointed out, there is a lot of investigations are required and one need to invest a lot of time. It is a labor intensive. So what is required is whether every patient need to go through that is the question. You need to have a phased approach. And a phase has to be done where you need to have an invasive investigation, not required in every case. So you need to plan out your steps. And in a conclave like this, I wanted to bring to that notice only that it is not necessary or it is not possible to have every investigation in every center. So that was the reason I was mentioning to our management that you must have regional-wide certain of the facilities available. And these facilities should be used as a common facility. And then we can have it. As it is already, for example, MEG, it is an expensive investigation. It cannot be have everywhere. So we are all using, I'm sure Sujit is using and Ravi Mohan Rao is using, we are all using from NIMHANS. So we send them patients and get it from the south. Similarly, in the north, Delhi has got. So only 2 are there in the whole country. And in NIMHANS, we have an MRI with EEG facility. So that can be used. In the gantry, we can have an EEG. Such facility is available. So the idea behind it should be a networking, and we must have a common pool of investigatory facilities. If not one in the country, it can be 2 or 4 region-wide. That would help. I think we need to work from that angle. That is my comment. For that only I was standing. Thank you.
Now, one simple question. What is the average cost of all this investigation? What would be the cost?
So if you think about just the 3 Tesla MRI and video EEG for 48 hours, it will be probably around 50,000, I would think, 50K. Just the basic cost of investigations, the basic investigations would be around 50K. Yeah.
Dr. Mishra.
Okay. Thank you very much for a very, very nice talk. But I just want to take an opportunity to say that, so much of expertise and so much of highly evolved techniques are available. But, they are restricting. I mean, large number of patients are referred to 1 or 2 centers and they are doing. But what is more important is that this expertise should be utilized to extend the skill and knowledge to a larger number of people. And I wonder if it is a right forum to say or not that to have a fellowship programs, to have a training program and make it dispersed to wider areas. Not the highly technical and highly complicated things, but a lower level of expertise people can be trained and they can take the matter outside. Because, large patient burden is there, they're not available, and the medical colleges and large number of people coming up without infrastructure, that's a real problem. So I think, we'll have to think that, although we want to develop and develop our technology and expertise to a higher level, but maybe we can expand laterally also. and include larger number of people so that the benefit could spread. Thank you very much.
Thank you. So I just want to make that one comment. Thank you. That's very appropriate. One of the things I'm sure tertiary quaternary, epilepsy centers face is that if these investigations like PET and other things are done already by other centers, when they come to see us in the clinic, we often find that the reporting might not be consistent or they may not be accurate, and you may not rely on the report. For example, if I do a video EEG and send it to Sujit might say, well, you didn't do this. I want to do this again. So, it's always beneficial to have a group of centers, few centers who build the expertise repeatedly, but the information should be disseminated to a wider audience and, so that they can refer patients appropriately. Thank you.
Thank you for stimulating discussion. We move on to our fourth speaker and the final speaker for this session, Dr. Ravi Mohan Rao, neurologist from Bangalore and part of the organizing team, and he will be speaking on overview of epilepsy surgery. Over to Dr. Ravi.
Thank you, Chairperson, sir. I again extend a very warm welcome to all the delegates for the Apollo Neuro Conclave. This is our neurosciences team, which includes neurologists, neurosurgeons, neuroradiologists, neuroelectrophysiologists, etc., which is there in Apollo Hospital, Seshadripuram, which works up these epilepsy patients. This is our experience in the corporate sector. We have operated from 2010. That is the year when I left Sri Chitra to come to Bangalore to work in the corporate sector. We have done 465 patients, out of which 229 are pediatric patients and 236 are adult patients. We have this number of 195 temporal lobe surgeries, extratemporal 270, hemispherotomies 42, motor sparing subtotal hemispherotomy 9, frontal lobe 77, posterior quadrant 49, collosotomies in 16, stereo EEG in 25 patients. So Ari Chako had asked a question about how do these investigations work out when you don't get concordance with because of either MRI negativity or bilateral lesions present. What we usually follow in our unit, which includes Dr. Dinesh Naik, is we have a very strong clinical hypothesis which correlates with EEG. So even if MRI is negative or bilateral lesions are there, when we have to do invasive, we are guided by this hypothesis, which invariably confirms the diagnosis. Out of 25, I think we have not been able to come to a conclusion in only one patient who underwent a stereo EEG. We had operated on 5 patients of hypothalamic hamartoma. The classification of epilepsy surgery can be with a curative intent or a palliative intent. Curative intent is you remove the lesion from the connections with the rest of the brain, which can be small, like a lesionectomy, larger lobectomy, multilobar resections, posterior quadrantotomy, and hemispherotomy. We do more of disconnections than resections nowadays. With palliative intent is total corpus callosotomy. If time permits, I'll just dwell on this towards the end of my lecture. Multiple subpial transections, VNS, responsive neurostimulation, DBS, and nowadays we have MRI-guided lesion, laser ablation, and radiosurgery. I've left out RF lesions, which I'll show in a few examples. So starting with the temporal lobe, 29-year-old male with CPS left temporal, you see gross atrophy of the hippocampus. But the lateral neocortex is normal. This is a rare situation. In MTS, we usually have neocortical polar involvement too. And the PET scan shows a considerable hypermetabolism of the mesial temporal lobe. The lateral temporal lobe is normal. This patient underwent a selective subtemporal approach and selective amygdalohippocampectomy in 2011. This is the post-op CT scan showing selective removal of the amygdala and the hippocampus. This patient is a high-functioning individual engineer. For 6 months, he had severe anomia. He couldn't name his colleagues, but then he came out of this. He's gainfully employed and Engel class 1A outcome without any drugs. In contrast to this, the second patient is a 13-year-old girl who had risk factors of febrile seizures, typical temporal lobe epilepsy with no secondary generalization. And the MRI scan showed the gross shrinkage. In the flare, you see this hippocampal gliosis, sclerosis with the involvement of the lateral cortex too. ECOG showed the spiking. We do ECOG-guided resections of the temporal lobe and generally use it in all our surgeries except hemispherotomy. And hippocampal spikes. Post-resection, some residual spikes were present, which disappeared after extending the resection, and this is the post-op scan. This is the more common type of temporal lobe surgery we do, where we do an anterior temporal lobectomy and amygdalohippocampectomy. This patient has 13 years follow-up, is not on medication, seizure-free, and working in a bank. Now coming to temporal plus epilepsy. The problem with this is this mimics temporal lobe epilepsy, and if the red flags are not picked up, it leads to failure of temporal lobe surgery. These regions could include the frontal opercula, the subfrontal olfactory, orbitofrontal cortex, the insula, which can all mimic temporal lobe epilepsy to some extent. And these red flags are not picked up during the evaluation. It can lead to failure of temporal lobe surgery. This patient had red flags, no early insults, unprovoked seizures in stage 3, predominantly nocturnal and in clusters. But this patient had features of temporal lobe epilepsy with one additional thing of being very restless during the seizure. The scan looked normal. This is the EEG, which shows the spikes in the entire temporal chain. And this is the ictal VEG with the left temporal and parasagittal chain being involved. This is the seizure semiology. She starts rolling around in bed, is restless. This is unlike the behavioral arrest you see in normal temporal lobe epilepsy. So I'll proceed forward. So the odd points were no febrile seizures, early age of onset of unprovoked seizures, predominantly nocturnal clustering, initial hypermotor, then hypomotor, MRI, no significant changes. Ictal EEG showed more widespread changes. The PET scan showed the temporal hypometabolism and olfactory, the orbitofrontal cortex hypometabolism. Underwent intracranial grid and the strip monitoring, which included orbitofrontal subtemporal electrodes and a grid over the temporal lobe. And this showed the seizure onset from the orbitofrontal cortex and going and settling in the temporal lobe. Whenever we do invasive, we do stimulation studies for one, eliciting the seizure at very low amplitudes, 1 milliampere currents, and also to do functional brain mapping. So the aura was elicited, this elicited aphasia. So the results of the invasive monitoring was the seizure started in the orbitofrontal cortex and ended up in the temporal lobe. So this patient underwent a temporal lobectomy with resection of the orbitofrontal cortex simultaneously. Nearly 12 years of follow-up, no seizures, off AEDs, got back the job, and she is leading a successful life. Now coming to insular epilepsy, another form of temporal plus. You can have pure insular epilepsy or it can be combined with temporal lobe epilepsy. 17 years old patient had underwent antetemporal lobectomy and amygdalohippocampectomy in Delhi. Sensory symptoms in the body, left half of the body, which is not a march, followed by immediately excessive salivation lasting for 30 seconds. This was there initially, as Sujit showed, excessive salivation which occurs in the beginning of a temporal lobe epilepsy or choking which occurs in the beginning of a temporal lobe semiology is suggestive of insular seizures, which was ignored at that time. It can also spread to the operculum with perioral jerking and left upper limb jerking. So these are T4 spikes which are seen. And this is the semiology of the patient. Is getting salivation, some sort of choking. And goes to the perioral region, which is the frontal operculum, and involves the upper limb. So the progression of the seizures is very clear in this case. So this is the post-op MRI after the first surgery, which shows insular hyperintensity and also a nubbin of the superior temporal gyrus, which is left behind on the right side. And the PET scan shows insular hypermetabolism with a hypermetabolism in the left behind the superior temporal gyrus. And this patient underwent a completion of the temporal lobectomy, the resection of the STG, and the total insulectomy, which was done at the same time. And 28 months follow-up, minor hand sensations. Many of the insular surgeries, they develop temporary upper limb, lower limb weakness, which improves over a course of time, lasting from weeks, days to weeks. The pathology came as Rasmussen's. He's on immunotherapy. His hand function is very good. This is the report from Nemans, which confirmed Rasmussen's. Now, coming to frontal lobe epilepsy, there's a Bonini, who did extensive, Bonini and co, who did extensive stereology, classified frontal lobe epilepsy into 4 types. Group 1 is precentral. Group 2 is more posterior with proximal stereotypy. Group 3 is more anterior with integrated stereotypy and hyperkinetic seizures in the orbitofrontal region. 2-year-old female child with focal seizures and epilepsia partialis continua in the right leg and hand with mild hemiparesis, large dysplasia in front of the motor cortex, underwent resection of the dysplasia, preserving the motor cortex. This is the post-op scan. Nearly 14 years, no seizures. Histopathology is dysplasia. This and this is 14 years after surgery, doing well, no seizures, off drugs. The next is a 17-year-old boy with no antecedents. Perinatal and developmental history is normal. Seizure occurrence since 13 years. I'll better show the seizure than describe it. This is the seizure which was passed off as pseudo seizures. This is integrated stereotypies. So he has this integrated stereotypy followed by, at the end, he starts smiling and feeling happy. So there is a gelastic component too. Both of these are components of frontopolar epilepsy. So for a long time, this was passed off as pseudo seizures. And the characteristic spikes, which you see with the focal cortical dysplasia and the electrode decrement response, low voltage fast activity, and MRI, lo and behold, showed this dysplasia in the depth of sulcus with a tail extending towards the ventricle. And the PET showed more extensive. This showed a network rather than the dysplasia alone. And depth electrode recording during surgery, which showed the spikes. And post-resection, after resecting in the depth of sulcus, you have to go on both sides of the sulcus and resect the dysplasia. Nowadays, we don't do such extensive resection. We go along the sulcus, which I'll show in another case, and remove the dysplasia on both sides of the sulcus. This is the post-op MRI scan, pre-op, post-op. And the patient is seizure-free, 7 years follow-up, doing very well, completed studies. So coming to few examples of stereo EEG, this is a 16-year-old girl, habitual seizure since 3 years of age, single stereotype seizures, 7 to 8 seizures per day affecting schooling and studies, vibration sense in right arm, stiffening of both upper limbs. So this is the only type of seizures she gets. And then the seizure is over quickly, brief seizure. So this is the ictal VEG, which shows this spiking, ictal onset, and again, a middle frontal gyrus depth sulcus dysplasia, which is seen very clearly here. And the PET scan showing the hypometabolism. The problem here is fMRI showed a function at the mouth of the sulcus, entry point of the sulcus. Underwent a stereo EEG, want to do brain mapping. You can do brain mapping with stereo EEG, and also to confirm that the seizures are coming from there. This is the stereo EEG map. We proved that say spontaneous seizure onset and stimulated seizure onset are the same. Speech mapping, and she underwent awake craniotomy and excision of the lesion. So these are the speech maps, and this is the inferior border. I is the inferior border of the lesion, which is just above the frontal speech area. And this is the resection preserving the speech cortex in the frontal lobe, resection, the pre-op, post-op. So more than 7 years follow-up, angle 1 of drugs, completely seizure-free. She had transient dysphagia, speech apraxia post-op, which persisted for 2 to 3 months, but led to complete recovery. Now we are doing more and more language FCD surgeries, and we see that dysphasias can occur, but they invariably recover. And denying surgery to these patients who are highly incapacitated because of the high seizure burden is not good. So posterior language area, we saw the anterior language area, posterior language area. Episodes consist in an 11-year-old female child patient holding the right ear, whether due to sensory phenomena or due to pain or tinnitus, not very clear. Appears frightened, crying out, calling for patients, remains responsive during seizures. So these were all the areas which we thought could be responsible for these are clinical hypothesis, and in stereo EEG, we sample all those areas. This is the spontaneous event. She holds her ear, indicates that something is happening there. And then we saw this dysplasia at the posterior end of the sylvian fissure. You see this dysplasia. This is the posterior end of the sylvian fissure in the parietal lobe, and then in the temporal lobe, this is the superior temporal gyrus. So this is very near the language area, posterior language area. Stereo EEG was done because this was not initially picked up in our own center. We had passed off the MRI as normal and did the stereo EEG. Fortunately, the stereo EEG, because we work on a network hypothesis, the stereo EEG sampled the dysplasia. And then this is during surgery. This is the parietal lobe. This is the temporal lobe. So this is the posterior end of the sylvian fissure. Go along the bank of the sylvian fissure to remove the lesion, and then go along the bank of the temporal lobe to remove the lesion. This is at the end of the surgery. And this is the MRI of the surgery showing resection of the dysplasia completely, both the upper bank and the lower bank. And the post-op, she is doing very well. Very high seizure burden. So her language is intact, preserved, though we operated on the language area. So hemispherotomy is where the entire hemisphere is disconnected. Sujit already showed this patient, hemimegalencephaly. PET scan, if the seizure burden is high, you see this ring of fire in the PET scan, which is an ictal PET rather than an interictal PET. This is the post-op CT, which shows that the hemisphere is disconnected from the brainstem and the thalamus. And this patient is from Iraq, has hemiparesis, but child is showing development and has no seizure burden and is off drugs. So this is the idea of doing hemispheric surgeries, that patients, the normal brain is allowed to function well and some cognitive development occurs. And these are all hemispherotomy patients. So motor preserving subtotal hemispherotomy, 14-year-old boy, extratemporal right hemispheric seizures. You see that except for the motor cortex and sensory strip, the whole of the hemisphere is gliotic. And motor cortex stimulation during surgery. And this is the motor sensory strip left attached to the brainstem, which results in preserved hand function. This patient was psychotic before surgery, significantly improved in quality of life, not on antipsychotics, only on lacosamide, Engel outcome scale 1. So a significant improvement in his life after the surgery. Posterior quadrant, one example, 23 years old male who presented with this atrophy of the posterior quadrant. Hemianopia is seen. The visual fMRI shows normal vision in the right occipital lobe, nothing in the left. And motor fMRI function is preserved on the side, and language has shifted to the right side. It's on the right side. And this patient underwent a posterior quadrantic resection, disconnecting the temporal parieto-occipital lobe from the rest of the hemisphere. And this is the post-op CT showing the disconnection. Hypothalamic hamartoma. This is a hypothalamic within a 13-year-old child. Just a few more minutes, sir. Gelastic epilepsy, hypothalamic hamartoma. Multiple falls which caused these repeated head injuries. I used a contralateral lamina terminalis approach to approach the hypothalamic hamartoma. This is the hamartoma which is seen. Depth electrode recording from the hamartoma. The post-op scan showing the resection of the hypothalamic hamartoma. And the patient did very well after surgery. Multiple seizures per day, no seizures after surgery and during follow-up. Now, I had a case which had undergone radiosurgery in Mumbai. I operated on him twice. Both the times the surgery failed. What next? So this is the hypothalamic hamartoma, which is seen here. After the first surgery, which is a translamina terminalis approach, some residual lesion post-op, which I couldn't see from the lamina terminalis approach. So choosing a lamina terminalis approach is important because the lesion has to be anterior. It should not be extending posteriorly to see it from the lamina terminalis approach. Second, transcallosal interfornicial approach operated. Again, during surgery, I had trouble differentiating the normal from the posterior hypothalamus from the dysplasia. Hence, again, a little bit of tissue get left behind. And patient had recurrence of seizures after a few months. So subsequently, I called the patient for an RF lesioning. So the residual hypothalamic hamartoma was treated with RF lesioning. So this is a patient who had a gamma knife before surgery, 2 surgical approaches, and the last one is an RF lesioning. Whether this is the end of the story, we have to wait and watch. And because of steroids, he had avascular necrosis of the femoral head. But patient is doing well. Otherwise, he has psychosis because of the hypothalamic hamartoma, which has slowly improved. Sensory cortex seizures. I will cut this short. Underwent a stereo EEG because MRI was basically normal. So from the leg and posterior SMA seizures which go through these areas, we place it orthogonally, entering from the lateral surface, going up to the medial surface, which showed that it was coming from the hand sensory area. And we did an RF lesion, a small lesion. So that is the advantage of doing stereology. If you want to do sublobar surgery, if you want to do limited surgery, you should need more proof. Whereas a lobectomy is much more easier to do, and so also advanced surgeries. Motor cortex, again, I'll cut this. This patient had SMA type of seizures. So we do a lot of eloquent cortex surgeries nowadays, which includes motor, sensory cortex, language areas. So this figure of 4. This is called the Statue of Liberty signed by Dinesh Naik. Patient underwent a MRI scan, which was reported as normal in Chennai, in Nimans. PET scan didn't localize properly. Patient had PET MR fusion at Nimans, which again said no discrete lesion. And the MEG localized it to the opposite hemisphere. But there is a depth of sulcus dysplasia. This is the motor cortex. You see the depth of sulcus dysplasia in front of the motor cortex. Underwent a stereo EEG to prove that the seizures are coming from there. This is the habitual seizure during stereo EEG. And this is the activity recorded from the electrode. This is the stimulated seizure. I'll cut this short. And the post-op MRI showing a resection of the lesion. I was very cautious in the first attempt and spared the motor cortex. You see that little bit of dysplasia is left behind. After 6 months, patient was seizure-free for 6 months, recurrence of seizures after 6 months. And that is because of the anterior bank of the sulcus, which is the motor cortex. We read this paper which says I'm finished almost, which showed that the corticospinal neurons, pyramidal neurons are in the posterior bank rather than in the anterior bank. We took advantage of this to do the second surgery and resected the anterior bank of the motor cortex. So this is the MRI after the second surgery. Initially, he had hyponatremia-induced seizure. He had mild hand weakness, which improved completely. And this video is not playing. This Sujit has already shown tongue area FCD. And so this required more extensive resection of the motor homunculus below the hand area. Resecting the face area, tongue area does not cause a permanent, including Broca's area, does not cause a permanent neurological deficit. And we do that quite frequently when we do opercular seizures. This is the post-op showing the resection of the motor cortex below the hand area. And the patient is doing well after surgery, seizure-free. I just want to finish with this colosotomy. You have patients suffering LGS syndrome. This patient cracked her head on the glass due to a drop attack. This patient had end injuries. After colosotomy, we see complete elimination of drop attacks. And we see no major cognitive deficit. Unlike in the Western countries, they say they prefer VNS more than doing colosotomy. We think colosotomy is a poor man's VNS, and it's far superior to VNS in controlling seizures and also in the final outcome. So these are the outcomes ranging from 66%. In gliosis, the outcome is slightly poorer, hemispheric gliosis, and it's very good in temporal lobe. So investigation based on clinical hypothesis is rewarding. Investigations can be misleading sometimes. So the importance of clinical hypothesis cannot be overemphasized. We also need to relook at difficult cases because there may be cases of surgical failures, but when they are properly addressed, you can help them further. Teamwork is most essential. And when we use stereo EEG, we use a hypothesis which is based firmly on the clinical semiology and the electrophysiology. Thank you very much.
Thank you, Dr. Ravi, for showing a plethora of surgical cases from your team. We have time for just one question or comment. Anybody want to make a question or comment? Yes, please, sir.
Sir, just wanted you to clarify to us, in which cases would you like to use radio frequency lesioning? Going to the time, you couldn't cover that.
No, radio frequency lesioning can be used when we are very sure of the ictal onset zone. So ictal onset zone is defined by stereology. It's the French concept. Whereas the American concept, it's retrospective. You determine how much cortex you remove. Based on seizure freedom, you say this was the amount of cortex required to be removed for seizure freedom. Whereas the French with the stereology, they have shown that prospectively you can show what is the amount of brain which needs to be disconnected or removed. And when this area is small, like a hypothalamic hamartoma or specific concepts in the motor cortex, sensory cortex, or in the language area, you can use RF lesioning or HIFU, high frequency ultrasound guidance. That's horrendously expensive, so I don't know whether it will be applicable in India. Similarly, laser guided application can be done, but each optical fiber at present costs $1 lakh US. So again, it's very expensive. So RF is a good option for our country.
Yes, sir.
Is a comment, Dr. Ravi, as usual, an excellent presentation and lucid interval. Carrying forward the discussion we had about centers of excellence during within Apollo. We have here a man, Dr. Ravi, who has got extensive experience in southern region, at least in the private sector of doing epilepsy surgery. Is something we should look at, to organize and coordinate between the regional Apollos to enhance the experience and better outcomes, to identify centers rather than all of us trying to do everything. Thank you, Dr. Ravi, and just taking it
Thank you.
forward.
Thank you. Final comments on the session from Dr. Dhanraj, and then we hand you over to the organizers.
I think altogether it is well done, I think. In fact, the first, I think she spoke about how to choose these anti-epileptic drugs. Subsequently, I think they spoke about what are the pre-surgical evaluation, surgical impact. I think it is a very thought-provoking. All of us are here are very much benefited. I think as it has been suggested, I think it is better you should have a small teamwork among the centers, the nearby centers. I think the patients will be enormously benefited.
Thank you, sir.
Thank you, organizers and all the speakers for concluding the first session. May I request all the chairpersons and speakers to join us for a group photo session, please. And there is a slight change in the scientific program. Dr. Vineet Suri had to leave a little early for some emergency. So we are, tomorrow morning, he was supposed to talk in the stroke session. So we are preponing the talk. So the coffee will be served in the room. So may I request all the chairpersons and organizers to come on the stage for a group photo with Dr. Satish Chandra. Yeah, please. To chair Dr. Vineet Suri's talk, I request Dr. Satish Chandra and Dr. K.N. Krishna to, come forward and chair the session. May I request Dr. Satish Chandra and Dr. K.N. Krishna to chair the session. And may I request Dr. Vineet Suri to speak on intravenous thrombolysis in acute stroke, indications revisited.
Oh, good morning. I'm Dr. Satish Chandra here, along with K. N. Krishna, chairing this session, which is very important, unfortunately, because of some acute emergencies which he cannot avoid. Dr. Vineet Suri has to fly back to Delhi. And because of that, we have to prepone, though we know that it is not in the middle of the session. So we will be having his session. He has come all the way from Delhi. And Vineet Suri doesn't need any introduction. Can you please put it on? Can you put on his?
Thank you, sir, and sorry for creating this little trouble. Actually, I have to just fly back because of some
Yeah,
emergency.
he's a senior consultant neurologist and in Indraprastha Apollo Hospital from 1995 onwards. And he was the previous consultant neurologist at Moolchand Gayatri Ram Hospital. And in several papers, he has worked on extensively on the area of stroke. And I think he's the right person to speak on acute IV thrombolysis, which is a very important topic in the area of stroke. Over to Vineet Suri.
So I think this is a very, very important and practical talk because I'm just going to talk on all the problems and dilemmas that neurologists face when they are doing thrombolysis. As we all know that thrombolytic agents, they break the plasminogen into plasmin, active plasmin, and the active plasmin then breaks the fibrin clots and it saves the penumbra into a normal tissue rather than going into an infarct. The penumbra is actually seen by a Tmax. If you look at CBF, if you look at advanced imaging, the cerebral blood flow of less than 30% of the contralateral side is what is the core. Or if you look at a diffusion image, then ADC less than 620 is the core. So this is how we look at the core of the infarct. And a Tmax more than 6 seconds is what is actually the penumbra. So the aim of thrombolytic therapy is to try to convert the penumbra into normal tissue and save it from going into the infarct. Less than 4.5 hours, we assume that the penumbra is there. Up between 4.5 to 9 hours, we have to prove that the penumbra is there. So we need advanced imaging as of now, but that's all going to change over a period of time. And I think, like Dennis Mercier says that flying a kite is not what it used to be. It's a drone world out there. There's so much is changing. Technology is changing. And I think thrombolysis, the world of thrombolysis is changing so rapidly. Every 3 months, there is a new advancement. And it's really difficult to keep, track of what all is changing. So basically, there are clear-cut blacks where there are contraindications, where you would not like to thrombolyze because you're going to lead into complications. There are clear-cut whites, which means here it is indicated, and missing out on a thrombolysis here is not what a neurologist would want to do. But there are a lot of beyond guidelines, gray zones, and dilemmas. And that's what I'm going to talk. This is the crux of my talk here. So some case vignettes that we would all face. If we have a right MC infarct at 2 hours, aspect 1 and NIHS 25, how many would like to thrombolyze this patient? Huge infarct, aspect only 1, NIHS 25, right MCA 2 hours. Any show of hands? How many would thrombolyze him? So I see a few people, daring people who would like to thrombolyze. So we'll see whether that's right or not. Elderly 88, we know now, up to 4.5 hours, no issue. But based on CT perfusion, extent criteria, if it's 4.5 to 9 hours, is it safe to do above 80? Any thoughts on that? Would you do a 88-year-old with CT perfusion data? So we'll see that. Now we have a pregnant 2-month lady who is 3 hours into stroke or 6 hours into stroke where you need advanced imaging. So can you do a pregnant patient with advanced imaging and thrombolyzer? Is it safe? So we'll look into that literature as well. Then a lot of new procedures have come in. Cardiologists now are replacing valves by TAVI, pacemakers, and even if it is a 30-minute post-angiogram, would you be able to thrombolize a patient who has 30 minutes post PTCA? Minor stroke, if it is not disabling, if it is non-disabling, if there is should we do mechanical thrombectomy directly if there's a large vessel occlusion? Should we do bridging? And if you are going to do bridging, should you choose tenecteplase or alteplase? So that's all we are going to look into these aspects. So looking at indications and contraindications, we all look at the guidelines. It's the 2019 AHA guidelines and the 2021 ESO guidelines. The one indication where it is very clear that you will thrombolize these patients is anybody within 3 hours. This says severity, any severity, even severe strokes you can thrombolize. If the blood glucose is more than 50, you can thrombolize. If the CT shows only early ischemic changes, and end-stage renal disease also has a class 1 indication of going. So if you have a patient, CKD, who has just received dialysis, you can thrombolize this patient. Now coming to contraindications, you have class 3 where there is no benefit, or you have a class 3 where you can harm patients. So these are the time from onset. If the time is unclear or more than 4.5 hours, that was a contraindication, but that's now changing. If you have a CT scan which has subarachnoid hemorrhage or an ICH, obviously that's a contraindication. If you have a stroke within 3 months, so there's a past stroke in the last 3 months, that's a contraindication. But the ESO guidelines have tweaked that. They say that if the stroke is more than a month old, if the patient has had a significant recovery and the stroke was not major, even up to beyond 1 month to 3 months also you can thrombolize. So that's the little change that's happened. Rather than waiting 3 months from an old stroke, 1 month, minor stroke, fair recovery. Head trauma less than 3 months remains a contraindication. Any intracranial or intraspinal surgery remains a contraindication. If there is a history of intracranial hemorrhage any time in the past, so patient has had a 10-year-old basal ganglionic bleed, AHA guidelines still suggest that it's a contraindication. But the ESO guidelines have said that if the bleed is remote and the patient has been treated for the cause, which means there is no underlying AVM, no aneurysm, that has been treated, you can thrombolize the patient. This should not be a contraindication. If there is an intracranial neoplasm, if you have a glioma, or if you have, then it is a contraindication. Extraaxial, like meningiomas, are not contraindications. Then coagulopathy, if the platelet count is less than 1 lakh, the prothrombin time is more than 1.7, or APTT is more than 40 seconds, one will not be able to thrombolize. If the patient is on thrombin factors, if the patient has taken the drug, the DOAC, in the last 48 hours, if the anti-factor 10A level is less than 0.5 or the thrombin time is less than 0.6, then you can thrombolize. Otherwise, it would be a contraindication, but that's also tweaking. I'll show that. Infective endocarditis, if there is evidence of infective endocarditis, it's a contraindication. And if the patient has had aortic arch dissection, that remains a contraindication. If the patient has a GI malignancy or a GI bleed in the last 21 days, that again is a contraindication. Now coming to additional recommendations where you have to apply your mind, the neurologist has to weigh the risks and benefits, look at the severity of stroke, look at what would happen if the patient is not given thrombolysis, and then take a decision. And this is where I think the maturity of the neurologist or the stroke neurologist comes in to decide whether they are going to thrombolize these patients or not. And this is where this is really a gray zone. So you have some 2A indications where it's a moderate benefit, and you have some 2B where there's a weak benefit, and measure that evidence and then look into what has to be done. So the exclusion criteria for 3 to 4.5 hours from the ECAS-3 trial were age above 80, history of diabetes with previous stroke, any oral anticoagulation usage, whether the INR is less than 1.7, but oral anticoagulation was a contraindication, and NHS more than 25. These were 4 contraindications from the ECAS-3 trial, and the AHA guidelines have also negated them, that you can thrombolize all of these patients, including NHS above 25. And so also the ESO guidelines have suggested that these up to 4.5 hours, these 4 do not remain a contraindication now. If the patient has dementia, if the patient has reasonable life expectancy, one can go ahead and thrombolize. If the patient has more than 10 microbleeds, that remains a contraindication. An unruptured aneurysm less than 10 millimeter by AHA guidelines was reasonable. ESO guidelines has removed the size of the aneurysm. So any aneurysm, any size, unruptured, you can go ahead and thrombolize. AVMs, however, are not included into the thrombolysis range. So if a patient has an unruptured AV malformation, that remains a contraindication for thrombolysis. Dissection, if there's an aortic arch or an extracranial dissection, it's a contraindication. But extracranial cervical dissection is not a contraindication. And like I said, extraaxial neoplasms, meningiomas, and pineal tumors or pituitary adenomas are not contraindications. Acute MI, use the stroke dose of IVTP and go ahead with a coronary PTCA. Recent infarct in the recent MI in the last 3 months was a contraindication, but ESO guidelines have said if the infarct was non-STEMI or is not anterior wall, if it's a lateral wall and inferior wall, you can thrombolize after 1 month. Post-procedure stroke, post-CAG, post-PTCA, there is a 2A indication. So if the patient, you get a call from the cath lab, we were doing an angio, the patient has had a stroke, and you can thrombolize if the PTT is meeting the criteria. So if the patient has received anticoagulation, but his coagulation parameters are fitting, even within 10 minutes, even though there is an arterial sheath and an arterial puncture, there is evidence to thrombolize these patients. Then patients who have had a diabetic hemorrhagic retinopathy with vitreous hemorrhages, because worse to worse, the patient will lose the eye. But whether you have to weigh the risk, whether the patient limb is, whether the stroke is more severe. And so even if you have to sacrifice the eye, if the stroke is severe, then you may go ahead and thrombolize. And recent trauma, recent surgery in the last 14 days, that continues to remain as a contraindication. Then the indication, the time window has changed. And I'll show what all time window has changed. So the wake-up trial actually showed that if the patient is diffusion negative and the amount of core is less than 1/3 of the MCA, you can go ahead and thrombolize them if they are flare negative. So any patient who is flare negative, when I say negative, meaning complete negativity, there should be no flare positivity at all. And the amount of infarct is less than 1/3 of the MCA, one can go ahead and thrombolize these patients, irrespective of whatever time they have woken up. Now, the EXTEND trial actually brought this forward, and they said that patients who, this is based on now demonstrating that there is a penumbra. So this is by advanced imaging, where you need a CT perfusion or an MR perfusion. If the infarct core is less than 70 ml, the perfusion to infarct core mismatch is more than 1.2, and the absolute penumbra is more than 10 ml, then you can thrombolize these patients even 9 hours from midpoint of sleep. So if the patient slept at 10 o'clock, woke up at 6, the midpoint of that, 9 hours from there also you can go ahead and thrombolize. The ICAS-4, which used a core of 100 ml, was actually a negative trial. So this is the criteria that is used. And a new trial, so basically, how would you do on CT perfusion? How would you look at the core? The core is cerebral blood flow less than 30%. And the diffusion, if the ADC is less than 620, that area is the core. And for penumbra, any area where the Tmax is more than 6 seconds is what the imaging will tell you. So basically, you need a CT perfusion, MR perfusion to tell you CBF and Tmax, and you can identify the core and penumbra, look at the criteria, and even 9 hours beyond the midpoint of sleep, you can go ahead and thrombolize. So like I said, can you thrombolize an 88-year-old in this window? Actually, in the EXTEND trial, there was no age, no higher age criteria. It was anything above 18 years. So you can thrombolize even elderly gentlemen at 88 in this window, and you can go ahead and thrombolize these patients. The only little catch here is that there was a meta-analysis which showed that if you do not use rapid software or you do not use software to identify the core and penumbra, and you're only eyeballing it, by the radiologist is eyeballing it and they're not accurately measuring, then the benefit may be little. So that is the little rider there. And there is a new trial now, HOPE trial, which is coming up, same criteria of EXTEND, that is the core is less than 70, penumbra more than 10, mismatch more than 12, and they are using a window of 24 hours. So they are trying to see whether based on penumbra, because the endovascular therapy has now been extended on dawn and diffuse criteria to 24. That means 24 hours. That means the penumbra does exist till then. So whether the IV thrombolysis will also be affected, I think this is what we have to wait and see. But maybe the window may increase to beyond 20 to up to 24 hours. Then severe stroke, like we discussed. So what is severe stroke? Severe stroke is clinically when the NIHS is more than 25, or the area involved is more than 1/3 of the MCA, or the aspect is less than 7. Now, the rider here is the product insert for actylysis in this group of patients, it is a contraindication. So that's the product insert saying that do not thrombolyze patients above NIHS 25. But then the SITS registry showed that there were more than 868 patients with NIHS 25. And they found that there was no increase in bleeding. These patients do poorly. Their mortality is high. Their functional outcome is poor. But there was no increased risk of intracranial hemorrhage when these patients above NIHS 25 were thrombolized. And therefore, both the AHA guidelines and the ESO guideline now suggest that if these patients are not going in for a mechanical thrombectomy, IV thrombolysis can be done even in severe patients, NIHS above 25. Take care about other contraindications. So if there are multiple contraindications, large stroke, do not thrombolyze, but take a proper decision at that time. It's not a no-no for 25 and above NIHS. You take a proper decision if these patients are not candidates for mechanical thrombectomy. Now, what do you do on minor stroke? Minor stroke has been defined as where the NIHS is less than 5. If the NIHS is less than 5, and that has been divided further into disabling and non-disabling. Disabling is where even though NIHS is less than 5, but so it may be aphasia. Aphasia would get an NIHS score of only 3, but it is disabling. So whether if the disability is such that it prevents the patient from performing basic activities of daily living, that is disabling stroke. And if patients can continue with daily activities, it is called as non-disabling stroke. So there is data from the PRISMS trial and from the ARAMIS trial. Both suggested that for minor stroke, NIHS less than 7, antiplatelet is as good as IV TPA. So the guidelines now suggest that for minor stroke, NIHS less than 5, if it is non-disabling, do not thrombolyze. If it is disabling, thrombolyze. The major issue is somebody presents with a little bit of facial weakness, but you do a CT angio and there is a M1 occlusion. So what do you do on a M1 occlusion, minor, non-disabling stroke? So the ESO guidelines have given the go-ahead and said that if you have even minor, non-disabling stroke, but you have a large vessel occlusion, you can thrombolyze. So these are the 3 things for minor stroke. Minor, disabling, yes. Minor, non-disabling, no. Minor, non-disabling, if large vessel occlusion, go ahead and thrombolyze. Thrombolysis on patients on anticoagulation. If the INR is less than 1.7, you can thrombolyze. And there is also data to suggest that you can actually give PCC on patients on VKs. You can give PCC, prothrombin complex concentrate, reverse the effect of warfarin, and thrombolyze these patients. Even for patients on heparin, there is data to suggest that you can reverse the effect by protamine sulfate and thrombolyze. But the maximum data is for idaruzumab, Praxibine. So any patient who's on dabigatran, if we want to thrombolyze and he has taken the medication in the last 48 hours, you can reverse the effect by Praxibine and thrombolyze. There is enough data for that, and there are ESO guidelines to suggest. Only problem is with anti-factor 10A. So if you are using Eliquis or you are using rivaroxaban, there is no data that you reverse with adnexate alpha. So in fact, there is a guideline not to use adnexate alpha reversal for anti-factor 10A levels. So if the patient is on a DOAC, you can only thrombolyze patients with Praxibine reversal. In fact, now a new interesting paper has come in where patients who are on DOACs, who have taken the DOAC in the last 48 hours, 355 patients who had taken IV thrombolysis without even looking at whether they had taken the DOAC within 48 hours, without doing any blood tests to see whether the DOAC effect was there, they found no increase in bleeding. So probably this will also tweak, like on dual antiplatelets, you can thrombolyze. Maybe in the next 1 year or so, we may see that even if patients who are on DOACs, irrespective of whatever is their blood level, you can go ahead and thrombolyze. So maybe that may also be coming up in the next maybe year or so. Thrombolysis after procedures, we've already discussed, of coronary angio, TAVI, pacemaker implantation, and post-hemodialysis. There is enough data to suggest that you can thrombolyze all these patients and you can go ahead and thrombolyze. This is an important question because a lot of time when a patient comes with an M1 occlusion, and the endovascular person wants to take the patient directly for a mechanical thrombectomy. Should we be giving and wasting time on IV thrombolysis, or should the patient be taken directly for mechanical thrombectomy? And so what should be the stroke neurologist doing at that time? Should they let the interventionist go straight away? Or the advantages of bridging are that sometimes you may get a recanalization just by the IV thrombolysis. And with tenecteplase, it's a 30% recanalization. But the disadvantage is you are adding to the cost and you're delaying the groin puncture. But the data, there are 4 trials, the DEFT, SKIP, and the DIRECT, and the so these 4 trials, all of them have shown, Mr. Clean number 4, they've all shown non-inferiority of bridging. So the data suggests, the AHA guidelines, all patients going for mechanical thrombectomy, if there is no contraindication, they should get IV thrombolysis. It is also the guidelines from, just one more minute. So they can, from the European Stroke Organization, also the criteria, and also from the Society of Vascular and Intervention Neurology, that one should use bridging and one should not be using direct mechanical thrombectomy. And tenecteplase, I think now we know that, it's a molecule which has a higher half-life of 22 minutes. That's why it can be given as a direct IV bolus. It has much higher, 60 times higher resistance to plasminogen activator inhibitor. So it's a much more efficacious molecule. And it is 15 times more specific for fibrin. So it causes less bleeding. So theoretically, it's a much better molecule. And there's a lot of data from the NOR test and a lot of trials. I'll just skip through all of this. So there is enough data to suggest, and there's a meta-analysis of 9 trials of 3,706 patients, where it is now said that tenecteplase is equal, if not more superior, to IV alteplase, except that the advantage of tenecteplase is also for patients undergoing mechanical thrombectomy. So the guidelines now suggest alteplase or tenecteplase in routine patients up to 4.5 hours. Patients who are undergoing mechanical thrombectomy, tenecteplase should be preferred. So that's the guideline from ESO. So I think I'll skip the pregnancy and this for shortage of time. So I'll come to the last slide and I'll try to answer all these questions that I'd asked in the beginning. So if you have an elderly at 88 years, 4.5 to 9 hours, there is no contraindication. Go ahead, CT perfusion, go ahead and thrombolyze. 30 minutes post-coronary angiogram, yes. CLD, upper GI bleed 21 days back, but the PT is within range 1.4, go ahead and thrombolyze. CKD post-dialysis, yes. LVO, M1 occlusion, bridging is the answer, not direct. NIHS, if there is a severe stroke, NIHS 25, no mechanical thrombectomy, go ahead and thrombolyze. Minor stroke, disabling, yes. If there is a left MCS stroke, patient is on dabigatran, reverse with praxibind, it's allowed. MI, if it's inferior wall, don't wait 1 month. Inferior wall and lateral wall, even up 10 days, you can thrombolyze. Stroke MCA, pregnant lady, 2 months, yes, you can. Post-TAVI, post-CAG, post-pacemaker, you can thrombolyze all these patients. The major issue is minor stroke, non-disabling. So that's a dilemma, but the ESO has come into protection and said that, yes, if there is an LVO, yes. If there is no LVO, don't thrombolyze. If there is a pulmonary embolism, you can thrombolyze some of these patients. And the major problem that has happened is we were all using the low dose of alteplase in some patients where they are high bleeders. So somebody who's had a chronic liver disease, he's bleeding recurrently, so we were using, instead of 0.9, we were using 0.6. The guidelines, both the ESO and the AHA, have actually put a hold on that. They have said there is no role for 0.6. But I think in Asia, we all tend to use the 0.6. And I think for high bleeders, we continue to use it. But then we should take a consent off-label that, it's an off-label dosage that we are doing. Thank you so much for your patient hearing.
Thank you, Vinit, for completing this talk in a very short time. I know that you had constraint of time, but we have done that very good, very nicely covered. Now I will ask my students, who are all the people who are all giving thrombolysis. Do you have any questions? Please come and ask Vinit Suri. The students who are there, please participate in the discussion. I want you to participate.
I think thrombolysis is becoming a problem either way. If you miss out on thrombolysis on one patient, I think that's more a problem. And, thrombolizing the wrong patient and getting into trouble again is a problem. So it's becoming a little issue. And because the guidelines are changing so rapidly, every 3 months, 6 months, there is a new thing that's happening. And the guidelines are only 2021 and the AHA guidelines 2019. So you have to keep up with literature rather than with these guidelines. Yeah.
Yes, Mishra ji, please.
Very, very nice talk, enjoyed it. But an element of chance comes in. You have a night patient advising, 88-year-old, a BP difficult to control, thrombolized, goes into bleed. And incidentally, last month, I had 2 patients thrombolized and same day, both bled. One had a minor bleed, one had a major bleed, undergoing hemicraniectomy. So I think, and then, you wonder that should I have given a lower dose? Should I have gone in old age? Probably. I have a feeling that in older age, 80 plus, should we go to a slightly lower dose? Once you burn your fingers, then you think maybe I should do that. I think these are clinical decisions which have to be decided case by case. And sometimes BP is a problem. You control it, again it rises. And again, it's a difficult thing to, in a short time to control the BP. Your comments, please.
I think that's very right, sir. So that's what is happening now. You have to tailor make the thrombolysis for the patient. And when you're tailor making it, you have to understand what are the guidelines, what is the literature supporting. So whenever you're going beyond guidelines, so we were all using the 0.6, and I think Asia, in China and Japan, 0.6 is the standard dose. In Japan, it is the standard dose, and we are all using 0.6. But if you have somebody who fails the recanalization and you have used 0.6, now the guidelines are saying don't use it. So it becomes a very important, very difficult issue. And I think one has to be, taking a consent at that time with the patient that, we are going beyond guidelines. I had a gentleman who was 88-year-old, came at 3 o'clock in the morning, retired Supreme Court judge, and both his sons who were lawyers. And, they at 3 o'clock, and we took a consent. Fortunately, everything went well. He had a right MC infarct. He improved. And 2 days later, when I went into his room, he said, "Doc, we are going to sue your hospital." I said, "For what?" So, when lawyers, so like what you said, he said, because every day in the ICU, a particular number of gloves have been used, a particular number of, so every day 5 gloves are used. How is it possible? So they take out, when you have lawyers trying to look into things, they get really tough. And then they are going to look into guidelines. Then they are going to go into literature and they say, this is the guideline. Why did you cross the guideline? So I think the consent that we take, I think that's also for the residents here. They just take a blind consent. It's a form, it's a and they just say, okay, IV thrombolysis for recanalization and complication bleeding. Always put it that it is beyond guideline. And why are we beyond guideline? And what is the advantage that we're thinking? What is the disadvantage? The consent has to be very proper because it can create 6 to 7% may have intracranial bleed. And if they bleed, 50% of these are going to die. So that's the crux that one has to tell the patients. 6 to 7% intracranial hemorrhage and 50% of the intracranial hemorrhages are going to die. That should be on the consent.
Yeah. Now, now that we have both RTPA and tenecteplase being approved for up to 4.5 hours with DCGI, except for some specific indications, how do you choose which drug to be given for a particular patient?
See, I think that's a very, very important question because now that we have both choices of alteplase and tenecteplase. Now, what I do normally is, so clearly there are certain issues where tenecteplase is better or certain issues where alteplase is better. Keep that in mind. And for the rest, you decide based on cost, based on other issues. So if you have to choose tenecteplase, the number one choice for tenecteplase is any patient who is going in for mechanical thrombectomy. Any patient with large vessel occlusion, you have got a CT angio done, you find that he has a M1 occlusion or an M2 occlusion, this patient is going to go into DSA, directly give tenecteplase. So that is one slot which is clear. Large vessel occlusion, going in for bridging, tenecteplase is the one to be chosen. Alteplase, what is the advantage of alteplase? Advantage of alteplase is all the non-garden variety patients. So you have a 90-year-old with previous bleed, you have a pregnant patient, at 2 months, because this is where the tenecteplase data is scanty. So wherever you have a garden variety patient, choose between tenecteplase and alteplase based on your local experience and cost. But where you are going for large vessel occlusion, bridging, tenecteplase, where you have out of window, out of guideline, you have a 2A, 2B indication patients, don't use tenecteplase there because you don't have literature to fall back to. So that is how I use, that is how I plan the.
Yeah, thank you.
Thank you, Dr. Vinit.
Sir, one question from.
Yeah, okay. Student.
Sir, we recently had a
That
case,
will be-
70-year-old gentleman.
Can you speak loudly? Just keep the mic to your mouth. Huh?
Yes, sir. Sir, we recently had a 70-year-old gentleman who was early dementic, had presented within 2 hours with history of aphasia and right hemiparesis. MR was negative. So in such cases, sir, even after coming out of MR, if he is not recovered, should we go ahead with thrombolysis or what is to be done?
I think that's a very important, if MRI can be negative in almost about 15% of patients, especially if the MRI is done early, not for somebody who's at 2 hours and somebody with an aphasia. Usually the diffusion is negative for patients who have a posterior circulation stroke or who have lacunar strokes. So these are two areas where the MR may not pick up. What we do in our protocol is if the MR diffusion is negative, complete the MRI and do another diffusion at the end. And sometimes you find that, and look at the B2000 value. Sometimes you'll find that the B1000 is not showing, but the B2000 diffusion is showing you the infarction. But if you think it's a stroke, even if it is a stroke mimic, there is enough literature to suggest that thrombolizing stroke mimics does not harm them. But your patient may be having some. So if it is a 2-hour aphasia, right hemiparesis, he may turn out to be something else. He may actually not be an M. But if you see that it is correlating, so he also has an M1 occlusion. So he has an M1 occlusion or an M2 occlusion, and he has come with aphasia, then he is definitely a MR diffusion negative stroke. Go ahead and thrombolize. So, and stroke mimics also can be thrombolized without fear. The fear would be that you wasted 60,000-70,000 rupees of IV thrombolysis, one, and second, you missed out the treatment or delayed the treatment for the primary illness. So if you are thrombolizing a stroke mimic, you are wasting the IV TPA and you are delaying the patient's primary treatment, that diagnosis that he had, you're delaying that treatment. So that one has to be careful. Otherwise, the guideline says stroke mimic, you can thrombolize safely. There is no increased risk of intracranial hemorrhage in these patients.
Tomorrow we are having the discussion, a complete session on stroke. We can continue the discussions because of some emergency. Dr. Vinit Suri has taken this. Please, due to constraint of time, we are closing it here. Thank you very much, sir. You brought out a wonderful thing. I know this topic is very, very hot for neurologists. I remember Professor James Toole, the pioneer in strokes 3 decades ago, making a statement that neurologists have to wake up to the standards of cardiologists. Today, we don't need to wake up neurologists anymore. We need to define. And as we discussed previously, once again, as he brought out very nicely, that we should have at least Apollo, which has been promoting stroke for the last 4 or 5 years, have a concurrence of some protocols, basically because still it is very, very fluid. And so, and many issues, when you are trying to do good, we all are facing the problems of medical legal issues and being questioned in the gray area. I think conclaves like this would help us to do that. Thank you very much, sir.
Yes, thank you very much. May I request Dr. Vinit Suri to join the stage for a group photo with the chairperson. And we will move on to the next session on
Now we move on to the next part of this session, which is a panel discussion. So the topic of the session is women and epilepsy. And I call upon the chairpersons to come on stage. Dr. UK Mishra, who has more than 35 years of clinical experience, and he was a founding member and former HOD of Neurology in SG PGIMS, Lucknow. And he has more than 500 papers published under his name in national and international journals, and is an author of 5 books. Welcome, sir. And the other chairperson is Dr. Sucheta Mudgerikar. She has over 30 years of experience in and around Ahmedabad, and she practices at Apollo Hospitals, Gandhinagar. Extensive expertise in multiple areas of neurology. And welcome, ma'am. So the moderator for this session is Dr. Satish Chandra, sir. So sir does not need any introduction. So,
good morning, everybody. I think we have had very nice discussions till now. And now we are going on to a very interesting topic of women with epilepsy. Now, women and epilepsy. There is a plethora of problems there, right? Starting from menarche to menopause, to pregnancy, lactation, and so many anticonvulsants which have to vary. And all this discussion should come up during our panel discussion. So I'll hand it over to Dr. Satish Chandra to moderate the session.
Topic of this nature. Very equal, when you look at the model, it is equal between the man and the woman. But however, there are certain differences. To discuss about that, I invite my colleague, from Hyderabad, Dr. Prabhakaran from Chennai, Dr. Jyotsna from Mysore, Dr. Kindu from Singapore, Bank. Please come to the dais. So when we look at the demography, we always say there is 50% men and 50% women. And the demography always look at that. Even an effect of 1% is disturbed in whole ecology. And that is what is very, very important. But when we look at the equality among these genders, there are and especially among women, and lots of people register starting from the decade to the old age. So now we discuss this aspect in a different way. I have a picture here, a girl who comes to me, who is 81-year-old, young girl, disease, presenting with a generalized seizure for the last 1 year, and had occasional death in 30 hours of morning. We all know that this will be an IPD syndrome or DPD syndrome. So I'm asking Jyotsna, the pediatric neurologist, how do you manage this young girl? What are the issues involved at that age? Maybe menarche, maybe menstruation, etc. So how do you manage this?
Good morning. At the outset, I thank you, sir, for the invite. And so as sir has clearly put it, it's a 12-year-old girl with one generalized seizure. And there is a defining seizure type here that is jerks in the morning, which suggests that they are myoclonic jerks. And probably we are dealing with a JME syndrome. And the onset, again, fits in because it is 12 years and early adolescence is the usual age of onset of JME. Now, directly moving to, because we are not discussing, we are more into the gender aspect of it. What are the drugs? How would you manage the child is the first part of the question. So the drugs that work in JME, irrespective of gender, whatever it is valproate. That is the drug that works the best. 80 to 85% go into remission with valproate. What other drugs work? Levetiracetam, clobazam, topiramate, lamotrigine. So these are the other drugs that offer a good benefit in JME syndromes. Now we are dealing with a premenstrual or probably a pubertal, prepubertal child. So how does that change things? How to put things in perspective? So a very brief summary on how the puberty has an effect on this clinical case scenario. One, the changes during puberty has an effect on the epilepsy. So the sex hormones, the FSH, LH, they change because of this stimulation of the hypothalamus-pituitary axis. The GnRH pulse regulator is there, and through the increase in the surge in the FSH and LH, that has an effect on the epilepsy in terms of, in some children, there is a remission. Some children have exacerbation, while in some children it makes no difference. But if we take JME as a syndrome, apart from sleep deprivation and stress, menstruation has been known to be a common reason for increase in the seizures. How about the seizure causing an effect on the sex hormones? They also do that. So there is an interrelationship between seizures and epilepsy on the seizure. Not only that, we are also dealing with a scenario where the child is probably studying for exams. There is a sleep deprivation, stress about education, and with and without alcohol use in this age group. That is one. And the last part, the later part of the question was, how do the time is up. Okay, sir.
So considering choosing the right anti-seizure medication for Ms. Nidhi, first of all, we need to look at the pros and cons of starting the right anti-seizure medication. For example, as ma'am discussed, sodium valproate is the most efficacious drug. However, in the likelihood of hormonal disturbances and likelihood of PCOS in this age group, and also with the newer anti-seizure medications, which are also quite effective, except in probable cases of refractory IgE. There are medications like levetiracetam and lamotrigine would be preferable in this age group. There would be an important consideration to other factors, such as the comorbidities in this case. So obviously, if there are any hormonal disturbances, valproate should be avoided. If there are any other comorbidities which need medications, we need to consider the impact of lamotrigine because being an enzyme inducer in this case. Certain newer anti-seizure medications such as brivaracetam are also helpful, albeit their evidence in just in case she happens to conceive is not proven. Other anti-seizure medications such as right. So to begin with, I would consider newer anti-seizure medications other than sodium valproate in this age group. My drug of choice would be lamotrigine. This will be effective in majority of the JME. It may sometimes enhance the chances of having myoclonic jerks, in which case I would prefer levetiracetam. And mainly because of the safety.
So there's a patient with Jamie, and she's a patient with Jamie, and then she's on anti-epileptic drugs. The points to consider would be one, menstrual cycle, second, marriage counseling, third, counseling regarding contraception because we have to plan early. So first, talking about the menstrual cycles, the estrogen is proconvulsivant and progesterone is anticonvulsive effect. So we need to be aware of that. And then the catamenial epilepsy, it's a major concern. The recent studies have shown acetazolamide with clobazam is working for that. And second, PCOS, which already has been mentioned. The sodium, if the patient is on sodium valproate, if no other drug works and the patient is on sodium valproate, we need to be careful about sodium valproate. And there is increased possibility of obesity and increased levels of testosterone when the patient is on sodium valproate. Though we avoid sodium valproate, if the patient has no other drug working, we have to continue lower dose sodium valproate. And third, about marriage counseling, which should be discussed in detail with the parents. So the counseling should be done for that. And contraception is a major problem because 80% of women with epilepsy has at least one unintended pregnancy. So the contraception should be discussed, and barrier methods or intrauterine devices are the best option. And try to avoid, if the patient is on enzyme inducers, then again it's a troublesome.
Good morning, everybody. Thank you for inviting me to be a panelist. It's a good question. So in case she's not being controlled with levetiracetam as well as lamotrigine, and that too considering her age being 12 years, so the next drug would probably, we can try something like topiramate or zonisamide or clobazam before resorting to valproate, because the guidelines, especially the British Pediatric Neurological Association, anyone above the age of 12 years, we must try to avoid valproate as much as possible. So probably we can give a trial of the other medications before resorting to sodium valproate. And yes. I think, sorry, I think I missed the contraception part of it. Yes. So contraception in young women is very important because a study in US said that around 65% of the pregnancies in women with epilepsy are unplanned. So contraception is very important, and there are various methods, as we know. It can be OC pills, or it can be depot preparations or barrier methods. So the problem comes here because most of the medications that are used, especially the enzyme inducers like phenytoin and carbamazepine and phenobarbital, they all act on the CYP3A4 enzyme. So, and your OCPs as well use the same enzyme. So what happens is when we use it along with these drugs, which are enzyme inducers, there will be a contraception failure. And in addition to that, there are some drugs like topiramate, which act only on a particular part of the OCP, like the estrogen part of it. So we have to make sure that we use drugs like zonisamide, levetiracetam, and lamotrigine, which do not have an impact on the OCPs. And in addition to that, one more catch is lamotrigine, though it does not have an effect on the OCP, in reverse, the oral contraceptive pills, especially the estrogen, can induce something called as glucuronidation, and that increases the metabolism of lamotrigine. So giving an OCP along with lamotrigine can reduce the levels of lamotrigine and indeed cause seizures. So that is something that we'll have to keep in mind. So the best method ultimately in women with epilepsy would be probably an intrauterine device, either copper T or levonorgestrel eluting IUD would be a better option. Right. So coming to pregnancy and epilepsy, first of all, pregnancy is a huge steps that someone's going to take. So especially with women with epilepsy, considering that they are a high-risk pregnancy, we always have to reassure them that 90% of the pregnancies are going to be uneventful. You're going to have a normal delivery and it's going to be fine. But at the back of our mind, we should always, counsel them saying that overall, the baseline seizure control is very important, especially 1 year prior to pregnancy. So in case a lady goes into pregnancy with a very good seizure control, the likelihood of her having seizures are very less during pregnancy and during delivery. So it's extremely important to have a baseline seizure control at least 1 year before pregnancy. So that, and also it means that we have to change all this polydrug therapy to monotherapy as much as possible before the pregnancy. And also the type of anti-epileptic drugs. Like for example, if she's on valproate, we can always substitute it with levetiracetam or lamotrigine before she even plans to conceive. And I follow this thing that I usually start off these patients on folic acid supplementation, at least 5 mg, at least 3 months to 9 months before conception or before planning pregnancy. So these are few things. And in addition to that, we must also keep the dose as minimum as possible just before the pregnancy, because once conception happens, there's always a possibility that the doses of AEDs have to be adjusted, especially in the second trimester when it requires continuous monitoring and adjustment of anti-epileptic drugs. So,
That's a very pertinent question, especially for the women who are planning pregnancy. So the place where I practiced before joining Apollo in Bristol, we have something called as a valproate risk assessment form, wherein all the women in the fertile age group until the age of 44 years, they have to fill up something called as a valproate risk assessment form every year. And they have to have an appointment with their epileptologist to discuss about the risks of consuming valproate in this age group. And also they need to be on a contraception pregnancy prevention program while they are using this medication. So having said that, once the patient has conceived, it is very important that you document the risk factors of consuming the anti-seizure medications. and to explain about the potential teratogenic side effects, and to have the fetal scan done at the gestation age of 20 weeks, and documenting about the counseling during this is extremely vital. Absolutely. So pregnancy is a very dynamic state, and the levels of anti-seizure medications are seen to drop significantly. This especially holds for the newer anti-seizure medications such as lamotrigine, to some extent levetiracetam, and also drugs such as zonisamide and lacosamide. This, in fact, it starts even pre-conception, because women who are on contraception with lamotrigine, it's advisable that when they stop the contraception, the doses of lamotrigine should be lowered to as much as 50% to the pre-contraception doses. Once the patient conceives, it is recommended by guidelines that the anti-seizure levels are monitored every month. And if the levels happen to be low, they need to be increased by 25%. At the same time, at the end of pregnancy, this monitoring needs to be more frequent at the end of 1 to 2 weeks, because there are cases wherein lamotrigine, drugs such as lamotrigine can present with toxicity because of the extremely high levels.
So we'll be looking at the problems for the mother, problems for the fetus, and planning the delivery. This will be the concerns for me at this moment. So this Nidhi, who's having a JME, probably she's on levetiracetam or lamotrigine, less likely to be on sodium valproate. So my concerns will be, one, for the mother, as we discussed about the drug. Usually the drug is increased, if it's levetiracetam or lamotrigine, we increase by 1/3. The reason is the reduced serum albumin levels, increased volume in the mother. So these things will reduce the drug levels. So we usually increase. As the doctor said, we can check assays and also increase. The other concern will be, if the person is, if the person did not have seizures 9 months prior to pregnancy, then we can plan a normal delivery. Yes, if it is sodium if the patient was on sodium valproate, then we will be advising as a vitamin K advice, because it can cause coagulopathy. And for the fetus, obviously we will check for any defects. So if the patient did not have seizures 9 months prior to pregnancy, then normal delivery is advisable. If not, it's a discussion with the obstetrician. There is the mortality is almost tenfold in patients with women with epilepsy. So we need to consider that and change over to IV anti-epileptics prior to, if it is cesarean, better to change over to IV anti-epileptics.
As a mother, she wants more of What advice do you? Are there any concerns that you would want to utterly express?
Yes, so I am a pediatrician turned pediatric neurologist. So when it comes to breastfeeding, there is no louder. Okay. So from a pediatrician's perspective and a pediatric neurologist perspective, breastfeeding is helpful to the baby irrespective of what drug the mother is on, even if it is valproate. Even if the mother happens to be on valproate, the level of drug, it is not equal to a fetal exposure of valproate or a fetal exposure of any anti-seizure medicine, because the levels in secreted levels in breast milk is much, much lesser. So irrespective of what drug the mother is on, the baby definitely benefits by breast feeding. And the cognitive outcome, verbal, non-verbal, memory, language, all types of outcome have been studied in multiple studies. We also have our own Kerala registry where they have studied the cognitive outcome of children on mono and polytherapy. So irrespective of drug, overall outcomes have been better in children who have been breastfed. So coming to the what a mother would want to know when she's on medication, teratogenicity is definitely a risk. The highest teratogenicity is with valproate and subsequently phenytoin. And the other drugs, carbamazepine, lamotrigine, all come around 2% when it comes to teratogenicity. But at the outset, if a woman just wants to know what is the risk of my child having a seizure or an epilepsy because I have one, it is a very difficult question to answer. However, if the general population has a 1 to 2% risk of epilepsy, children of women with epilepsy, or the CWWE that we call it, they have a slightly higher risk of 2 to 4%. And that is having a dose, is dependent on the drug and dependent on the dose. Valproate being the worst, which is also dose dependent. And the other drugs that the other panelists discussed about, like lamotrigine, clobazam, have a much less teratogenicity. But there is another thing to it. What other risks does my baby have because I'm an epileptic? In the immediate post-partum period, a mother, especially with an IgE phenotype, is sleep deprived. There is stress. There are hormonal fluctuations. So she's at risk of seizures during that time, in which case there are some general advice like not handling the baby alone while bathing and having support system, and also not being alone while carrying the baby. These kind of general advice we also give, especially when she's in a danger situation, like bathing. So that kind of a general advice is given to a mother.
So genetic generalized epilepsies, around 15 to 20% of all epilepsies are genetic generalized epilepsies. If a person has a genetic epilepsy, then the first degree relative, the chances are around tenfold that a person getting an epilepsy. The diagnosis actually electroclinical and not genetic testing, because most of the times, because of the inheritance pattern is very complex, and most of the time it's negative, except when a child is less than 4 years and only has primarily absent seizures, it's worth chasing. If not, most of the time it's negative. The genetic generalized epilepsies are childhood absent seizures, juvenile absent seizures, and juvenile myoclonic epilepsy, and GTCS alone, and with eyelid myoclonus. So it's not, the inheritance pattern is very complex, and only less than 4 years it's worth chasing. Can I add one line, sir? It's still electroclinical. It's the seizure semiology, the triggers, the characteristic EEG findings, the age of onset, and the probability of the person getting seizures. This decides the diagnosis.
Right. So normally what happens is a lady comes and they're planning to get her married, and they say, okay, is there any other way to control her seizures other than medical management? So is there any surgery? So in such cases, it is important that we evaluate them in detail, do a pre-surgical evaluation with video EEG and PET CT and MEG if required. And if all the investigations are concordant, and if there is a chance that she's going to be seizure-free by more than 70 to 80%, then I would strongly advise them to go ahead with surgery before marriage, so that the concerns after marriage, be it continuing the medications or further pregnancy, would be addressed by just the surgery. And I feel the timing of the surgery would be appropriate if it is done before marriage, because the further, as you know, epilepsy is a social stigma. So even getting them married is going to be difficult in so many families. So they want them to be off drugs as much as possible. So if there is a 70% cure rate or seizure freedom, I would definitely advise them to go ahead with further pre-surgical evaluation and epilepsy surgery prior to marriage, or after marriage before the conception. Yes. Absolutely.
Well, there are two significant problems for these women who are nearing the menopause. One of them is the seizure control, which may significantly decline as they approach menopause. That's because of decline in the progesterone levels, and progesterone happens to have a seizure protection role in these women. So in these women, we have an important concern about the women who would be wanting to start on the hormonal replacement therapy do pose a significant risk of worsening in the seizure control, and it's not advisable. The second concern is in these women who have been on anti-seizure medications for a significant while, especially for more than 3 years, do have, especially the enzyme-inducing drugs, have chances of developing osteoporosis, and that could be 2 to 6-fold. And in these women, it is important that they are screened for osteoporosis, they are treated for osteoporosis, and they do receive calcium supplementation of 1 gram, and as well as vitamin D supplementation of over 800 international units per day.
Honored teacher for all of us. Thank you so much, sir. Thank you, panelists, for the wonderful discussion. For really, so my question is, the same Nidhi kind, sir, is a patient who is on levetiracetam, started on 500 mg twice daily, went to 1 gram BD for juvenile myoclonic epilepsy. Could not increase further, but he continues to have at least 2 or 3 generalized tonic-clonic seizures. Planning for marriage in July, and she is on this medication, not able to go further. So what should be done for this patient? Should you go for a dual anticonvulsant and tell them about the risk? And what is to be done, sir?
So this is a very important question, and we do come across such situations when one anti-seizure medication fails to control the seizure. And we all know that with the increasing dose and with polytherapy, the chances of having teratogenic side effects do increase manyfold. In fact, 16% with polypharmacy. So there's a beautiful Nordic study where they have studied the importance of combination therapy, and the combination of levetiracetam and lamotrigine, they have shown that the chances of having the teratogenic side effects, the major congenital malformations, is about 2%, which is fairly acceptable. So the first line of management would be to see if any other anti-seizure medication is being helpful, for example, lamotrigine. If that fails, then a combination. If that fails, I would still consider the role of neuromodulation, such as VNS, in refractory IG. And if that fails, then a low dose of sodium valproate.
Thank you. 24 years, sir. Wants to get everything, want to get married very soon. That is what you are thinking. If I were you, I would advise them to go now, because the patient is getting very frequent seizures, and maybe that we will control the seizure first and then go on to the very advanced device. That may be the first factor.
then they will not listen to you, then you need to plan for another drug. What drugs do you use? Then you have to find how do you plan for them. If they not get the marriage today, tomorrow they might not ask you to do pregnancy. So how do you handle it? So these are the questions which are a counseling session. It's a future, but getting married, which is possible, bring them onto the table, discuss about. I have many times the prospective, the tribal, I want them to come and discuss with them. I always say, I'm having many ideas, but I'm not a pro.
So the second question is regarding the one last question, that's all, sir. Having a pre-marriage surgical option to give them seizure-free rate. It sounds very tempting, sir, but there are social reasons behind this. A girl who has undergone a brain surgery, very difficult to get a match, sir. Your comments on this?
Yeah, so a girl with brain surgery is obviously she finds it difficult to get a match, but a girl with refractory epilepsy also finds it difficult to get a match. So I think we'll always have to weigh the risks and benefits. And if surgery is giving her a seizure freedom, I think that would be the best quality of life that she can even get. So I think that has to be kind of conveyed to them. And if seizure freedom is going to improve quality of life, why not? I think she has to look for more matches which will accept her surgery and her, you know.
Sir, I have no questions. I have only some comments. One is, the real problem for a woman is only at marriage. A unmarried girl getting married, if she tells that she has got epilepsy, the marriage is going to be a problem. That is the one major issue. The second issue is during pregnancy. In the government hospital which I have worked, we have seen thousands and thousands of people, women, everything. We had only phenytoin, carbamazepine, valproate. We hardly had any problem. And the question of planning the pregnancy, it never works here in a setup where, these less educated, less one, you tell them don't get pregnant, they get conceived and come back. You tell them take this tablet, don't take this tablet, they come. And even valproate small doses, say 300, 600, had not harmed this one. I think the harm of valproate comes only when it is given at a very high dose. Barring these two situations, we had come across hardly any problem with women with epilepsy.
Some time back, I read in the Continuum that the American society is different. Teenage girls, they have a different behavior. Those teenage girls on enzyme-inducing anti-epileptic drugs, the recommended American Academy of Pediatrics recommend IUD insertion. Now, epilepsy, woman with epilepsy, married, wants to, on anti-epileptic drugs, wants to have a baby after 3 years. What is the role of IUD in this situation?
From a pediatric neurologist perspective, I think an adult person is a better person to answer this. But just this thing that Andat sir was saying, continuing that, the clientele that I get, the kind of patients that I get, single mothers separated because the husband found out about her epilepsy after marriage or during pregnancy, which obviously acts as a stressor. And that kind of a social implication also is very huge, sir. And then the children are cognitively not so great, the anxiety in the mother. And it is a continuum, actually, not just at marriage. After delivery, separation, single mothers, that also is very high. While this question, I think an adult neurologist is a better
I've
person
been probing this. I've interacted with the obstetricians. They said no. So I want to know what's the consensus of this house about IUD in a married, pregnant woman. before, she has got epilepsy. She wants to postpone it, whether she can go in for IUD or not.
I think IUD insertion may be done before planning on a pregnancy, but however, she wants to have a child in the next 3 years. So what I feel is,
I asked my obstetricians, they said, no, sir, no, sir.
Yeah.
Before this birth of the first child, no, sir. I got a second question here.
yeah, yeah. So,
Yes.
so what we can plan is probably other methods of contraception would be better in her. Probably after the first pregnancy,
Question
IUD
was
can be
of
inserted.
IUD. I got a second question. There is a dose-dependent teratogenicity of using these anti-epileptic drugs. Even lamotrigine, for that matter, if you are exceeding 325 milligrams, the risk of major congenital malformations exceeds 3.25%. Similarly, we have been talking about levetiracetam. The risk of major congenital malformations is to the tune of only 0.7% if it is individually used. How far we can push levetiracetam in a pregnant woman without teratogenic side effects?
Zero.
So, may I be allowed to make a comment? So as I was saying, there are studies which have shown that 200 or 300 milligram, 400 milligram of sodium valproate stands the same amount of teratogenic risk as against levetiracetam or lamotrigine at a very higher dose. I cannot offhandedly remember the dosage. So in a particular patient who is not responding to levetiracetam and lamotrigine, whether her 200 milligram alone as a monotherapy might be as successful to reduce the teratogenic risk may be considered, but that is not, that's not a hard and fast rule, as I said. So that's well justified. And somebody was also asking about the dilemma of arranged marriages and whether to reveal it. So in epilepsy and behavior, there was an expert group from our country itself. There is a published paper, Dilemma of Arranged Marriages in Persons with Epilepsy. In that, the statement, the consensus was that to reveal the epilepsy might probably need to be underscored in that patients, but then it's left to the particular individual and the family that she's going to get into. Thank you.
She has got a marriage video to prevent epilepsy from deploying epilepsy. She is successful and she has been awarded by
One last question from my side. These are all practical. Yes, last question from my side. Grandmother has got IgE. The mother has IgE. They bring a 5-year-old child. Sir, just see genetically whether my child is going to be affected with epilepsy or not.
Can I take that? Okay. So when it's an IgE syndrome, especially a JME, the risk is polygenic. The risk is genetic per se, 7-8 genes have been implicated. On top of that, there are environmental factors, and then there is epigenetics. So when it comes to an IgE syndrome, estimating the risk in a child is very difficult. And overall, on a broad level, if we would want to say, the risk is very low, actually, in an IgE syndrome. But again, it changes again with the type of epilepsy.
We don't test.
What is it, sir?
Testing.
Testing, no. Actually, unless the family wants to pursue it, testing is not recommended.
No, it's very brief because what is the concept of annulment of marriage with respect to epilepsy? With the history of epilepsy. Now, the situation is where you have girls who have had seizures in the past, well controlled. There's a stage where we get them off their drugs. We tell them that you have a lifelong risk of 20–30% having a seizure again, but now you're off your drugs. 3 years later, she gets married. Husband finds out that she had epilepsy earlier. This has not been disclosed to him. See, disclosing when a patient is on active treatment, I think is required. In not disclosing epilepsy when the patient is actively being treated, there's a lot of a lot of legal issues there. But when you have a patient with an IgE treated off drugs, and then the husband comes, there are a lot of cases where they file for divorce, file for annulment. So just concepts on that.
Legally, the law says differently. So the IEA has got all the laws regarding this, and they are equal, they can be given, they can marry, there is no another. But on the other hand, social issues are to be. So those are to be addressed in the individual. We can discuss about this. I think we are running short of time, and we will go on to, if there are any more questions, I think families are available in the last time. Please feel free and discuss. Thank you very much. Thank you, Chairperson, for very much.
Now we move on to the debate. So the topic for the debate is older versus newer anti-epileptic drugs in the management of epilepsy. So I call upon Dr. Madhusudan Babu, sir. He has over 25 years of experience in Apollo Hospital Health City in Visakhapatnam. And he has had significant roles, including Superintendent of King George Hospital and HOD of Department of Medicine, Andhra Medical College. And he has been awarded the Best Doctor Award on Independence Day and Republic Day. So I invite Dr. Madhusudan Babu. And the next chairperson is Dr. Adur Gurucharan, sir. He is a senior consultant neurologist at Apollo Hospital's BG Road. He has completed his education from Vaidehi Institute of Neurosciences, and he is a member of multiple societies, including ECTRIMS, UAE MS Society, and COVID Care Unit, Bangalore. Sir. Welcome, sir.
Good afternoon to all of you. And this Apollo Neuro Conclave, as conceived by Professor Satish Chandra, is going on very well. And the interest was shown in this panel discussion. So now we come to the debate. So in the management of epilepsy, the goal is to control seizures with good quality of life, giving a good quality of life to the patient without side effects. Which drug meets this criteria? None. So many drugs are coming. So let's have a debate on this, older versus newer anti-epileptic drugs. First, old is gold, so we will go to the talk on older anti-epileptic drugs. And I invite Dr. Shekhar Patil from Mumbai to give a talk on this. Dr. Shekhar G. Patil is esteemed as distinguished neurologist with over 16 years of experience. sorry for that. He did his MBBS, MD Pediatrics and DM Neurology and DNB Neurology. His expertise spans across broad spectrum of neurological conditions offering specialized APMC market, Vashi, Belpur, Blanket, and Chikbalapur. Dr. Sekharji Patil for comprehensive among others. I'm sorry for the interruptions in between because of the mic. And Dr. Sekhar Patil, please take over.
Is it coming through? Yeah. Okay. Thank you for having me here. So I'm going to actually have a debate with my colleague on talking on newer anti-seizure medication, and I'm going to defend the older generation. So I'll be talking about the newer, meaning the role of anti-seizure medications, looking at the older variety. So to start off with, we're looking at the epidemiology. And if you look at the epidemiology and the burden of epilepsy, we really are looking at a good number when we come to India as well. And what we actually need to now have is a good control between the, so the primary aim would be the seizure control. So we first begin with what would be then ideal for an anti-seizure medication. So what we should have for a good property would be high oral bioavailability, low plasma protein binding, linear kinetics, renal excretion. So linear kinetics, very important for the newer generation compared to the older generation. Should have a broad spectrum of activity, definitely offer excellent seizure control, which is the primary aim. And that is the reason we are here. Just to take you through the mechanism of action, where we have the excitatory and the inhibitory synapses, different locations, newer mechanism of actions, novel therapies which are coming through. And then we look at the drug discovery. So we have various stages of the evolution, and the ones which were before 1986, those are the ones that we are actually talking about, the older generation. So we are actually very relative. So maybe 10 years down the line, I could be actually moving a chart to the right side and actually say that gabapentin, lamotrigine, levetiracetam is actually old. So I mean, it's very relative to be talking about anti-seizure medication, old versus new. So today, this is where we are. 10 years down the line, the argument may be different. But we also need to remember that you could be driving around in Maruti or you could be driving around in a GLC. The primary aim is seizure control. So if that is the primary aim, and if the older variety of anti-seizure medications stand true to their task, that they are actually giving us seizure freedom, then I think we should probably be choosing and sticking to them. So the primary purpose and objective is seizure freedom. And of course, we have to balance it with the tolerability and the side effects along with the cost, because most of the cost is borne by the patient. So we have to really look at the cost increasingly in the current day and age. Now, what are the potential advantages that my colleague might put you through? So it's novel mechanism of actions. We have lesser drug interactions. They're better tolerable, lesser hypersensitivity reactions. And they do talk about safety in pregnancy. But we also need to have, well, I'll actually come to that when I actually discuss these cases. So the cost-wise, I would say that the older generation definitely do much better. Now, when we look at the pharmacokinetic profile, we are looking at non-linear, there's less of autoinduction. The older generation, you would say that enzyme inducers or blockers, they definitely lead to drug interactions. And you actually look at the pharmacokinetic variability for all these medications. When you look at the newer generations, you definitely offer a favorable pharmacokinetics. They do offer lesser drug interactions, but they have variable half-lives, which can be an advantage, sometimes disadvantage. But having said that, what we generally look at is the final outcome. The better pharmacokinetic profile, the lesser drug interaction does not translate to better efficacy. So that is the primary aim. Now, when we look at pharmacoresistant epilepsy, be it in the era of 1980s, be it 1990s, 2000, 2023, we have not changed at all. So the proportion of pharmacoresistant epilepsy remains the same. So we are probably just between 65 to 70%. That is where we stand. You add more and more combinations, so you increase, and you are actually looking from monotherapy going up to 7 anti-seizure medications. You're barely moving. So we will look at 2, you are actually at 64%. You look at 7, you are actually looking just at 69%. So you've not really dented much when you actually have these ones. Of course, the proportion of prescriptions, when you look at the prescriptions in the world, so you look at the anti-seizure medications, the older variety are probably not being chosen as monotherapies, and a lot of prescriptions, newer ones, will actually have the latest anti-seizure medications. But when we look at our own data, look at our tertiary care hospitals, government-based setups, we still are bearing a lot of value and hope on older seizure medications. Now, when we look at this, probably 30 years of second generation anti-seizure medications, and we look at the impact and future perspectives, you can actually find out that the amount of medications actually is, even though the prescriptions will have the lesser number of the older generation, the number of seizure-free patients still remain the same. And we always have this particular thing to deal with as older seizure medications, that, okay, you are more teratogenic, and then you actually have to look at this particular issue because a large number of women with epilepsy will actually come to you for treatment. And this is the point that is held against us. So you look at the teratogenicity, as I do agree with the dosages and the teratogenic potential, but the dose of valproate, it is, if you use it lesser, maybe up to 200, 400, we are actually not looking at 10%. We are probably in the realm of 3 to 4%. So if you want to choose sodium valproate, there is an argument to still choose sodium valproate. Now, the problem about the SANA-2. So if you actually look at the critique, the critique actually mentions that the primary aim is seizure freedom. So even if you want to offer sodium valproate to someone with a woman with epilepsy, and you're actually looking at the seizure freedom as a primary aim, then probably you can discuss and actually place it out in terms of the teratogenic potential and discuss the role of sodium valproate and offer efficacy. So we'll look at the comparison now. So we'll look at scenarios where the older generation is compared to the newer one. We look at status epilepticus. We do not find any change when we look at sodium valproate, we look at phenytoin, we look at levetiracetam. So when you look at the number of patients that have been treated and the outcomes compared to any age group. So here you have a chart which have the children, the adults, as well as the older population, and you do not find any significant difference vis-a-vis the outcomes in terms of sodium valproate, phenytoin, as well as the levetiracetam groups. So you can still continue to choose the older generation medicines. Now, levetiracetam plus phenytoin for a second line treatment for CS, this is a trial specific for pediatric population. So the final argument is that levetiracetam is still not superior. So when you look at all the research articles also, they are not showing that they are superior. Probably they're placing it as they're not inferior. So that's the argument of putting in and pushing through newer anti-seizure medications. So when you look at generalized epilepsy and absence, so if you look at all the data that comes through, finally, two main, so if you look at pure absence epilepsy, there's nothing to beat sodium valproate or ethosuximide. And we look at the role of the SANAT study, which actually looks at, so valproate is still superior to lamotrigine, levetiracetam, and topiramate. It's better tolerated than topiramate. So efficacy of valproate is definitely superior. And when you compare levetiracetam versus sodium valproate, it's neither efficacious nor cost effective. So when we look at this data and compare it with teratogenicity, the only thing that is holding you against it is probably against sodium valproate is the teratogenicity, but with the proper dosages, you can still probably argue for its use. And then this particular paper which came through. So we are actually looking at an article which published that is the honeymoon period for levetiracetam finally done with. So yeah, yes, it has a quick therapeutic effect. It probably is being used as often because it is user friendly. there is a known side effect profile, but there are certain surprises which probably everyone will have anecdotal cases to comment on, but nothing much to offer in terms of long terms with regard to seizure control. So when we're actually looking at the primary basis, we still have nothing much to choose from with regards to the newer medications. Now, Sanat actually tried to look at use of lamotrigine and probably portray lamotrigine as something superior to the focal epilepsy group. And they actually said that that should be the first choice medication. But when we look at the critics, so the everywhere in all the studies, what has been published, that carbamazepine probably as a controlled release preparation is far better adjusted and far better tolerated than carbamazepine in immediate release preparation. Now, within the trial, the escalation was carried out in 4 weeks itself. That probably was responsible for poor tolerance in the study, and that is the reason lamotrigine was better tolerated. They also argued that the seizure control was probably better, but if you look at the analysis and subgroup analysis, carbamazepine still is far superior to any of the medicine that was tried. So we use carbamazepine Reptard, probably all the advantages with regards to the tolerability of the newer medication disappear. So almost all data suggests that the argument for lamotrigine actually disappears, and we have a lot of reviews here. So this is the critique against the Sanat study, and you can actually see the highlight. I've actually put these 2 arguments forward, and that is the reason why people tend to still leave it to an individual to choose whatever they want. Then we come a specific scenario, neonatal seizures. So neonatal seizures, still the #1 choice is phenobarbital, and that is probably what has been pushing through. The data is for phenobarbital. You look at different studies, then we have acute provoked seizures and tonic seizures or the metabolic seizures. So even here, if you look at the choice of medications, so the metabolic epilepsies will still go back and be controlled by the older generation. So phenytoin, carbamazepine work very well in that setting. So phenobarbital for a standard first-line medicine, and the other variety, which is the metabolic epilepsies in neonatal setting, again phenytoin or carbamazepine to be chosen, which means we do not really have room for the newer medication here. Elderly population. So we look at elderly population. So, well, we do not have an ideal according to the convention tend to use because of the comorbidities. They are ISD, cardiac patients, renal failure patients. So you actually have them on multiple medicines. So yes, I would take the point that you would choose a medicine which will have a lesser interaction. But when you finally come down to the bottom line, seizure freedom, then again, the older medicines still stand steady. So this was the article which was published in 2007, actually. So this was lamotrigine versus sustained release carbamazepine in elderly, and the elderly population still tolerated the carbamazepine controlled release. So we have a lot of data from different groups of population where the older generation medicines are still doing its work. And when we come to the genetic epilepsies, well, some of the genes are now looking at responsive to only older generation medications. So we do have everywhere to go by, and we still #1. So in summary, for status epilepticus, phenytoin, sodium valproate, phenobarb are still effective. Newer generation medicines, probably not inferior, but definitely not superior. For generalized epilepsy, valproate still the #1. Even for women in childbearing age, even though it is teratogenicity, but if I have to focus on seizure-free outcome, I will still discuss sodium valproate and still use it. For focal epilepsy, when we look at carbamazepine controlled release, it is still #1. But in terms of tolerance, yes, I give it to the newer generation that they are better tolerated. For neonates, phenobarbital, carbamazepine. For the genetic epilepsies, for sodium channel mutations, sodium valproate, phenytoin high dosage and carbamazepine have an impact on the sodium channel SCN2A and SCN8A mutations. But when we also look at anecdotal reports, you will actually come across Dravet syndrome where they have been treated on carbamazepine, and the moment they withdraw carbamazepine, the seizures return. So I would say that older generation medicines still have value, still have something to play with. And we are here just targeting seizures rather than diseases. So probably the way forward, instead of having a newer versus older, would be to understand the epileptogenesis better, actually understand the molecular mechanisms of epilepsy and look at pharmacoresistance, because even with the newer generation medicines, nothing has changed in terms of the seizure-free outcome. So we are still at between best 64 to 70%. That is where we have stayed in the last century, and even now we are there. Thank you.
Thank you, sir. Thank you for presenting the Maruti 800 side of the presentation. Now we look forward to the Mercedes GLC talk by Dr. Sudhir from Hyderabad Apollo. It's indeed a pleasure to have Dr. Sudhir on board today. In fact, he inspired us with his first Neuro Conclave in Hyderabad last year. And welcome, sir. He's a run addict. He's a fitness freak. He's on Twitter. He has over 30,000 followers. So apart from all this, this is something which is definitely not on the slide. So let me take this opportunity to welcome Dr. Sudhir to make his presentation on the newer anti-epileptic drugs.
Yeah, thank you for the introduction. And we are happy to be here, and we've had a lot of interesting discussions since morning. And this one also is very interesting. In the previous speaker, Dr. Shekhar, he presented all the good facts. And that picture is the most valuable, Maruti 800 versus the Mercedes. You know, if somebody were to have an accident in the older generation car, possibly there is no chance of survival. In the second one, there is some hope of survival. And, you know, this debate we always have, old versus new. But, you know, how to define old, what is old and what is new? Maybe the year of passing DM, or whether it depends on our age. So we had a professor, you know, so the young stroke and old stroke, as her age kept on increasing, she kept on increasing the, you know, young stroke, less than 40, less than 45, less than 50. So very difficult to decide what is old, what is, and also very few drugs are left. Like Dr. Shekhar said, only 4 drugs are left to be old. And we have a huge number of new drugs. So that comparison itself is very, very unfavorable, but still he did a very good job of defending the. And then if you look at, we have, you know, so many new anti-epileptic, anti-seizure drugs are getting approved every year. And then, so one is to look at, you know, the drugs, how they act, and the mechanism of epilepsy, and then that may be a better way. And then looking at the comorbidities, the adverse effect profile, tolerability, rather than, you know, if you look at the common side effects. So these side effects, definitely the newer anti-seizure medications are better tolerated, and the adverse effects are much lesser compared to the, if you remember phenytoin, you know, the gingival hyperplasia was so common, and then we had many patients taking drugs for 10 years, and they used to come with cerebellar atrophy. So those kind of severe adverse effects with the newer anti-seizure medications we don't see. And if you look at the seizure freedom, of course, there are very few head-to-head comparative trials, but the seizure freedom possibly is better with the newer drugs because the tolerability is better, and, you know, the drug compliance has improved. So that could be the reason. But if you ensure the compliance with the older drugs, also the seizure freedom is almost similar. And then if you look at the number needed to treat to achieve seizure freedom is again on the lesser side with the newer anti-seizure medications. Then other thing which comes to our mind is always people with epilepsy have many other comorbid conditions, and a huge number of them. If you look at, many of them have liver disease, renal disease, and, you know, the whole entire list is there. And in many of these conditions, we fall back on the newer drugs because they are much safer in people with comorbid conditions compared to, like sodium valproate, obviously we cannot use in a person with liver disease, whereas newer drugs can be used. And, you know, and then even phenytoin with cardiac issues. So there are a lot of ifs and buts. When we have a patient with comorbidities, many people keep on complaining about weight gain, and then that straight away takes away sodium valproate, which is such a good drug. But nowadays people are weight conscious, and even if it is not due to the drug, they blame on the drug. So I always look at the, you know, they say the mother will complain, my son or daughter is gaining weight, see so much weight he has put on. Then I look at the mother, but how did you gain weight? Because you also are equally over, it doesn't look nice, I tell in a very subtle manner. But then the blame always falls on the drug. So, but at the same time, even though we have so many old drugs, so many new anti-seizure drugs, but as of now, many needs are unmet. And that is the main thing. So, whether we claim victory over the older drugs or the newer drugs, I think the conclusion is that we still haven't won over epilepsy. Still, there are many patients whose seizures are not controlled. Still, many of them come with adverse effects. So still, we have a long way to go. Maybe we need still another 5 or 10 newer drugs, which can be more efficacious, which can be better tolerated. And there are no significant drug interactions, which don't impact cognition, mood. So newer drugs, many of them have, even though they are safe, but like levetiracetam has cognitive and behavioral side effects, and things like that. So definitely there is a need for newer drugs. Lacosamide came, definitely it helped in some of the patients with focal epilepsy. So patients who are not well controlled on carbamazepine, which is the first line drug, when we add lacosamide, then the seizure control was better, and also the drug was better tolerated. And the long-term safety data also is there on lacosamide. And it doesn't impact cognition, mood, behavior, and also it helps in comorbid conditions. And quality of life also improves. So few things definitely improved when we added lacosamide to the treatment of partial epilepsy. And then in liver disease also I just discussed. So basically we have some of the newer drugs which can be safely used compared to sodium valproate. In renal disease also we have few drugs which are from the older as well as newer anti-seizure medication which can be safely used. And then if you look at cardiac arrhythmias, so basically among the older drugs, carbamazepine and phenytoin is the main culprit there. But newer drugs are generally safe. For weight, as I mentioned, so in that the biggest culprit is sodium valproate, and whereas few drugs like levetiracetam, that is weight neutral, lamotrigine also is weight neutral. So few of the newer drugs can be safely used when we are concerned about overweight or obesity. And other issue is lipid metabolism, where we see that with carbamazepine, there is increase in the lipid levels, and same thing with oxcarbazepine also, whereas lamotrigine is safe. Phenytoin also it causes increase in total cholesterol, triglycerides. So these are some of the markers which we need to look at in some of our patients. And so this just summarizes what we have already discussed in the comorbid. So basically, if you look at the newer anti-seizure drugs, so they have more novel mechanisms, and also they have multiple different mechanisms of action. So they can be safely combined, and then the interactions are lesser. And there are many studies which show that where the first line anti-seizure medications have failed, adding second line drugs have achieved seizure control as well as seizure freedom in some of those patients. And they're generally better tolerated. Side effects are lesser with the newer medications. And they can be safely used in people with liver, renal, or cardiac diseases. And they have lesser drug-drug interactions. And some of the newer AEDs are better choices with people with comorbidities. But as I mentioned, I think the main debate here should not be like old versus new. It's like, how we can progress further so that the 30% people who don't get relief from anti-seizure medications, something can be done for them. I think that's all I have to say here. Now it's open for debate and discussion.
I request Dr. Sekhar Patil to come and take the chair. Sir. Sir, older card, it's not only Maruti, but also Ambassador was there, which is strong. Anyway, sir, after hearing to this newer AEDs, what is your take on older AEDs, sir?
Sir, definitely sodium valproate is one of the drugs still commonly used. Carbamazepine also is very commonly used. Maybe the phenobarbital and phenytoin we don't see in the cities much commonly, but I think, sir, you work in Vizag, and when you see people coming from rural areas, still many of them use it. And if somebody is well controlled on phenytoin or phenobarbital without any side effects, most often we will not change the drug in those people.
Yes, that is true. Sir, how about you, sir?
So looking at the newer one.
No, he is
Oh, Yeah. So for me, I would agree that older generation medicines, they're still the best. Sodium valproate, number one for generalized epilepsy. I would say that yes, carbamazepine would be still used for focal epilepsy, but most of bulk of preparations coming from rural would be phenobarbital and phenytoin still. And if I agree with him, if there are no side effects which are noticeable, the cosmetic ones, I don't think anyone would have the guts to change the prescription.
There's probably one entity where drug level monitoring becomes a challenge with the newer anti-epileptics. What are your thoughts? Both of you can probably tell.
So honestly, I personally do not really use therapeutic drug monitoring unless and until I'm looking at the toxicity. So if I would probably from the old school that way. So I do not use it on a regular basis, look at specific situations to use it because yes, one is also the cost. So if I keep on doing it regularly, I'm adding to the burden. So I would look at if I'm sure that I'm administering just to check the compliance once in a while and toxicity.
And also with the seizures which are being labeled as drug refractory epilepsy. Have you found any articles where DRE levels were much higher before the newer anti-epileptics came into the market? And is there a drop in the number of people, the percentage of people with drug-resistant or refractory epilepsy once the newer ones are in the market? I'm sure the logical answer would be yes, because the newer anti-epileptics is probably solved to some extent the epilepsy burden and the refractory status.
I think that definitely we have seen. So if you look at the last 30 years, the drug-resistant epilepsy percentage has come down. It has not come down to a great extent, but maybe 5 or 10% more than when we, let's say, for 20 years back, 25 years back. So there is improvement in that, but still about 25 to 30% people, they keep coming back with recurrent seizures, despite being on, 3 or 4 anti-seizure medications.
So I showed a graph where we had started off with 1 and we moved up to 7. So even at 7, we are not breaching that 70%. So yes, from 64, you've come to 70, which is a good achievement. But probably the number of medicines that you need to try and the different combinations, get it right. So many medicines are there. So you may not get the combinations also right. And sometimes at the end of the day, probably you may actually move medicines which are probably should not be used in the first place.
You mentioned about the SANAC 1 and 2. But there was one very simple trial was Conquest, which looked at only the feasibility, the drug, the finances involved with the drug. So they discourage the newer anti-epileptics purely based on the money involved.
But yes, that's one aspect is we should try to protect our patients from that. But I don't think if it's something which you really believe that this should be tried and it is going to help your patient, that should not hold you back. Because finally you are just offering that it is a costly medicine. The ball is in his court to decide on it.
Audience, please.
Sorry. So many times in status epilepticus, I'm asking Dr. Sudhir, we have used levetiracetam, lacosam, whatever injectables are available, and ultimately they respond to Gardinolone. So what's your take on that?
I think, Madam, you have brought out very important fact. And Dr. Shekhar also mentioned that point, that many times we start using the newer anti-seizure medications. Like now routinely in our emergency, we see that emergency physicians, they start injection levetiracetam by default, even though it is not the drug of first choice for either partial or generalized seizure. But I think you have to thank the marketing team of various pharma companies. So they have forgotten that sodium valproate is the drug of choice. And once somebody is already on medication, it's difficult to change that in the OPD also, even for men patients I'm talking, not only women. So, and we have seen that. So we have seen cases where patients have failed newer anti-seizure medications and finally they respond to phenobarbital. That is well known. And sir pointed out in the neonatal epilepsy, definitely it is one of the drugs which is recommended. But adults also, we see occasionally patients who respond to phenobarbital after failing other drugs. It's not a very common situation, but occasionally we do see. Dr. Mishra sir wants to say.
Yeah, I think, when you say newer anti-epileptic drugs, no doubt benzodiazepine, phenytoin have been used always for a long time, and we have a lot of experience. But as time passes, the receptors are internalized, and then, you have to use newer drugs. And especially if the patient got sepsis, because the danger of using valproate, danger of using older anti-epileptic drugs is cardiotoxicity, hypotension, immobilization. So we have to use, especially if the patient got sepsis or systemic disorders. So there we have done trials on all, lacosamide, valproate, and levetiracetam, and seen personally, if a patient got multiple sepsis or multi-organ failure or hypotension, in that case, the newer drugs have to be used. And then, using benzodiazepine and phenobarbital for a long time produces hypotension. So therefore, that has a place, in my opinion. So I thought.
Dr. Mishra had published one of the first randomized trials comparing sodium valproate in the status epilepticus. And he showed that it was quite effective compared to the previous protocols. Regarding phenytoin, we remember from our DM days, extravasation of the injection, and many patients used to come back with thrombophlebitis, and that would trouble them more than the seizures, initial seizures, for the next several weeks. And occasional patients where the emergency physicians have pushed the injections, that's very rare. But I remember seeing few patients of cardiac arrest also, where because of phenytoin, the infusion rate was faster than the recommended dose.
So in my opinion, unlearning is more difficult than learning. So what people have done in their early days, given phenytoin and Gardinal initially, so that persists. And in many ICUs, you see that because of the habit and reflex, these drugs are used as a routine. And then, it is very difficult to introduce newer drugs. So I think we should all make effort to use the rational drugs as it indicated.
Just a quick comment. I'm Dr. Madhuri, consultant epileptologist at Apollo Jubilee Hills. Excellent talk, both the speakers. I must congratulate you. I would be making a couple of quick comments. So I would second Dr. Mishra's opinion about the novel mechanism of action that the newer anti-seizure medications offer, especially for these drug refractory epilepsies, for example, perampanel targeting the AMPA receptors, or in cases of Lennox-Gastaut syndrome, wherein fenfluramine and the cannabidiol do have novel mechanism through the serotonergic pathway, and drugs, newer anti-seizure medications such as cenobamate, which I was very lucky to practice while being in England, has been extremely effective, having a novel sodium channel plus glycinergic and serotonergic mechanism, and it's extremely rewarding practicing prescription of cenobamate as well as brivaracetam. A couple of points on the older anti-seizure medications, sodium valproate, as we keep on talking about the role of sodium valproate in women. But in UK now, they have banned prescription of sodium valproate in males of reproductive age group, which is very important because it can have significant consequences related to infertility as well as malformations in the offsprings. Thank you very much.
Please talk into the mic, sir. You're not audible.
Just one quick comment, that is all. I'll take your views also on this. What is new and what is old is completely subjective, as you correctly said. I'll tell you why. Levetiracetam comes in the newer anti-seizure medication. But the day brivaracetam came into the market, there is not one company who have told me that if you take levetiracetam, you'll become mad. Either the patient becomes mad or the doctor is mad. So it's just something we knew that there was some psychotic side effects, but you tell me how many times it has been discussed in the forum before brivaracetam came to the market. Just your comments on this.
From a marketing standpoint, that would not be highlighted at all. But in the clinical domain, I think we all were aware and we have been discussing the role of psychiatric comorbidities and psychiatric features related to levetiracetam, and it is a true thing. So, I mean, as clinicians, we were aware, but just not being marketed by the companies.
I think, Dr. Miyashki, we have been seeing and we have noted also, one of the earliest days, maybe in 2005 or 6, that time. So one mother came with her son, and her request was just somehow, give something so that he dies. Very few mothers will even say this. And the fact was that he was a very, very somber and well-mannered kid. and who had become totally psychotic. He was abusing, cursing, hitting mother and everybody at home, and she was so disturbed. And that time it was not very well known that levetiracetam can cause this kind of severe psychotic reactions. And then we just had to stop that and shift to another drug, and then he had changed. And in the ICU patients, after the emergency physician started giving IV levetiracetam, ICU psychosis rates went up in the patients with seizures. And then one thing required was just to change levetiracetam to sodium valproate, and psychosis disappeared. So as clinicians, we had noted that, and we have been telling our residents also same, keep watching for behavioral side effect. But yes, marketing teams are different. Their aim is to increase the sales of the new products, so they will never focus on that.
Point taken. I think any more questions? Yeah, please.
So we often come across this situation wherein levetiracetam may not offer a complete seizure freedom in these patients with drug refractory epilepsy. And I've seen at least half a dozen patients when we do say that brivaracetam is more effective, is more efficacious, but I have at least seen half a dozen patients wherein I had switched them to brivaracetam and the seizure control dropped down, and had to bring them back to levetiracetam. So I mean, just assuming that it has a better seizure control doesn't mean that, the levetiracetam being an older anti-seizure medication can be sometimes more effective in comparison with brivaracetam as well. Thank you.
I think seizure control is not better. That's what we have seen. But maybe those were behavioral side effects. It may be lesser with brivaracetam.
Neurosurgeon, can I ask you, the whole panelists and everybody neurologists here, what would be the best scenario for perioperative anticonvulsant as of today? I know that it's very easy for us, many of us who have got people like Satish Chandra to just, form it off onto them. What would you think is an ideal thing? It means in the perioperative period, we want something injectable, and we have lots of other issues with especially head injury patients coming with irritability.
If you ask me the practice pattern, it's levetiracetam. But if you were to choose, probably you could actually go for any of the wing. Even for that matter, phosphonatoin is fair enough. I mean, you can actually do away with the extravasation altogether.
Thank you.
Just to add to Dr. Madhuri's, views, actually, we have seen a lot of consultants switching from levetiracetam to brivaracetam for no reason, just because it's a new molecule. At least seizure control, I had at least 3 or 4 patients having breakthrough seizures when they were switched. So, my view is, if patient is tolerating well levetiracetam, and if there are no other issues, I don't think there is any need to change. That may be a market pressure, but definitely there is no need to change if patient doesn't have any behavioral side effect.
We can have one last question before we conclude the session.
Regarding your question, which is the best drug for a neurosurgeon? Phenytoin has the role for provoked seizures and for head injury. It has been shown to be the evidence. Doing a new trial for a new drug with sufficient number of patients is a difficult thing. I mean, for brivaracetam versus levetiracetam, you need to have a head-to-head trial. But if you do that trial, who will sponsor that? Nobody will sponsor. Only an academic institution can answer that question, and the result may be negative. So who will publish that? So therefore, these are the problems. So those questions either we have to take up head-to-head comparisons in a sponsored. But the pharma company is not going to support this type of study. So we have to make our own observations and decide which one is better. But certainly for a provoked seizure or for head injury, phenytoin has been. Now it's the question of doing another trial in head injury patients with newer drugs. So it needs support. Is there a financial advantage to that or not? Therefore, these studies are not done. So there is a limitation.
Purposely asked this for the sake of the younger ones. In fact, I don't think in any of the emergencies where it's available today at all, phenytoin. Younger generation, they would laugh at me if I asked them what you have started off. This is what exactly is happening. And sometimes I'm made to believe that whether this has to be thrown out of into the dustbin. Still it works because they are all influenced by the newer medication.
Thank you, sir. So behind every Rishabh Pant, there has to be an MS Dhoni. Behind every new anti-epileptic, there has to be a time-tested older drug. And I'm sure as clinical neurologists, all of us have used a combination of both the older and the newer anti-epileptics, and each of them have their own pros and cons. And with this, let's conclude the session. Thank you, both of you, for giving such a illustrious talk. Thanks.
Good. Thank you, chairpersons and dear speakers. May I request you to join for a group photo session? I request Dr. Satish Chandra, Dr. Ravi Mohan Rao, and Dr. K.N. Krishna to join. So with this, we conclude the first session on epilepsy. Now we will break for lunch and we'll reassemble at 1:45 p.m. sharp. The second session is on movement disorders. So Yeah, playing, yeah, that's okay. I just seeing the slide.
So, good afternoon, esteemed professors, distinguished faculty members, dear colleagues, and honored guests. Now, welcome to the afternoon session, the movement disorder session of our conference. So, from Parkinson's disease to dystonia, our discussions will delve into the latest research, innovative treatments, and compassionate care for those living with these disorders. So, it is with great honor and privilege that I would like to introduce the chairpersons for our movement disorder session, Dr. Subhashini Prabhakar, ma'am. I think ma'am will join in a few minutes, and Dr. Vishwanathan V, sir. Dr. Vishwanathan V, sir, is a member of the IAN, the British Pediatric Neurology and the Association of Child Neurology in India, has multiple publication and presentations in national and international conferences, multiple book chapters, and he's been a principal investigator of the NIH of the USA and the European clinical trials for over 22 years. Welcome, sir.
Thank you. Thank the organizing team for inviting me to chair the session. It's an honor, really, indeed. I hope we'll get more audience shortly. I think with the explosion of the knowledge in genomics and the rapid advances in the understanding of the metabolomics and well laid out pathways of the mitochondrial or mitochondrial pathways, we understand that the phenotypic variability and the expression can occur from newborn to adulthood on the environmental influences, as well as the environmental, shall we say, influences as well as the pressures, as seen in disorders like dopa-responsive dystonia, cerebellar ataxia, or riboflavinopathies, where you find there's a whole spectrum starting from newborn to adulthood, where you can actually get the varying expression of the movement disorders. So with that brief introduction about movement disorders, I would like to invite the first speaker. May I? I don't know who is the first speaker, please.
Dr. Sandeep Nayani is the first speaker.
Sandeep Nayani.
Here it is there. It's in the.
Okay, Dr. Sandeep Nayani is a senior consultant neurologist, Apollo Health City, Jubilee Hills, Hyderabad. And his interest is in movement disorders and autoimmune neurology. I request you to go ahead and give your talk. Tremors Revisited.
Thank you, sir. Thanks to all the organizers for giving me this opportunity. I'll be talking about tremors, mainly with respect to the different phenomenology of tremors, how to identify different types of tremors, and how that will help us in managing patients with tremors. So the scheme of presentation will be the definition of tremor, various types of tremor, the IPMDS classification of tremor, major conditions presenting with tremor, and how to examine a patient with tremor, especially to help the residents with examination, and brief note on the management of tremor, both pharmacological as well as various advanced newer techniques. So tremor can be defined as an involuntary, rhythmic, and oscillatory movement, which may involve one or several body parts. So each of these words is important because it is supposed to be involuntary, it is supposed to be rhythmic and oscillatory. That's how when we examine someone having a tremor, that's based on these characters, it is how we label it as a tremor rather than any other movement disorder. So it is one of the most commonly observed movement disorder in adults, probably the most common. And it can be a manifestation of an isolated disease, isolated manifestation of a disease like we see in essential tremor, or it can be part of various other neurological diseases where tremor is also one of the components. So there are various ways we can classify tremor. We can classify it based on the frequency into low frequency or high frequency tremor. We can classify it based on the part that is affected, like into limb tremor, head tremor, vocal tremor, or chin tremor, or probably the most useful way for us to differentiate different type of tremors is by classifying them according to the activation pattern into two broad categories, that is rest tremor and action tremor. So if we further subclassify rest tremor and action tremor, so rest tremor, it may be an isolated rest tremor, or most commonly it is associated with dopaminergic deficit like we see in Parkinson's disease, or it may be a component of a dystonic tremor. Action tremor can be of three main types, like postural tremor, kinetic tremor, and isometric tremor. A postural tremor may be again divided into something like position dependent tremor or position independent tremor, which will be seen in all various postures. Kinetic tremor may be a simple kinetic tremor, or a simple kinetic tremor that we notice when we do a finger nose test. It may be a task specific tremor, which will be specific only to a particular task like writing or singing or playing a musical instrument. Then there is intention tremor, where the tremor appears on approaching the target. Then there is a third category, that is isometric tremor, where the tremor is usually prominent on holding a fixed weight in the limb without moving the limbs. I'll be describing each of them. So then we have recent International Parkinson and Movement Disorder Society classification into two axes to better understand the various tremors. So axis 1 will tell us the various clinical features, the history and tremor characteristics, which help us in identifying what disease it is and what type of tremor it is. Then axis 2 will be mainly dealing with etiology as to what is the cause of the tremor, whether it is Parkinson's disease, whether it is essential tremor, or whether it is dystonic tremor. So etiology, the focus of axis 2 will be on etiology. So if we look at various types of tremor that we like come across based on the type of activation. So rest tremor, we call it a rest tremor when the affected body part is fully supported against the gravity and is not actively contracting. So like if we see in this picture, the both hands are resting completely on the thighs and the limb is not actively contracting. So rest tremor is something that gets diminished or absent during voluntary muscle activation and during movement. So that is how a rest tremor appears. Whereas action tremor again can be postural, can be kinetic, or can be intention tremor. Or it can be an isometric tremor. So action tremor, postural is where the like we see in the first picture here. So postural tremor is something that is evident on maintaining an anti-gravity posture, either with arms in front of the chest, like in this picture, or in a wing beating position with shoulders abducted and elbows flexed and palms facing down. So a wing beating position, or in this position, we usually look for any postural tremor. Kinetic tremor, we most commonly do finger nose testing, or we can also make the person draw spirals, or more practically, maybe make them like pour a water from one glass to another, or drink water taking a cup in hand. So if there is tremor in the initial part of the movement, it can be described as an initial tremor. During the course, it may be a dynamic tremor. And when it is approaching the target, if the tremor is becoming more prominent or appearing at that time, it can be labeled as an intention tremor. So, and then we have task-specific tremor and isometric tremor, which I have just discussed. So task-specific is mainly only it has to appear or get exacerbated mainly during a task. And isometric tremor is voluntary contraction of muscle not accompanied by change in position of the body part. As we notice, one of the classical examples would be an orthostatic tremor. So, like other ways in which we can classify based on the distribution into whether it is affecting the limbs or whether it is affecting the head, tongue, voice, or trunk. So again, because of the complexity of the limb tremors, it is best to describe across which joint the tremor is oscillating and it is most evident. So maybe we can describe it as it is more across the metacarpophalangeal joint or at the wrist or elbow or ankle. So that gives more specific information. If you look at tremor frequency, most of the tremors that we see, most of the various conditions in which we see tremors, they are in the range of 4 to 10 hertz. But there are exceptions, like we see cerebellar tremor, which is a much lower tremor. Frequency is only 2 to 3 hertz. And also in brainstem pathologies, we see myorrhythmia, which is again a very slow tremor. There are again exceptions on the faster side also. We may see fast, high frequency tremors in conditions like orthostatic tremor, where the frequency is much more like around 13 to 18 hertz. So if we briefly discuss the common conditions that are presenting with tremor. So the most common and most important condition would be an essential tremor. And there are a lot of changes taking place in the definition of essential tremor, what constitutes an essential tremor, what does not constitute an essential tremor. So previously, people who had other soft signs were also classified as essential tremor. But now, according to the new definition of essential tremor by the Tremor Task Force, It should be an isolated tremor syndrome manifesting as an action tremor of bilateral upper extremities. It should definitely be bilateral, even if it is asymmetric. The minimum duration should be 3 years, and there should be no other neurological signs like Parkinsonism or ataxia or dystonia. It may or may not be associated with other tremors involving head, voice, or lower extremities. And the classical frequency of action tremor in essential tremor is 4 to 12 hertz. So now, because of this, we have an ET and an ET plus. So whatever previously we used to say some soft signs like ataxia, mild cognitive impairment, or mild dystonic posturing, those patients whom we classified previously as essential tremor are now called ET plus. So because of that, the number of patients, if we look at it, probably ET plus patients will be much more, because the pure ones probably are lesser in number than the ones who have subtle signs, subtle soft signs. So, how does tremor appear in essential tremor? What is the classical tremor description in essential tremor? So, obviously, we look at both postural and kinetic components. So, like this, I think this we have already discussed, where the position in which we check the postural and kinetic tremor. So, the important point is tremor in both upper limbs usually has similar frequency, but can have different amplitude. And alcohol responsiveness is one thing which is asked for and looked at as an important finding in essential tremor. So the tremor in essential tremor, the cardinal feature is kinetic tremor is much more prominent or larger in amplitude than a postural tremor. So amplitude of kinetic tremor exceeds that of postural tremor. There may be mild asymmetry between the limbs. And up to 50% of patients may have an intention tremor. Postural tremor at wrist is usually of flexion extension type in an essential tremor in comparison with Parkinson's disease, where you have more a rotation or pronation, supination type of tremor. So sometimes it may be difficult in early stages to differentiate between an early Parkinson's disease or an emerging Parkinson's disease and essential tremor. So whenever someone has an isolated postural tremor, or postural tremor being more prominent or more prominent than a kinetic tremor, or kinetic tremor not being that prominent, we have to suspect, we have to watch carefully for development of other PD signs, because it may be an emerging PD rather than an essential tremor. And also, if postural tremor is predominantly involving the MCP joints rather than the wrist, that also is one factor that it may be more likely to be PD rather than an ET. And like I just said, if rotation at wrist is more in favor of PD, whereas flexion extension at wrist is more in favor of ET type of tremor. So I'll just show a video of how essential tremor looks. So here, yeah, like there is a definite postural tremor, which is slightly more on the right side than it looks much more on the right side than left side. There is a clear kinetic tremor. And if you look at it on the left side, there is clear kinetic tremor with some intention component also, as the limb is approaching towards the finger of the examiner, there is some intention component. So this is how, like, usually we notice essential tremor presenting with postural and kinetic tremor being more prominent than postural tremor, with some people having an intention component as well. So in essential tremor, usually tremor worsens over time It can also have motor and non-motor manifestations. Of course, now the newer classifications probably will not allow these to be classified as a pure essential tremor. But generally, subtle dystonia, subtle ataxia, and Parkinsonism may develop over a period of time, which may probably have to be labeled as an ET plus now. And even essential tremor may have some non-motor features like cognitive impairment, apathy, depression, and anxiety, and sleep disturbances developing over a period of time, which are different from what we see as a non-motor manifestations in PD. Pathogenesis of essential tremor, it is thought to be mainly involvement of the cerebello-thalamocortical circuit. Whenever there is family history, it is usually autosomal dominant, but there is no single gene that is responsible for essential tremor. So there are other isolated tremor syndromes. So according to the new definition, we call ET when the duration is 3 years. But what about cases that are having classical features of ET, but the duration is still not 3 years, it is only 1 or 2 years? We have to label it as an indeterminate action tremor syndrome for the first 3 years, and only afterwards we can call it essential tremor according to the new definition. Sometimes like some other conditions like DYT24 or SCA12 may initially present as just as a postural tremor, but subsequently develop things like dystonia and ataxia. So we have to watch for those, especially in the initial stages. Similarly, sometimes the rest tremor of PD may present as just tremor without any bradykinesia. At that stage, we have to probably call it as monosymptomatic rest tremor and then watch for development of signs of Parkinsonism like bradykinesia and rigidity. So coming to enhanced physiological tremor. Enhanced physiological tremor is something that can be observed in normal individuals during enhanced muscle activity, such as while exercising or immediately afterwards. It's probably related to increased sympathetic activity. It's a form of action tremor, which may not be visible to naked eye because its amplitude is low and frequency is high. So usually involves the differentiation. One way to differentiate is usually involve both hands and all fingers symmetrically. And it's probably the most commonly observed postural tremor because it can be seen in many people during anxious conditions or after exercise. So a sheet of paper may be placed on the outstretched hands to amplify the tremor and make it more evident with essential tremor. So there are other types of tremor like Holmes tremor, which we see in lesions of cerebellar outflow pathways, particularly superior cerebellar peduncle near the red nucleus. So it has all three components that is in addition to rest and kinetic tremor, it will also have a tremor at rest because of the interruption of nigrostriatal pathway. So it was described in 1904 by Gordon Holmes. It's a low frequency rest tremor which gets accentuated by posture and intention. So what we see is a rest tremor which gets exacerbated during maintenance of posture, and which gets further worse during performance of any movements. So it is usually predominantly unilateral, and there may be other signs like ataxia and bradykinesia, ophthalmoplegia. So most common conditions are like tumors, trauma, and multiple sclerosis conditions affecting either brainstem or cerebellar outflow tracts may cause Holmes tremor. So we have tardive tremor, which we see after the usage of neuroleptics. Again, this can be both rest, postural, and kinetic tremor with a frequency of 3 to 5 hertz. And it can persist even after the neuroleptic withdrawal, but it improves with treatment with tetrabenazine. So it may accompany other tardive movement disorders like akathisia, chorea, dystonia, myoclonus, and stereotyping. If we briefly look at task-specific tremors, we have tremors that emerge while performing or attempting to perform a specific motor task, which are not seen in the rest of the activities. So we have primary writing tremor, in which we may see some mirror dystonia in the opposite unaffected hand. But sometimes these people may later develop Parkinson's disease-like features, so we have to watch for that. Orthostatic tremor is a high-frequency tremor of the legs upon standing. So the main feature is high frequency, low amplitude. So sometimes it may not be visible to the eye. So we may have to do a surface EMG to confirm. So again, palpation and auscultation of the leg muscles may reveal presence of thrill and a continuous thumping sound called as a helicopter sign. So the patients report unsteadiness of gait. They may present more like their imbalance of gait, and they're very uncomfortable when they are standing. They are better when they are sitting or when they are moving. So especially there are rare conditions where there may be a slow orthostatic tremor, and that can result in much more unsteadiness and even falls. I want to play a video of a patient with orthostatic tremor. This is here the amplitude is quite significant, but many times we may not see such significant limb movements. It may be mainly patient manifesting with imbalance, and we may have to find it mainly on EMG. So then we come to the important condition of tremor associated with Parkinsonism. So we all know that that tremor of Parkinson's is mainly a rest tremor, which is the hallmark. It happens, it is seen in 75% of patients with PD. It is typically asymmetric, has a frequency of 4 to 6 hertz, commonly involves the hands in a pill rolling pattern, that is the classically described one, and often exacerbated during walking or while performing physical tasks or mental tasks. There is inhibition of tremor during voluntary movements. So we see something called as a re-emergent tremor, where tremor subsides immediately on when the limb is moved, but again re-emerges after a gap of few seconds. So there are some paradoxical aspects regarding rest tremor. There is lack of correlation with the degree of nigrostriatal degeneration. I think I have a few more slides. I'll just finish quickly. There is resolution of rest tremor in some patients with progression of disease, which is a paradoxical finding. And there is inconsistent response to levodopa, which again is a paradoxical thing about the rest tremor. It may even though there is no response to levodopa, it may respond well to DBS. So I'll just play this one video. A patient with Parkinsonism, she actually has atypical Parkinsonism. So she has rest tremor, which on maintaining posture, it disappears, and again there is re-emergent tremor. So dystonic tremor is like a condition in, again, there are two types of dystonic tremors. One is a dystonic tremor in which the tremor is seen in the same limb that has dystonia. And there is tremor associated with dystonia where non-dystonic body part may show tremor. So how do we differentiate dystonic tremor from an ET, essential tremor? Irregularity and variability in frequency and amplitude. So we classically say tremor is rhythmic and oscillatory. So a dystonic tremor may not exactly be a rhythmic or oscillatory tremor. It will be irregular. There may be a spooning posture of the upper limbs where there is flexion at the wrist and hyperextension at the metacarpopharyngeal joints. That is again typical of dystonic tremor. Maybe things like improvement with sensory trick and disappearance of tremor at null point where the dystonia is maximum. These things will help us in identifying dystonic tremor. I'll skip the video because of the lack of time. So one important condition which may trouble us sometimes is psychogenic tremor. So whenever there is abrupt tremor onset, waxing and waning history, if tremor is equal both at rest, posture, and action, then we have to suspect it's probably not organic. If there is involvement of non-contiguous body parts, and if there are periods of remission, abrupt remission and abrupt increase, then also we have to suspect. So distractibility, suggestibility, and entrainment. So sometimes distractibility is when the tremor may suddenly reduce when patient is distracted. Suggestibility with when you suggest the patient that she may have tremor by doing some maneuver, patient may actually manifest tremor. And in entrainment, the frequency of the tremor of the movement of the limb, frequency of the tremor may change when we ask the patient to perform a different frequency of movement in the other limb. I'll just show this one last video. So here, the patient is having some tremor in the left upper limb, but when she is asked to do a movement in the right upper limb, of a certain slower frequency, the tremor in the left upper limb is also changing. So briefly examining a patient with tremor, we have to, I think it's already been discussed, we have to look at patient at rest, posture, action, and while performing specific tasks. Note the dominant frequency, note the amplitude, observe for any change and make them do Archimedes spirals. Especially look for bradykinesia, look for any abnormal posturing and postural instability, gait ataxia, cerebellar signs. So Archimedes spirals are very useful because in dystonia, it will be the direction of it will be multidirectional because it's not a regular tremor, whereas it will be unidirectional in essential tremor. In Parkinson's disease, we may see a small spiral without much of, if there is no tremor while drawing, we may not see much of jerkiness in the spiral. So treatment, I just want to conclude with one slide commonly, I think everybody knows this. So we use, for Parkinson's, we use levodopa, dopamine agonists. Of course, trihexyphenidyl and amantadine may offer more symptomatic benefit for tremor. And for dystonic tremor, we use trihexyphenidyl. Cerebellar tremor sometimes may be difficult to treat. Primidone, carbamazepine, and levetiracetam are tried. Orthostatic tremor is also one more condition which is difficult to treat. We try clonazepam, gabapentin, and levodopa. So this is essential tremor. We all know that the two main pillars are propranolol and primidone. We have to try the correct doses if there is no response to the initial smaller doses. So these are the ones that are found to be mainly efficacious, and topiramate may be tried when those two fail or are not very useful. DBS, obviously for medically refractory tremor, DBS is an option, both in PDA as well as ET. The target will be ventral intermediary nucleus of thalamus.
I think we are running
Okay.
overshooting.
Okay, I'll conclude with that.
Yeah,
Thank you.
Thank you, Sandeep. It was exhausting.
Sorry to.
I think since we have overshot the time, we'll skip the question answer session, move over to the next one.
Thank you.
It's on restless leg syndrome, recent concept by Professor Agati. While we're waiting, if there are any questions to Sandeep, we could probably discuss that.
PowerPoint
Yes, sir. Please, sir. No, sir. No?
Thank you for a wonderful talk. Question on treatment of this emergent tremor. Do you think emergent tremor is just a resting tremor in a different position, or it's an essential tremor superimposed on a resting tremor? Because I find that unless you add a beta blocker, the emergent tremor doesn't go away. We use trihexyphenidyl for the resting tremor. But the moment they have a emergent tremor, that is really disabling for the patients. Because when they hold their phone, it is really shaking. And you ask them to put their arms, after some time it shakes. So is trihexyphenidyl enough, or do you also add a beta blocker?
Probably emerging tremor is a rest tremor only manifesting again. So probably we have to treat it like how we treat a Parkinson tremor rather than with a beta blocker like an essential tremor.
So usually I end up putting a beta blocker. They don't do well only with it is what I have seen.
Okay.
Thank you, sir.
Thank you.
So we move on to the Professor Agati's talk. Can we have the slide, please? Yeah, Professor Agati is a well-known neurologist in Bangalore. It's huge experience in this field. And without much any other, let me go ahead and request him to kindly deliver a talk, sir.
Thank you, Chairperson. Ellargu namaskara. I bring greetings from Apollo Hospital, Sheshadripuram, Bangalore. At the outset, I thank the organizers of Apollo Conclave 2024 for having given me an opportunity to speak to you on the topic of restless leg syndrome. It was Sir Thomas Willis, an English physician in the year 1672, who first described about the clinical features of restless leg syndrome. Those days, there was a fashion of treating majority of the illnesses with bloodletting, and most of these patients developed iron deficiency anemia, and as a part of that, they were having symptoms of restless leg syndrome. But later, in the year 1945, it was Dr. Carl Axel Ekbom who described in detail all the clinical features of restless leg syndrome, and it was the subject of his thesis that is submitted in 1945. How common is this disease? 5 to 15% of the population have this problem. But surprisingly, in Taiwan and Japan, the prevalence is to the tune of around less than 2%. In India also, it is mentioned that it is to the tune of 1 to 3%. It can happen at all ages, more prevalent in women. There is a family history in about 60% of patients, and there is a high concordance rate in monozygotic twins. It comes with the comorbidities like insomnia, major depressive disorder, anxiety, attention deficit hyperactivity disorder, and cardiovascular disease. I did not know till I was asked to talk about this particular topic that it can be associated with the occurrence of the ischemic heart disease. Up to 80% of these patients can have periodic limb movements of sleep. Be careful whenever you encounter a patient with restless leg syndrome, please ask the history of all antihistamines, antipsychotics. See, dopamine antagonistic medications like Perinorum, Domstol, Stemetil. So please ask about the history of intake of these medicines. Then antipsychotics like Serenase, Oleans, Kutipin, Respond. Then antihistamines like cimetidine. Most of the antidepressants, tricyclic antidepressants, on the one hand, you try to treat this restless leg syndrome, but you forget as to what is the offending agent, will not be doing justice to the patient. Most of these tricyclic antidepressants, selective serotonin and selective noradrenaline and reuptake inhibitors, anti-epileptics, remember zonisamide and phenytoin, and not to forget tramadol is used for the treatment of restless leg syndrome, but surprisingly, I found that it's mentioned as one of the drugs which is likely to precipitate restless leg syndrome. There are diagnostic criteria. You remember this urged. Urged stands for the urge, rest, getting up, evening, and do not occur because of other diseases. I'll just read you the essential criteria for the diagnosis of restless leg syndrome. Criteria 1, an urge to move the legs, usually but not always accompanied by uncomfortable sensation in the legs. 2, the urge to move the legs with any accompanying unpleasant sensations begins or worsens during periods of inactivity and quiescence, such as lying down or sitting. The urge to move the legs with any accompanying unpleasant sensations is partially or totally relieved by movements such as walking or stretching as long as the activity continues. The urge to move the legs with accompanying unpleasant sensations during rest or inactivity only occurs or is worse in the evening or night during the day. And the above features are not accounted for by any other medical or behavioral conditions like myalgia. These are all the conditions which are likely to mimic restless syndrome: myalgia, arthritis, venous stasis, leg cramps, positional discomfort, and habitual foot tapping. The following features will support the diagnosis of restless leg syndrome. One is 80% of these patients can have periodic limb movements of sleep or periodic limb movements during wakefulness. A response to dopaminergic treatment, at least initially. Be careful about these dopamine antagonists when you are treating RLS. I'll come to that later. They have a positive family history. I told you that it's about 60% of these patients can have, and lack of profound daytime sleepiness. There are certain clinical courses for RLS. One is intermittent RLS. If a patient has got less than 2 episodes of RLS in a week, it is called as intermittent RLS. Whereas chronic persistent is if a patient has got more than 2 episodes per week. So I told you that it has an autosomal dominant pattern with anticipation, and it has got an autosomal recessive mode of inheritance also. These genome-wide association studies have found associations between at least about 13 genes are implicated in the pathogenesis of this restless leg syndrome. What causes RLS? Iron is an essential factor for the enzyme tyrosine hydroxylase, which is involved in the synthesis of dopamine. Iron deficiency leads to D1 and D2 receptor expression in caudate and putamen. Majority of patients with renal disease and pregnancy, they can have RLS. MRI has demonstrated decreased iron in the striatum, substantia nigra, and thalamus. And it is said that the brain iron levels fluctuate during the daytime also. There is low iron in the CSF. Dopamine production has a circadian rhythm with decreased production in the evening. That is how there is a circadian rhythm of the occurrence of these symptoms of RLS. Dopamine agonists initially correct this deficiency, but enhance the downregulation of dopamine receptors, which then leads to augmentation over time. I'll tell you about the augmentation a little later. There is increased cerebral glutamate and decreased adenosine. Parampenil is one of the anti-epileptic drugs that can be used in patients with restless leg syndrome based on its action on the glutamate. There are a few case reports of the use of parampenil. Dipyridamole, which is an anti-epileptic, anti-platelet drug, because it enhances the brain levels of adenosine, and it's implicated that lower levels of brain adenosine are causing these RLS. So dipyridamole and parampenil these are the 2 new drugs which are being thought of as a treatment for restless leg syndrome. What do these patients complain of? The moment they hit the bed or the moment they sit for about 10-15 minutes, imagine if you are to catch a flight from Bangalore to San Francisco, or you have to take an overnight bus, or you have to sit quietly in an interview, or in a discussion or a board interview, or in a movie theater. So these are all the situations wherein they have the utmost difficulty in resting. They complain of crawling, creeping, pulling, itching, drawing, or stretching in the legs, worsen towards the end of the day, and are maximum at night, occur within 15 to 30 minutes of reclining in bed. In severe cases, the symptoms occur earlier, and sitting is horrible, as I just now told you. Arms may be affected. I was interested in knowing, just because we talk about restless leg syndrome, is there anything called as restless arms syndrome? So there have been about 10 case reports of restless arm syndrome in the literature. But surprisingly, I came across the fact that it can affect the face, the trunk, genitalia, and upper limbs as well as the lower limbs. These are all the body parts which can be affected in restless leg syndrome. These patients are forced to get out of the bed, pace the floor to relieve their symptoms. 80% of them can have periodic movements of sleep. Usually, the physical examination is normal. Look for signs of radiculopathy, look for signs of peripheral neuropathy, and look for signs of parkinsonism, because there's some of the associations. And I just now told you about what to look for in these patients. There could be secondary causes. Iron deficiency is the most important, and end-stage renal disease, diabetes, rheumatic disease. There is a surprising to know that there is a higher association between restless leg syndrome and immune-mediated disorders, right from your dyscologenosis, multiple sclerosis, irritable bowel syndrome. Surprising to know that there is an association between RLS and these things. Venous insufficiency, folate or magnesium deficiency, amyloidosis, lumbosacral radiculopathy, fibromyalgia, and celiac disease. Some of these could be associated with the restless leg syndrome. So when you evaluate, take the history of nocturnal cramps, which can happen in the majority of the normal individuals also. Look for varicose veins, look for arthritis and myalgias. I told you all antipsychotics, antihistamines, so antiemetics. So please take a thorough history. Do the iron studies, because there is a relationship between serum iron levels and the occurrence of restless leg syndrome. In the fasting, so you should do the iron studies in the fasting state. Look at the serum ferritin level and transferrin saturation levels.
it is see, there could be a false rise in the serum ferritin levels. As you know that serum ferritin is an acute phase reactant. So look for inflammatory conditions which can give rise to a rise in the serum ferritin levels, and and correlate with the serum transferrin levels also. How are we going to treat these patients with RLS? Give iron if the serum level is less than or equal to 75 nanograms per ml. It is the serum transferrin levels and the serum ferritin levels. It is the serum transferrin level less than 75 or equal to, and the transferrin saturation less than 20 to 25. If they are there, these are the candidates who require iron. Can be given orally, or even you can use a low molecular weight iron dextran carboxymaltose 1000 milligrams infused over 1 hour. Please do a test dose with 25 milligrams of that, because there could be anaphylactic reactions. Soon after giving iron, the patients will not improve in their symptoms. So it may take about 2 to 6 weeks for them to show improvement. Dopamine agonists, pramipexole, ropinirole, rotigotine. Pramipexole can be started with 0.25 milligrams. Gradually go up to 0.5 milligrams. Please don't make the mistake of increasing these dopamine agonist agents if the patient comes back with recurrent symptoms. The maximum you can go with for pramipexole is 0.5 milligrams only. Same is the case with ropinirole. Start off with 0.25 milligrams and go up to 4 milligrams. Don't make the mistake of increasing this dosage. Rotigotine patch, it's a long-acting dopamine agonist, and it comes in the form of a patch. So different sizes. It should be applied over the body. The ideal sites are the outer aspects of the arm, thighs, back, scapular region. And don't make the mistake of applying this rotigotine patch at the same site, because it can cause skin reactions. Nowadays, these alpha-2 delta ligands, gabapentin enacarbil, pregabalin, gabapentin. See, FDA has approved only gabapentin enacarbil as a treatment modality for restless leg syndrome. The problem with gabapentin is that it requires a monoaminergic transport carrier system for absorption across the intestine. This transport carrier system gets saturated with the higher doses of available intestinal gabapentin. So if the carrier system is saturated, if you are going above 1600 to 1800 milligrams, the gabapentin is not going to be absorbed. So if you want to prevent this problem happening, split the dose of gabapentin to 3 or 4 or even 5 doses from morning till evening. These drugs are administered about 1 to 2 hours before the onset of RLS symptoms. Gabapentin enacarbil comes with a carrier attached to it, so that it can easily enter into the it can bypass the intestinal epithelium and then gets dissociated in the blood, so that gabapentin is available for the site where it is to go. Pregabalin does not have a non-linear kinetic. It has got a linear kinetics. So the difference between gabapentin and pregabalin, the higher the dosage of pregabalin you give, the steady state serum levels, they go on rising, where this doesn't happen with gabapentin unless you use gabapentin in split doses. Start up with 300 milligrams 4 times daily. If you are tall, you are to increase the dosage to 2400 milligrams per day. But all these drugs, they come with the side effect: weight gain, pedal edema, falls are known, sleep. So elderly people may have sleep. And these are excreted exclusively through the kidney. So if somebody has got, see, RLS is associated with renal disease. So if somebody has got a renal problem, you need to have a dosage adjustment. Dopamine agonists can cause sleep attacks and impulse control disorders. This fellow has started behaving abnormally. About 15% of these patients can have it. He has hypersexuality. He has punding. He goes on shopping like anything. These are the impulse control disorders. The longer the duration you go, higher the dosage, this can happen. Augmentation is a very peculiar thing that can happen with dopamine agonists. The symptoms which are supposed to occur in the the late evening or early night start occurring earlier in the day. They were happening only in the legs. Now they have extended to the arms. They were not so severe earlier. Now they have become very severe. And the moment they sit, they start happening. Whereas earlier they were happening about 15 to 30 minutes after going to rest. It is chronic deterioration of symptoms with an increased drug dose. So whatever dosages I told, don't increase that. Chronic intermittent dopaminergic stimulation give rise to postsynaptic desensitization of D2 receptors in the substantia nigra and putamen. And in addition to that, iron deficiency, genetic risk factors, circadian rhythm, and vitamin D have all been implicated in the development of augmentation. RLS unresponsive to monotherapy with tolerable doses of first-line agents. First-line agents are the dopamine agonists and alpha-2 delta ligands. Dopamine agents have been pushed back because of the problem of augmentation. The first-line agents should be alpha-2 delta ligands like pregabalin and gabapentin. Due to the reduction in the efficacy, augmentation or adverse side effects. So when you encounter a refractory patient, check iron stores, check medications. On the one hand, you are giving tricyclic antidepressants, and on the other hand, you are giving drugs for RLS. Lifestyle change, ask them to reduce their weight, let them be more active. Consider a combination of therapy of different class. Second agents may be dopamine agonists for alpha-2 delta ligand and vice versa. You can try a combination of these drugs, keeping the levels of dopamine agonists low. In a patient with insomnia with RLS, you could use a benzodiazepine or a low-dose, high-potency opioid can be added. Consider low-dose methadone for severe refractory cases. Opioids are typically used when other management strategies have failed. Before you initiate opioid therapy, an opioid risk tool should be used to screen the abuse potential. So for having done that, for having had a discussion with the patient that you are going to give the opioid, the drugs useful are tramadol up to 200 milligrams, oxycodone up to 30 milligrams, methadone up to 20 milligrams, or buprenorphine hydrochloride up to 6 milligrams. How to choose opioid for RLS? See, opioids differ predominantly in their half-life. Their opioid treatment is based on the 24-hour distribution of RLS symptoms. See, if somebody has got RLS symptoms less than or 4 hours per day, oxycodone, tramadol, hydrochloride could be used. Yes. If it is up to 6 to 10 years, oxycodone ER can be used. And if it is more than 10 hours, use methadone and buprenorphine. Be cautious about the side effects: nausea, constipation, urinary retention, itching because of the granulation of the degranulation of the mast cells, unsteadiness, precipitation of obstructive sleep apnea, and it can give rise to hypogonadism with its accompanying side effects. Pregnancy, there is a peak incidence in the second and third trimester. Symptoms improve or resolve around delivery, and by 4 weeks after delivery, most of these symptoms should have resolved. Clonazepam could be used at bedtime in the second and the third trimester. You could use intermittent carbidopa, levodopa also. And oxycodone could also be used in such patients. And you should be careful about the OPD withdrawal, the opioid withdrawal in the neonate. Lactation, clonazepam, gabapentin. Severe refractory cases, you could use tramadol. Dopamine agonists are not used in lactation because they are supposed to suppress the lactation. So don't use the dopamine agonists. In children, you treat them with iron supplementation. Still, you could use gabapentin, pregabalin, and second-line agent is clonazepam. Dopamine agonists could still be used. If a patient has got attention deficit hyperactivity disorder, you could use clonidine. Non-pharmacological methods are very important. Before you jump to drug therapy, eliminate caffeine and alcohol, massage, stretching, walking, cognitive distraction, that's working on a task that requires concentration, pneumatic compression devices, vibration pads, yoga, acupuncture. A repetitive transcranial magnetic stimulation over the supplementary motor cortex has been found to stimulate dopamine release from this has been a newer thing for the treatment of RLS. So I conclude, RLS is a common disorder. It is a familial disorder and commonly seen in patients with iron deficiency, renal failure, and pregnancy. Initial treatment should include iron therapy based on serum iron studies. Alpha-2 delta ligand should be offered as first-line therapy. Dopaminergic therapy is effective for short duration at low doses. Opioids should be reserved for patients who fail the initial therapies. These are my references. Thank you so much for a patient hearing.
Thank you, sir. Thank you very much, sir. Just wanted to comment that in pediatrics, definitely we see it quite often in attention deficit hyperactivity children. And it is, quite well relieved with benzodiazepines just at night time alone. We don't use it during the daytime because they are going to school. Any other questions? Or
Sir, I would like to ask from you, what's your experience of using gabapentin and pregabalin in children?
Actually, because most of these children are the younger age group, they are usually below 5-year-old children. And it worries the parents much more than the child. The child happily comes to your clinic and they're very happy. It's the parents who are very keen for treatment. And very often it's the parents that we treat rather than the children themselves.
Thank you.
You brought out RLS is not only a difficult to treat situation, difficult to diagnose at times, especially in the elderly. What we face is many of them do have degenerative spine, stenosis, trochanteric bursitis. All of them exist, and they would have already gone through the investigation, and somebody or the other would have put them on gabapentin or even clonazepam. It becomes extremely difficult. You go and operate them, they continue to be unhappy. I don't know what is the experience of the chair and the rest.
Those
is there
patients,
anything that you could screen and tell that how much it is truly restless?
those patients who have such problems like lumbar spondylosis, degenerative disc disease, radiculopathy, peripheral neuropathy, or some other rheumatological diseases, versus patients with restless leg syndrome. How are you from morning till evening? Can you run, jog, go up, down? Can you climb a hill? Doctor, I'm perfectly all right. The moment I come home and sit on my sofa to watch the TV, this starts. I will have to move to relieve myself.
Basic issues, they have a combination. They do have. And there will not be neurological deficit in majority of the degenerative stenosis. That's the issue. I mean, there I again insist upon a teamwork. I think most of the time I involve my neurologist also preoperatively and then come to a conclusion as how to deal with them subsequent to surgery.
Thank you for a very, very clear talk. I've been worrying about this RLS diagnosis for a long time. And there's entity like primary RLS and secondary RLS. Now, secondary RLS is host of disorders like neuropathy, pregnancy, degenerative disorders, spondylosis, everything. So my feeling is it that these people are predisposed to primary RLS through genetic, and then they develop a disease? Now, if he develops diabetic, he becomes diabetic RLS. He does neuropathy, he becomes neuropathic RLS. He goes lumbar spondylosis, he becomes spondylotic RLS. Your comments. I mean, I'm not.
That is why the urged symptoms. If somebody doesn't have urged symptoms, it becomes difficult to make a diagnosis of RLS in a patient with
I
secondary.
fully agree with you. We have been doing a study on neuropathic RLS. We try to compare the pattern, clinical picture, everything. And, then my hunch was to look at the genetic disorders in so-called secondary RLS. Could not do that study. Maybe somebody else should do it. So ultimately, my feeling is that, I could not prove it, that these people are, there are 13, 15 genes you have already mentioned. There are many more. Now, the person is predisposed to that. Now, he develops a neurosurgical disorder, he becomes surgical RLS. He becomes a medical disorder, he becomes medical RLS. And then the whole scenario of secondary RLS comes in. Rather than calling them primary RLS with the secondary disease. I mean, renal failure, pregnancy RLS.
Sir, I would like to know from you, in a patient Professor Krishna was raising, in a doubtful case, should we resort to genetic studies to know whether the...
No, in a doubtful case, give him a treatment. He responds, that diagnosis is made. You give him a Ropark or whatever, and he responds immediately. It's like magic. So that proves the diagnosis. There is no investigation which is going to solve it. So, and you know, there are so many genes, who will do those all genes, and scanning is so expensive. So I don't, you know, that to prove the point, I wanted to do that genetic study to prove a point, but clinically at the moment, clinical diagnosis. Yeah, pain clinics. And, you know, unless they pick the right diagnosis, and, you know, in difficult cases, sometimes giving iron injection, when you are last resort, nothing is working, ferritin is low, then give and bring the ferritin to 100 or more. Then we give iron injection, and sometimes patients respond.
You may not find an immediate response. At least wait for about 6 weeks. And in the meantime, you can cover with alpha-2 delta ligands.
You know, we try everything, and if the patient is not responding, and if serum ferritin is low, then as last resort, we admit and give a injection of iron, and sometimes they respond.
Point well taken, sir. Point well.
Thank you, sir. I think now we'll probably move on to the emergencies and movement disorders, which is an interesting topic. And Dr. Shishir Pandey from New Delhi will deliver the talk. Dr. Shishir Pandey is from Indraprastha Hospital, Apollo Hospitals, New Delhi. He's had experience in handling neurological emergencies like acute strokes, stroke thrombolysis, status epilepticus, both inpatient and outpatient care counseling. Over to you, Dr. Shishir.
Good afternoon, everyone. I am Dr. Shishir Pandey, attending consultant neurology in Indraprastha Apollo Hospital. First, like to thank you for this Apollo Bangalore for organizing this great gala conference and giving us an opportunity like a young neurologist for presenting a topic here. Regarding that, the emergencies in movement disorder, the sir has rightly said that it is a very neglected topic. Everything that comes moving in the emergency department, the emergency department doctor said, ki, sir, there is something with moving. We have loaded it with the Levipil, considering it as a kind of a type of a scissor. And then I'm informing what we are supposed to do. So regarding that, the movement disorder thing, as the movement disorder, we are considering, we are also classifying this into the hypokinetic, hyperkinetic, and the miscellaneous categories. In the hypokinetic category, the things are neuroleptic malignant syndrome, malignant catatonia, serotonin syndrome, Parkinson hyperpyrexia syndrome, acute Parkinsonism, abductor paresis in multiple system atrophy, emergencies related to the management of a Parkinson's disease, that is the motor fluctuations, fall, and the psychosis. In hyperkinetic category, we have chorea hemibellismus, myoclonus, tics, acute dystonic reaction, and status dystonicus. In miscellaneous one, we have the functional movement disorder, mixed movement disorder, and movement disorder mimics. Regarding the neuroleptic malignant syndrome, it is defined in 50s and 16s as a side effect of a phenothiazine antipsychotic group of, that is a chlorpromazine, classically described with the presence of a delirium, rigidity, high fever, and dysautonomia. The drugs which are notorious for causing these are psychiatric group of medications, that is risperidone, haloperidol, clozapine, and olanzapine, antiemetics, chlorpromazine, promethazine, properistaltic drugs, metoclopramide, and anti-Parkinsonian withdrawal, that is of levodopa withdrawal. The clinical features is defined by the tetrad of altered mental status, hyperthermia, rigidity, and dysautonomia. The exact pathogenesis of NMS is not entirely clear, but the hypoactivation of central dopaminergic activity and peripheral sympathetic adrenergic hyperactivity are supposed to be caused these symptoms. The offending drugs, could disrupt the pathway dependent on the dopamine, including the central thermoregulation pathway that leads to hyperthermia as a symptom, nigrostriatal pathway that leads to the rigidity, akinesia, and tremor, and reticular activating system that knock off the patient and lead to alertness. The risk factors are the higher neuroepileptic doses, hyponatremia, hypokalemia, thyroid disease, early postpartum depression, infectious encephalitis, catatonia, and the physical exhaustion and dehydration. The differential diagnosis of these are neuropsychiatric disorders are delirium and malignant catatonia, toxic and metabolic oculogyric crisis, and thyrotoxicosis as a major disease. Infections include the sepsis, meningitis, and encephalitis, and environmental factor could be the heat stroke. The management part, when it is a mild in the category, it could be easily manageable with the lorazepam at 1 to 2 milligram intramuscular or IV every 4 to 6 hours. Moderate category, which is characterized by rigidity, mutism, catatonia, confusion, stupor, and hyperthermia and tachycardia. Lorazepam along with bromocriptine and amantadine has to be tried. And in the severe category, in which there is a comatose state, the dentrolene, which is in the 1 to 2.5 milligram per kg body weight, along with bromocriptine, amantadine, and in the most resistant cases, electroconvulsive therapy has to be tried. Malignant catatonia. It is another entity which is now identified as a non-specific syndromic subtype of catatonia associated with many toxic and metabolic and neuropsychiatric illness. It is characterized by a similar triad along with some laboratory markers, that is elevated creatinine kinase, white blood cell count, and low serum iron. The clinical features are more or less same: altered mental status, motor symptoms, muscular rigidity, catatonia, hyperthermia, dysautonomia, hypermetabolic state, and the laboratory findings as we discussed. The pathophysiology has a major low GABAergic tone in the lateral orbitofrontal cortex and the glutamate hyperactivity in the posterior parietal cortex as the major pathophysiology. Risk and the foremost recognizing factor is the patient has a severe neuropsychiatric conditions, which could be the bipolar, schizophrenia, schizoaffective disorder, and major depression. Management part, the benzodiazepine and the combination of a supportive care is the major role has in its management. And in the resistant cases, electroconvulsive therapy is tried. The other entity is the serotonin syndrome. Serotonin syndrome is just as an increased serotonergic activity in the nervous system. Either it could be overdosing of an SSRIs or potentiation of a serotonin in the brain due to effect of interaction with other drugs. There are certain criteria led by Dunkley's et al. Which for the diagnosis, in which there is within a 5 weeks, the patient has taken the serotonergic agent, and one of the combination of the following seen, like spontaneous clonus, inducible clonus plus agitation or sweating, opsoclonus, agitation or sweating, tremor plus hyperreflexia, hypertonia, and there is a hyperpyrexia and opsoclonus. Pathophysiology is that inhibition of serotonin reuptake, inhibition of presynaptic release, and monoamine oxidase inhibition. And all these leads to the 5-HT1A and 1-2A receptors have been extrapolation. The noradrenaline concentration in the CNS has been elevated. That leads to the hyperpyrexia and hypermetabolic state. These are the culprit drugs in SSRIs and SNRIs categories. The majority one are the sertraline, paroxetine, venlafaxine, desvenlafaxine. MAO inhibitors are amitriptyline. Other psychiatric lithium can also cause this. Anti-epileptic, valproic acid, sometimes also considered. Antiemetics, there is a long list. Analgesics, cough syrups, and the last one is the drug interactions, that is SSRIs with other MAO inhibitors could lead to this. Management part, initial step is the same, discontinuing the offending agent. The second step is the supportive care, vitals, oxygenation, hydration, and cardiac monitoring. Hyperthermia, which is started with the cooling of the blankets, cooling into IV fluids. Serotonin antagonist, that is cyproheptadine, that has to be used. Agitation is controlled by the benzodiazepine. Severe rigidity causing hyperthermia, induced neuromuscular paralysis, or hypertension has to be managed with ephedrine, norepinephrine, or phenylephrine. Hypertension by nitroprusside, and if there is a we don't know the agent, then we have to call a poisoning control center for the same. And the other one is the Parkinson hyperpyrexia syndrome. Parkinson hyperpyrexia syndrome, now considered as an neurolab malignant syndrome that occurs following the withdrawal of an anti-Parkinsonian drugs. The clinical presentation is the same as of neurolab malignant syndrome, but here the more Parkinsonian features occur, and that occurs in an early. It generally occurs within the 18 hours to 7 days within the from the change of the dopaminergic medications. In the management part is the cooling, IV fluid, antihypertensive measures, and other supportive cares. Since the parenteral form of anti-Parkinsonian medications are difficult to procure, nasogastric administration is recommended. Bromocriptine in higher dose, 5 to 10 milligram, is the divided dose has to be given, along with levodopa and other dopamine agonists like ropinirole. These is the comparative table comparing the neuroleptic malignant syndrome, Parkinson hyperpyrexia, serotonin syndrome, and malignant catatonia. As you can see, the precipitant factor is different in different all these things, and rest of them is same. In neuroleptic malignant syndrome, it is dopamine antagonist, and in Parkinson hyperpyrexia, it is withdrawal of dopaminergics. Serotonin syndrome, that is serotonergic drugs, and in malignant catatonia, it is the patient must have a psychiatric or a medical cause. Acute Parkinsonism, as of we know, the Parkinson's takes time to evolve, but in the acute condition, it evolves in hours or week. And that could be due to the effect of the medications like the neuroleptic malignant and serotonin syndrome, and toxins, carbon monoxide poisoning, structural brain lesion, acute stroke, hydrocephalus or pontine myelonesis, infections, systemic lupus erythematosus, sarcoidosis, brainstem encephalitis, or a neuropsychiatric condition. This is a CT scan showing then hydrocephalus, and the patient present here with a 3-month history of an Parkinson syndrome, and it is completely resolved by the putting in a VP ventroperitoneal shunt over a duration of 3 weeks. And this is the rare movement disorder emergency, that is an abductor paresis in a multiple system atrophy, which is a type of atypical Parkinsonism. These occur typically in the night, where the patient is usually unaware of the problem. The patient bed partner may notice a change in their breathing pattern, often with an episodes of breath holding or a new snoring. The mechanism of vocal cord dysfunction in Scheidegger syndrome is complex, and that could be due to the paresis of a posterior cricoarytenoid muscle, that is which is the sole abductor of the vocal cords, or excessive activation of a thyroarytenoid muscles. The definitive airway protection is the treatment, that is tracheostomy, or it could be prevented by use of a continuous CPAP, nasal CPAP mask, botulinum toxin injection to the thyroarytenoid muscles, or a local laryngosurgery. This is an image of a female post vocal cordotomy that has developed this MSA stridor. And the last with the hyperactive disorder is emergencies in the management in the Parkinson disease. The fall is the most common medical emergencies that lead to the admission of an advanced Parkinson patient. But unfortunately, it is not levodopa responsive, and it has only preventive treatment in the form of an assistive devices. The motor fluctuation that could be of two types, either the worsening of periods, which usually encounter when there is a change in when the patient is using some dopamine receptor blockers in the form of antipsychotics or antiemetics, or there could be concurrent infections in the form of a urinary tract infection or pneumonia. If a patient of a Parkinson's came with a fall in your emergencies, the subdural hematoma is the first to be ruled out. The dyskinesia, that is other type of motor fluctuations, is usually not dangerous, but when it involves the respiratory muscles, which may cause rhabdomyolysis and dehydration, it makes an emergency. The treatment of dyskinesia, the agitation, where you have to lowering down or holding the levodopa doses. Benzodiazepine may be used for the concomitant anxiety. Neuroleptic should not be used. And the other drugs that control dyskinesia are amantadine hydrochloride and deep brain stimulation surgery for the resident cases. Psychosis, the precipitating factor for the psychosis in Parkinson's patient is the systemic illness. Anticholinergics, amantadine, monoamine oxidase inhibitor, COMT inhibitors, and dopamine agonist. These are the sequence of the drugs that has to be withdrawn one by one when a patient of a Parkinson's came with a psychosis in your emergency. And most of the patient with an hallucination without an insight cannot tolerate these above group of medication. They are only well preserved with the sole levodopa doses. Hallucination without insight or a fixed delusion has to be treated with the quetiapine and clozapine. Regarding that hyperkinetic disorders considered, chorea and Bellism syndrome. Chorea is a hyperkinetic movement disorder characterized by continuous, non-rhythmic, non-pattern movements. The term Bellism is extreme manifestation of chorea with a high amplitude. Children, the most common cause is Sydenham's chorea, and in the adult, the stroke and hyperglycemia, chorea gravidarum are common. This is an MRI showing that T1 hyperintensity in the caudate and the globus pallidus region in a hyperglycemic hemichorea state. The patient developed this hyperglycemia, and the imaging is this, showing that the chorea and hemiballismus of the right side. This is a diffusion weighted MRI image showing an acute stroke within the right basal ganglia, and the patient presented with a left arm and a left face chorea. These are the categories. That is an acquired chorea-Bellism syndrome. It could be drug-induced, antiarrhythmic, antidepressant, toxins, carbon monoxide, manganese, thallium, metabolic, both hyper and hypoglycemia, both hypo and hypernatremia, hypomagnesemia, autoimmune, the systemic lupus erythematosus, antiphospholipid. It could be post-infectious adenomas and herpes simplex encephalitis, vascular, ischemic, hemorrhagic stroke, paraneoplastic, infection, HIV, CJD, and other category includes the chorea gravidarum and polycythemia vera. Treatment-wise, it has to be managed with tetrabenazine, olanzapine, risperidone, pseudomonas chorea, selectively with the valproate and the carbamazepine. Myoclonus, it is characterized by brief shock-like movement, could be positive myoclonus, negative myoclonus. The most common cause is in emergency is the acute CKD patient on the maintenance hemodialysis came out with an myoclonic jerks and due to increase in creatinine and metabolic acidosis. That is uremic. And the drug-induced encephalopathies are the other causes. The other one could be the post-cardiac arrest myoclonus, which could be due to status myoclonus, in which a comatose patient had a myoclonus and it is had a very bad prognosis, and post-anoxic myoclonus, which is also called the Lance-Adams syndrome. Treatment-wise, it has to be treated with clonazepam and valproate or a combination of both. There is a rare entity, there is a call of a myoclonus after the propofol withdrawal in an anesthesia. This is a diffusion weighted and flare images MRI showing that hyperintensity in the basal ganglia and the thalamic, bilateral thalamic with a cortical ribboning sign post-anoxic state, and the patient presented with a myoclonus. Tics are brief movements or vocalization that are typically stereotyped, suppressible, and preceded by premonitory urge. Tourette syndrome is a common childhood onset neuropsychiatric disorder characterized by tics with neuropsychiatric symptoms like obsessive compulsive disorder and attention deficit hyperactivity disorder. Tics rarely worsen, but it could be worsen in the context of stress, fatigue, infection, with certain drugs like stimulants. Rarely, the patient with the malignant Tourette syndrome present, it is self-injurious tics and a comorbid behavioral disturbances. Treatment-wise, it has to be treated with an atypical neuroleptics like aripiprazole and dopamine depleters in the form of tetrabenazine. Focal tics can be managed with the botulinum toxin, and there is a deep brain stimulation for the refractory cases. The neurological sequel of this malignant tic could be cervical myelopathy or compressive neuropathies. Acute dystonic reactions. Acute dystonic reaction generally caused by the drug induced, and the culprit drug is the mainly dopamine receptor blocking agents, typically neuroleptics and antiemetics. However, this reaction has been described in association with other medication class also, like SSRIs, CCBs, and a diverse group of action. Symptoms occur abruptly, usually within the 5 days of drug exposure. The pathophysiology is the same: dopamine turnover, increase in dopamine turnover, dopamine receptor sensitivity, and cholinergic activity. The clinical feature is characterized by acute drug-induced dystonia, the oculogyric crisis, which is a usual appearing manifestation that starts with a fixed stare, followed by upward fixed deviation of the eyes, tilting back of the head, mouth opening with the tongue protrusion, oromandibular dystonia, opisthotonus, blepharospasm, stridor, dystonia of the trunks and the limbs. Treatment-wise, it has to be effectively treated with a parenteral administration of anticholinergic medication. Most common are benztropine or diphenhydramine. Due to possibility of the recurrent symptoms related to the half-life of the offending agent, a short course of oral anticholinergic has to be given. This is an acute dystonic reaction picture. Other entity is the status dystonicus, also known as dystonic storm or dystonic crisis, referred to as an acute worsening of generalized dystonia with a severe continuous generalized movements. Status dystonicus is more common in the pediatric population, especially the DYT1 category, and in males, and more frequently affected. The patient with a primary or a secondary degenerative dystonia may also develop the status dystonicus and tonic presentations, and more common than the phasic. Dystonia secondary to the cerebral palsy would also be seen. Clinical feature is worsening severe generalized dystonia, fever, dehydration, or rhabdomyolysis. Status dystonicus usually evolves gradually over weeks to months. The risk factors are infection or change in the medication. Other possible precipitants include trauma, anesthesia, surgical procedure, metabolic derangement, stress, discomfort, constipation, and puberty. The differential diagnosis could be the same: NMS, serotonin syndrome, malignant hyperthermia, acute dystonic drug reactions. Management part, it is not supposed to be managed with the pharmacological treatment with an anticholinergic or dopaminergic blocking agents. Hence, sedation and endotracheal intubation is often necessary. In the refractory cases, surgical intervention has to be required in the form of an intrathecal baclofen pump placement, thalamotomy, pallidotomy, or deep brain stimulation. These are the summary of the drugs that are used in various movement disorder emergencies. Miscellaneous categories include the functional one. It is the it could be functional movement disorder frequently present abruptly and often results in the hospital admission. Key positive features of making the diagnosis are distractibility and entrainment of the involuntary movements. Then the other category is the mixed movement disorder. No talk is completed without the discussion of an autoimmune spectrum of any movement disorder. The common one are NMDA and LG1 in the extracellular antigen category and GD65 in the intracellular antigens category. And there are movement disorder mimics in which there is a limb shaking TIA, which could occur after when there is a critical stenosis of an concomitantly supplied IC8 internal carotid artery. And other one are the focal scissors with appearance. And the last is the acute torticollis, which could be due to retropharyngeal abscess in the children, atlantoaxial dislocation, or a posterior fossa tumor. Thank you.
Thank you, Shishir, for finishing on time. Just a couple of points, actually, in pediatrics, because you spoke about emergencies the commonest is actually what we face is autoimmune disorders. Many of them come with so-called status epilepticus. But overall, we find there are more and more disorders that are being picked up as status epilepticus where they don't respond to anti-seizure medication, predominantly because they are movement disorders. For example, GLUT1 transporter defect, which was not known earlier, that presents as movement disorders, biotinidase deficiency, riboflavinopathies. As far as the other one that you mentioned about the malignant hyperpyrexia, more common in myotubular myopathies, particularly when they are being anesthetized, and you need to get into the ICU to treat them. One of the biggest issues we have in India is non-availability of dantrolene sodium, which is very effective in those conditions. So any other questions or comments, please?
Very nice review. I have seen some cases of status dystonicus because of Japanese encephalitis. There the lesions are in the thalamus, basal ganglia, brainstem. And severe spasms of the axial spasms, you fear if the body will fracture, the vertebrae will fracture. That's the severity. They last 2 to 15 minutes. Very difficult to treat. You give everything to cocktail to, control them. They take up to 2 months time to improve, but they all improve and they all recover over a period of time. So Japanese encephalitis, because of its anatomical location, is a very, very important cause. And we also have seen in case of Wilson disease that, you get severe status dystonicus. The editor did not agree with the diagnosis of status dystonicus. So we had to write it as markedly severe dystonia in JE. He was insisting to remove the term status dystonicus. So we removed it, It is movement disorder. Thank you. Definitely.
Thank you, sir.
Thank you.
Any other comments? If they're not, we'll go for the next talk. Thank you, Shishi. Thank you.
Thank you.
Thank you. Last but not the least is the psychogenic movement disorders by Dr. Soumya Sharma. This, of course, is a very common problem that we face in pediatrics. I'm sure it's true in adults too. Dr. Soumya Sharma is from GB Pant Hospital, from Bangalore Medical College, Fellowship in Parkinson's disease and movement disorders at London Movement Disorders Ontario, and also at the Ontario, Canada. Over to you.
Good afternoon, everyone. Thank you, Chairperson, for that kind introduction. And I would like to thank the organizing committee for giving me this opportunity. I would also like to thank my previous speaker because he did finish a little early. So I would be a little more greedy and ask for 5 extra minutes. I need 25 minutes to get through my presentation. I initially prepared it for a 30-minute talk, but I'll try and wrap up in 25 minutes. I'm not going to talk about pathophysiology and treatment. That's going to add up under 30 minutes to the talk. So there are lots of articles, and at the end of my presentation, I'll give you some references that you can go through. I'm not going to talk much about that. I'll also rush through the initial topics, try and cover them within 5 minutes. But the main focus of my talk is going to be demonstrating how you elicit these positive signs. So there's lots and lots of videos I have in this talk, and that's why I'm being a little greedy, like I said, and asking for 5 more minutes. So let's begin. I always like to start my talks with history. So when I looked up into history of functional movement disorders, this is what came up. For 2,500 years, this is what people believed. It was called hysteria, and the name was proposed by Hippocrates, and it meant from the womb. So hysteria means womb. That is, according to him, the reason for hysterical symptoms, and he decided that it only happened in women, was because of this wandering womb. So if the womb wandered up towards the head, that's when they had all these symptoms. So the picture on the left-hand side shows a woman being held up against fumes. That was to attract the womb back down so that her hysteria would settle down. So this lasted for 2,500 years. This is in the late 17th century. And again, you can see in this painting, the doctor is leaning over this hysterical woman who has this neurological symptom of having some contorted figure. It was not until Charcot in the late 19th century that finally we started understanding that this is a disorder of the mind and not of the womb. And that's Charcot giving a lecture to his students. You can see my cursor, okay. And finally, Sigmund Freud was the one who coined the term conversion, meaning your emotions get converted into physical symptoms. And in 1952, the first DSM incorporated conversion disorder as an official diagnosis. And then psychogenic was a term that was used for a long time by neurologists and psychiatrists to denote this, that this disorder is arising from the mind. However, the most accepted term right now is to use the term functional, and that means there's an abnormality in function of the brain and not the structure of the brain. It's a bit of a busy slide. I would like you to concentrate on 2 words over here. One, it's a functional neurological disorder. So neurological disorder, you see a syndrome, and you decide that this is not compatible with what you have been taught during your training. That's one part. And the second part is the functional aspect of it. That means there's no structural problem in the brain, but there are certain other processes that are mentioned over there that's causing these disorders. And almost more than 50%, that's more than half of these functional syndromes are motor related or movement related. Now, I'm sure all of you would have seen these functional patients and realized that, is the patient faking it? Is the patient being genuine, or is he just pretending to have these movements? So of late, there's been a lot of studies done, and we know that, especially functional MRI studies that say that these movements are in fact, the patients are doing this involuntarily, and they're not aware of these movements. And there are certain parts of the brain that shows hypometabolism or hyperactivity that predicts that they cannot understand that these movements are actually involuntary. So a bit extreme of this is malingering, wherein you definitely have a secondary gain. And how are you going to differentiate whether the person has genuinely got conversion disorder or psychological movement disorder, or is it malingering? Well, if you're an astute clinician and if you're good enough in making them confess, that's the only way to differentiate. But right now, the belief is that this is a true disorder and patients are not faking it. The only point here, the DSM-5 criteria came up about 10 years ago, trying to diagnose functional movement disorders. The most important is you need not prove that the patient has psychological stress. So again, a very busy slide. I would like to draw your attention to the second point, that this is a very common disease that we see in a movement disorder clinic. Almost 20% of the patients who walk into a clinic are functional disorders. And it occurs in usually about 40 to 50 years of age, but do not disregard if you're seeing this in an elderly patient, because they can also have this functional movement disorders. And the most common type of FMD is a mixed type, followed by very closely by tremor. Weakness I'm not going to touch upon, and dystonia. And here is the impact of functional movement disorder. It has a huge implication on the the patient itself, because they end up having persisting symptom for a long time. So more than 30% of them have persisting symptom, and a third of them are also laid off of work. In fact, the disability from FMD is compared with that of Parkinson's disease. So it's that disabling. So this is the most important slide for me. I'm going to be talking, predominantly about the positive signs that you can elicit. The current era is the era of absolutely fantastical investigations or diagnostics. So you have functional MRIs, you have PET scan, you can do MRI scan. However, the most important aspect of diagnosing a patient with functional movement disorder is still clinical. So be an astute clinician. I'm going to show you in videos how to pick up these positive signs, because this is a rule in diagnosis, meaning you don't investigate the patient too much before ruling out psychogenic movement of a functional movement disorder. You have to rule in, meaning you have to actively look for these signs. So in history, taking a few points, most often these patients say that, oh, the symptoms began on such and such date, and I was doing so and so thing on that day. That's very classical. The other thing is that the disability was quite rapid or quite severe right at the onset. And the course tends to wax and wane. They have good days and bad days. And when they have the episodes tend to relapse in different body parts, having changing phenotypes. And also inquire about psychiatric comorbidity. Although they may not have a psychological stressor, but more than half these patients have anxiety or depression associated with it. And if you can ask about physical or psychological stress that has triggered, usually a minor trauma. In case of especially dystonia, you can get a history of very small, like a small car accident, or this twisting of the foot triggered the symptoms. I call this the two pillars of the diagnostic algorithm. On examination, you look for two things: the positive signs, that like I said, two pillars, the inconsistency and the incongruency of the movements, and suggestibility. So I'll just talk to you a little bit about what those are, and then we'll get into the videos. What do you mean by incongruent? During your training, you have learned how a neurological disorder should look like. So if you're finding a patient whose symptoms do not fit into the classical organic disease, then that should raise a suspicion that this is probably a functional movement disorder. That's incongruent. What is inconsistent? I call this the wedge sign. The first and foremost, these patients require a lot of time to examine. So the variability, what do you mean by variability? The movement that you're seeing varies over a period of time with respect to its frequency, the amplitude, the body part that is involved. So examine them. Sometimes it can take an hour and a half, just talking to them, just making sure that you notice this variability sign. And the other two is basically draw the attention of the patient to the movement, or draw the attention away from it to elicit the signs. We'll get into that when I show you some videos. Now, this is a gray zone. Do we actually induce the movements? The most common technique that we use is putting a tuning fork to different parts of the body. Now, is this ethical, non-ethical? There's a lot of debate about it, but we do insist if the patient is having a paroxysmal, meaning intermittent episodic movements, then do this in the clinic, because you need to document that the patient has a functional movement disorder. So I'll go one by one. The first one I'm going to start, the first phenotype we're going to talk about is tremor. So more than half the patients of a functional movement disorder have tremor. Probably it's easy to simulate, I guess, I don't know. Anyway, more than 50% have tremor as the predominant phenotype. Most commonly in the hands, spares the fingers, remember. Now this girl presented to us with this typical head and trunk bobbing. That's all she had. There you go. That's very classical of somebody with a functional movement disorder. This is a very busy slide, so don't bother about reading any of this. Remember, I told you the two pillars of examination, the incongruency and the inconsistency, and I'm going to go through each point showing you video demonstrations. So what do you mean by incongruent? We know patients with Parkinson's disease, for example, have a higher amplitude rest tremor. On posture maintenance, they may have a re-emergent tremor, but lesser amplitude, and on doing finger nose testing, it goes away. And the reverse is true for essential tremor. However, patients with functional movement disorder have tremor that is of equal amplitude in all three positions. So that should raise a red flag in your mind. So this gentleman has tremor at rest, quite severe amplitude, and he holds the posture up. And again, the tremor is quite significant. And then we ask him to do some random posture with his hand. Again, the tremor comes out. And then we're going to ask him to do finger nose testing. And remember one more thing, this gentleman is in his 60s. Again, please do not rule out the fact that just because he's older, he doesn't have functional movement disorder. There you go. So all three positions, the tremor seems to be quite persistently of same amplitude. That was the incongruency. Next is the second pillar, the inconsistency. So variability. You're examining this patient. Now I'll show you this lady. She presented with this up and down foot tremor, flexion extension of the foot. And then during conversation, she crosses her leg and the tremor shifts into being a flexion extension of a knee joint. There you go. So you need to spend time with the patients, because during your examination, this is what happens. The tremor or the movement shifts the body part. Same thing, this gentleman I just showed you with a lot of hand tremor. Hand tremor is gone, but now the tremor comes out in the left leg. You'll see in a moment there. There you go. That's migrating tremor. This is a very, very important sign for functional tremor, entrainment. So what do you mean by entrainment? As normal people, we cannot maintain two different rhythms at two different rapid rhythms for a prolonged period. So what you do for this patient, if the patient is having tremor in one upper limb, you ask them to do certain movements of the other upper limb. So you ask them to either tap their fingers or flexion extension of their wrist, or even tongue movements, especially for the head tremor. I'll show you in a moment. Positive if the tremor in the involved limb takes up the frequency of the uninvolved limb. And like I already mentioned, we cannot maintain two different rhythms for a long time. And it's highly specific for functional tremor. So here is the same lady who had that foot and the flexion extension tremor. Now her leg is in the air, and there you go. See, you can see the left knee bobbing in time with the right hand. And now she's going to place her the left leg on the ground, and she's going to have the same foot tremor. Let me just come up in a moment. There you go. And just watch her left knee go up and down in tune to the tapping of the right hand. There you go. That's how you entrain it. Now this man, I already showed him. I believe I showed him. I don't know. Anyway, I'm going to show him another slide. He had a very peculiar multidirectional head tremor. And we asked him to do tongue movements. Initially, he didn't do properly. And now just observe that when he does it for the second time, the head becomes a no tremor. There you go. So that's entrainment. That's very important to demonstrate. That's very specific for functional tremor. Next, this is a sign called whack-a-mole sign. It's difficult to demonstrate most often in this functional tremor patients. So it's actually a video game wherein you hit on one mole and then the mole emerges from the other hole. So this lady presented with tremor in the right upper limb. When you hold down the tremorless hand, the tremor moves to the opposite limb. You'll see in a moment the examiner is holding a hand and it's going to shift to her left hand. There you go. That's called the whack-a-mole sign. Now the second sub-pillar of the inconsistency is distractibility. So what do you mean by distractibility? Most often you engage these patients in some sort of a good conversation, ask them about their grandchildren or about their vacation. That distracts them away from the movement that they're having. Or ask them to do some sort of a cognitive task or a motor task with the opposite limb. The tremor either stops or decreases in amplitude, and that's how you know that this is a distractible tremor. And the principle is same as entrainment. So here is the same gentleman I showed you with the head tremor. He has a tremor in the right upper limb, the shaking. And in the moment he's going to start doing a flexion, opening, closing of his left hand, and the tremor completely goes away in the right upper limb. Similarly, this lady has a right upper limb tremor. And then we are going to ask her to open and close the left hand, and the right tremor completely subsides. This can be even documented on electrophysiology, as I'll show you in the next couple of slides. This woman has a rest tremor of same amplitude as that of a postural tremor. And then she's going to start doing the finger tapping with her right hand, and the tremor will go away in the left upper limb. There you go. The left upper limb is completely quiet now. The same thing, she's going to tap with the left hand, and the right upper limb rest tremor is gone completely. So this is distractibility. Again, like I said, suggestibility is an important sign to elicit, especially when you're dealing with patients who have intermittent or paroxysmal movements. So this lady presented with left lower limb tremor. She did not have any tremor during her clinic visit. So we put the tuning fork on random sites, and there. The tremor starts up in the left lower limb. You'll see in a moment how it will increase in intensity. And surprisingly, she also developed a postural tremor in the right upper limb, which came out when the tuning fork was put to the forehead and went away the moment we took the tuning fork away from the head. Now, this is suggestibility. Just a very brief slide about electrophysiology. If you have this facility at your center, do it. It's a multi-channel surface EMG that you can do for the patient. So the first patient has, in the first slide, This person has an organic tremor. You do a ballistic movement with the opposite arm, nothing happens to the tremor. But in functional tremor, the tremor completely suppresses when you do a contralateral ballistic movement. Same thing, distractibility. This person has flexion extension tremor of the wrist, and then you ask them to do a cognitive task, the amplitude dampens of the tremor. Entrainment, like I just said, this is the initial frequency of the tremor in the flexion extensor of the wrist. And then the left side, you ask them to start doing this flexion extension. The involved limb takes up the same frequency. And then the variation in the EMG burst duration, you can see A and B. A is much bigger. That's the initial burst. And then the B is the smaller. So this is the contraction of the muscles that you're recording in them. So it has almost 100% specificity if you're able to demonstrate all of these signs in these patients. So moving on to functional dystonia. It's the second most common functional movement disorder. Again, women are more affected. There are three types that you need to look for. One is known as the functional cranial dystonia, functional fixed dystonia, and paroxysmal. So a bit of, again, busy slide. What I would like you to focus on is that functional dystonia, unlike organic dystonia, are fixed right from the onset. They are very painful. You cannot break the resistance in the dystonic limb, and most commonly involves the legs. And if it is severe enough and has lasted for long enough duration, look at that, it can even cause muscle atrophy and contractures. Again, I've listed out the two pillars. We'll go point by point. I'll show you the signs. Don't bother about that. I'll show you how to recognize those. So incongruency, we know the pattern of contraction. If in a patient with tonic hemifacial spasm, the lip goes up. This patient has a functional spasm. So in a functional patient, you can see here the contraction of the platysma, the lip is pulled down and the jaw is deviated to the same side. Similarly, this woman, in fact, she had an alternating left-sided and then both-sided pulling down of her lip. And on this side, you can see the jaw deviation as well. Again, functional cranial dystonia, there's something called an Other-Babinski sign, as we all know. In patients who have hemifacial spasm, with the contraction of the orbicularis oculi, there's also contraction of the frontalis. So normally, the frontalis elevates the eyebrows. As you can see here, this is the actual patient with hemifacial spasm. The orbicularis oculi contracts. But in a functional patient, with the eye closure, the eyebrows are brought down because there's no contracting frontalis contraction, and the opposite eyebrow is lifted up. So just watch this woman. She has a left-sided spasm. In fact, she has a convergent spasm. I didn't talk about that. They can have this intermittent eye coming inwards. She'll have that. So look at her left eyebrow. She has a left-sided functional spasm. The left eyebrow is down and the right eyebrow is up. That's how we make out that this is a functional. Same with this lady. The right side, she has a right side spasm. The right eyebrow is down and the left is elevated. Next, the posture that we see in patients with functional fixed dystonia is very characteristic. So classically, there's a sparing of the pincer grasp, and there's involvement of the last three fingers. And that's how they place their hand most often. In the foot, it's plantar flexion and eversion. In the face, like I already told you, downward pulling of the face. And the shoulder, it's fixed upward elevation of the shoulder and the neck tilting to the same side. Functional fixed dystonia, like I already mentioned, are fixed right at the onset, and they're very resistant to passive movement. As we can see in this gentleman, he came to us with about 2 or 3 years history of having this kind of a fixed posture of the right upper limb. One of my colleagues is trying to break the resistance that he's, trying to break the movement, but he's unable to do so. So that's very classical. You won't see that. We know that in patients with organic dystonia, it starts as an action dystonia. And the same thing with this lady. She presented with this fixed posture of the right upper limb. She was the same one with the left-sided spasm, facial spasm. Again, changing pattern of muscle involvement. If you have time enough to, if you spend enough time with these patients, you'll see that this woman initially had this left-sided spasm. And while she was being examined, the spasm shifted to the right side of the face. That doesn't happen in organic causes. Next, in fixed dystonia patients, make sure that you distract them away. Again, it's a type of distraction maneuver, but it's also variability. So what we did in this lady is that she had this fixed clawing of her right toes. So we pretended to do a lot of neurological exam, and when we did the niche and heel testing, the dystonia is completely relieved in the right foot. Then I mentioned about the paroxysmal dystonia. Of course, they're occurring in paroxysm, so you can't really see any of these signs in the clinic. What you do, you induce it, so suggestibility. So this man presented with some fixed posture of his left wrist, flexion or clenching of his left fist. He did not have this during the entire examination in the clinic, but we induced it by the tuning fork method. Again, there you go. It's induced that fixed. That's what he came to us with. Just a short slide. How much time do I have? I have time, okay. So just a few words about functional myoclonus. Most of the functional myoclonus are axial, and they're associated with all these other symptoms like facial grimacing. I'll show you in the next video how it presents. And then, most importantly, patients with functional myoclonus usually have episodic symptoms. So again, suggestibility or inducibility is important in these patients. Don't bother about the slide again. I'll talk to you about the incongruence and the inconsistency of functional myoclonus. So this gentleman had this intermittent spasms of his abdomen and the trunk while sitting. Now, again, look at the age of this man. He's in his late 70s. So it doesn't mean that you're seeing an older gentleman if they don't have functional movement disorder. And then we are asking him to do a finger tapping task, and the jerks completely go away. Same thing, like I said, functional myoclonus can be episodic, so suggestibility is important. Now, this lady has a lot of other bizarre movements, but a main symptom was she would have this flexion of her trunk. So we tell her, okay, I'm applying a tuning fork to your forehead, and it's going to elicit, not just forehead, maybe some other parts of your body, and it's going to elicit the movements. So initially she has, as you can see later on, she has a lot of facial grimacing and closing of her eyes. She looks like she's in distress. And then it's going to, in a moment, you're going to see that she's going to have these axial jerks. And of course, some random movements of the head as well. Next, functional Parkinsonism. Functional Parkinsonism is one of the rarest type of functional movements, phenotypes that we see. Most often they complain that they're having excessive slowness while doing activities. But when you actually see them, make sure you observe their spontaneous movements in the clinic. I'll show you in the next video about that. And they have this huffing and puffing sign. When they're trying to do the movements, they're they're sighing and they're making these sounds. And when they're doing the rapid alternating movements, there's no decrement. Unlike in Parkinson's disease, there is an associated functional tremor, and make them walk, because they'll walk not with the flexed arm, but rather with an extended arm, and you make them run, the arm movement doesn't improve, unlike in Parkinson's disease. Now, this is a bit of prolonged video. I'll show you most of the signs here. So this lady is talking spontaneously. So just watch her hand movement. She's going to bring up her right hand to her face, and then in a moment, she's going to bring the left hand to probably clear the hair from her eyes. They're quite good. The spontaneous movements are quite good. There you go. So very nice movements. I'm almost done. Yes. And then we ask her to do the finger nose testing, and look at the deliberate slowness that she'll execute on doing the finger nose testing. So this doesn't happen in organic disorders. So there you go. She reaches her target, but it's so deliberate and slow. Let's see if I can. Yeah, I can forward it. And now we ask her to do rapid alternating movements. On the right-hand side, it appears to be normal. And on the left-hand side, she has something like a clawing of a hand. Her hand gets stuck while trying to do the rapid alternating movements. There you go. She lifts it really slow, and then she starts doing the alternating movements. And then that's the clawing of the hand that happens. Now, the next gentleman in the same video, her gait is normal. That's an important clue as well. So much of slowness on doing all those movements, and then the gait turns out to be quite good. Now, this man, there's no audio in this, but he has a lot of, he's really struggling to do those rapid alternating movements. And he's deliberately slow on doing those movements. All right, just one slide about functional gait disorder, maybe, a couple of slides. Bizarre gaits. I'm going to show you some weird gaits that we have seen that do not fit into the organic gait pattern. Watch out for this huffing and puffing sign once more. They're very disturbed by the fact that they have to walk for us, and they tend to lurch. And there's something called this magnet-like attraction to walls. In fact, I had seen a child who could not walk without touching the wall. He would just lean into the wall, and that's how he would walk. That was his gait. Different types of gait, but we'll not get into that. I'll show you the video. Again, a bit of a long video. So this woman is walking, a very weird lifting up of the left foot while walking. And now we're going to ask her to turn. She's going to have an almost fall, but she doesn't fall. There you go. Loses balance, but she doesn't fall. And then this woman, She tends to have this, it's not a dragging actually, she's having a weird lifting up and placing. She doesn't have weakness. She doesn't have foot draw, by the way. And that's what happens to her gait. And then we ask her to do the tandem gait and she's able to do it, but she has a lot of exaggerated truncal sway while doing the tandem gait. And this man has this lurching kind of gait wherein he has this intermittent jerks of the leg, doesn't fall again. Again, look at that, the way he walks. It's almost like he's dancing to a tune. And this is a trunk twisting gait. Again, a very peculiar kind of gait. Look at the affinity for the walls. She's constantly holding onto the walls. She doesn't have any, we did a tandem gait for her. It was completely normal, but she seems to be grabbing onto the wall. And this gentleman was a deliberate slowness. And this is all, he's using a cane to support himself. And he's barely able to lift his foot off the ground, keeping it wide based. He was able to do tandem gait normally. Just one slide ticks. I'm not showing a lot of videos, any videos on this. I know there's been a lot of literature on TikTok tics since COVID happened. So 2 important points in functional tics. They do not complain of an urge or a premonitory sensation before the movement happens. And they cannot suppress the tics, unlike patients with the organic tics. And another thing is something called a blocking tic. That is, the tic interferes with the ongoing movement. So these are some of the articles I found really helpful and useful. This is just the tip of the iceberg. There are many, many more articles if you want to read up about functional movement disorders, especially the pathophysiology and the treatment aspect. And thank you very much.
Thank you. Soumya, just to say that this is the time we in children see a lot of tics when the exams come. Movement disorders and non-epileptic or psychogenic movement disorders in children. And also the family history in many of these children help a lot apart from school absenteeism. These are very common in children.
Yes.
Any questions or comments?
It's very important to know about these functional movement disorders. And being an epileptology, I'm interested in that. So this resembles many of the time the movement disorders. So there is a close parallel between the movement disorder and epilepsy. Sometimes we say this looks like more epileptic activity rather than movement disorder.
Yes.
And somebody will say it is movement disorder. So it is necessary to classify these cases as functional paroxysmal disorder.
Yes.
So functional paroxysmal disorder sometimes is the correct terminology because we have a difficulty in differentiating between the two. So this happens, for example, in a case like autosomal dominant nocturnal frontal lobe epilepsy, which occurs in the middle of the night. The patient gets these movements and it is so bizarre that you cannot even make a diagnosis. So that is why one need to be careful to differentiate these conditions from the real movement disorders and as well as epilepsy. And the treatment also sometimes is the same, which we give for movement disorders and epilepsy. So it is not that we can give the treatment and see the response. It is always positively make the diagnosis of functional disorder and then take the help of psychiatrists in these cases to deal. Thank you.
Thank you.
Thank you very much. Thank you. Thank you all. Thank you once again for the organizers for giving me this wonderful opportunity. Thank you.
Thank you, sir. May I request the chairperson and all the speakers to come for a group photo? The 4 speakers of the current session with Dr. Satish Chandra, Dr. Krishna, and myself. Now we'll move on to the panel discussion. I request Dr. Ali to announce the.
Good.
Thank you, sir. Next, we move on to our panel discussion session of the conference. May I request Dr. Sudhir Kumar, sir, and Dr. Mohammad Shujauz Zaman Bilal, sir, to join us on the stage. Dr. Mohammad Shujauz Zaman, sir, he's a neurologist working for the Apollo Hospitals, DRDO, Hyderabad, has more than 6 years of experience in the field. Special interests lies in lipid disorders, migraine treatments, head and neck infection, joint muscle, and various other. Thank you, sir. May I request sir to take over the session? The moderator for this session will be Dr. Professor Arul Selvan, sir. Panelists would be Dr. Vikram Kamath, sir. Then Dr. Somnath Vasudev, Dr. Praveen Sharma.
Good afternoon, everyone. I thank the organizers for giving me this opportunity to moderate this session. So we have just 30 minutes to discuss the medical management of Parkinson disease. So we'll start straight away. So, so Parkinson disease is a lifelong disease. So we will start with the early Parkinson disease. So when a patient comes for the first time with mild symptoms of Parkinson's disease, what would be the drug or treatment of choice?
Thank you for the question. So I think if I'm sitting in a clinic and I see a patient walking into the OPD with, say, a tremor, well, first time I ask the family and the patients, who has brought the patient, whether the patient has come, relative has brought the patient or the patient feels he has a disease. So making a diagnosis is important. So once we know it is a Parkinson's disease, they may have a mild tremor, they may have a little slowness. First thing I do is assess the disability that the patient really feels. Very often a patient hardly has any disability, and it is just because he's been noticed to have a mild tremor that is brought by relatives. Because I believe that decisions on starting drugs is dependent on the disability of the patient. Sometimes some patients have a very subtle tremor, no rigidity, no bradykinesia, no deficits. If you sit, talk to them, counsel them slowly, many of them even decide not to start treatment. So looking at the symptoms, if it is a tremor in a patient who is below the age of 65, predominantly a tremor without anything else, I will offer them to start with either a mild anticholinergic drug like trioxyphenidine, or if I feel there is an associated rigidity, mild brady, then usually Syndopa remains the first drug that I would be talking to them once they agree to start treatment.
Just to add, first for the PDs, so what is this fine? There is somebody in the stage one without any affection of activity that they do. That's when we call it mild Parkinson. That's like maybe just unilateral trauma or reduced arms. That doesn't affect his normal activities. As long as it doesn't affect his activities of daily living, yes, that's a mild Parkinson.
So does the age of the patient have a bearing? For example, somebody who's at 40 comes with the tremors, rest tremors, and one at the age of 70 comes with rest tremors. So will there be any difference in your approach to treating them?
Yeah, that's very important because you know Parkinson's disease is going to be a lifelong part. So you have to give him treatment for a long time. So the treatment depends upon the age of onset of disease. So somebody who comes with a myopathy or a juvenile Parkinson's, you can imagine from 20 years till whole of his lifetime, or 40 years till whole of his lifetime, we are giving treatment. And the treatment options that we have, medical treatment as of the drug treatment, are basically either dopamine in the form of levodopa, carbidopa combinations, or dopamine agonists or any of the small inhibitors, TLP, all those things, anticholinergics. So the basic main problem with the treatment with the dopamine is the side effects which they develop after 2 years. So there are about 50% of them develop dystonia after 4 years of treatment with at least 400 milligrams. So after 4 years, if you're going to develop symptoms of dystonia or motor response fluctuations, then that's going to be a big headache for that patient. So ideally, if it is a young patient who comes with a Parkinson's disease, symptoms either tremor or rigidity or bradykinesia, you can think of starting the patients on non-lethal drugs like the anticholinergics like Pediatric or even Neuro inhibitors. That's in the initial stages. And as this is progressed, then you can go on to Neuro. But if it is somebody who comes with a Parkinson's disease, they are at the age of 60 years, you can most likely the best to start with the liver, because we don't expect them to develop. Anybody can develop dystonia even in the initial stages of treatment too. But then you can always change the drug at that time. But it's always better to start with levodopa and then the LW.
So, as you clearly said, it depends on the age of onset as well as the presenting symptoms. If it is tremor predominant, probably you will start with anticholinergic, and if it's mainly rigidity and hypokinesia, you'll start with a dopamine agonist in the younger age group, and probably with levodopa straight away in an older age group. So what is the role of drugs like rasagiline and seligiline at the onset of the disease? Would you use it on every patient, or would you not use it at all? What is your take on rasagiline, seligiline?
So these are sort of neuroprotectives. So seligiline and rasagiline have been shown to reduce the free radical damage. So initial part, we can start off any one of them, rasagiline or seligiline. And whether it delays progression of the disease is still not known. But the initial part, we can start off either syndopa, that is levodopa, carbidopa, along with rasagiline. So that can be the initial drugs that can be started.
So would it be indicated in all patients, or will you use it in every patient, or?
It can be used, but rasagiline and seligiline, like other dopamine agonists, can cause psychiatric side effects. They can cause gambling, then addictions. So that has to be seen if the patient develops. If they develop, it has to be stopped.
So once you have decided to start on dopaminergic drugs, either dopamine agonist or levodopa, so initially, which one would you prefer, immediate acting drug or a long acting drug during the initial stage of the disease? Once you decide to start, whether you would start with the immediate acting or a sustained release preparation?
Sir, across the board, I think whether it's a young onset or a late onset Parkinson's, most of the time we start with immediate acting drugs. The role of the extended release preparations actually comes up a little later in the illness when they start developing motor fluctuations and all that. Probably the only time I use a long-acting drug is when we use it at night, so that when they wake up in their morning, they get their early morning boost. It helps to avoid their early morning dystonias. But for most of the time, I prefer to use immediate release preparations throughout the day, whether it is the levodopa or the dopaminergic drugs.
So would you use a combination of levodopa and dopamine agonists? So initially you started one drug. So would you keep raising that particular drug, or would you add levodopa, carbidopa? That is.
So most of the time, sir, if it's a young onset or it's a late onset, I'm a general neurologist. Dr. Praveen is a movement disorders. Dr. Somala is general. So what I do is that I generally start patients on syndopa, levodopa first, whether it's young onset or late onset, because sometimes seeing the response to the drug gives us a lot of clues. Sometimes people who don't respond well to Syndopa is a red herring in advance. Tell us that this may not be run-of-the-mill Parkinson's disease, maybe the very early presentation of some Parkinson's plus syndrome. So I generally start them on Syndopa. But then we know that in young onset Parkinson's patients, the incidence of dyskinesias tends to occur much earlier. So once I am clear that I am dealing with only a YOPD and nothing else, I gradually talk to them about moving to the dopaminergic drugs and move over to either to pramipexole or to the ropinirole. And in the elderly people, I generally go with Syndopa, 55 and 60 above, I go with Syndopa. We titrate it very slowly. We start with half a tablet twice a day, then thrice a day, and gradually titrate it to the requirements. I always tell the patients that, see, we are not here to make you run an Olympic or anything. We want you to be independent in all your daily activities. So we titrate those to the requirement. The role of dopaminergics in elderly people, I bring it on a little later when we start to see slowly the motor fluctuations, the dyskinesias, and all that. That's how I do it.
So this dopamine agonists are really helpful for restless leg syndrome. So if a person has restless leg syndrome, then long-acting either levodopa, carbidopa at night or pramipexole. Pramipexole has been found to be very effective for RLS. So that is one of the indications to start pramipexole earlier.
So what is the goal of treatment in the mild, moderate stage? So you have started drugs. So is it to eliminate symptoms, to make the person normal? Or what is the, how much of drug will you use? What is the goal of treatment?
So yeah, the patient should be independent for his daily activities. That would be the main aim, and reduce the symptoms as much as possible. So the dosage has to be titrated. Usually we titrate it very slowly because Syndopa can have gastrointestinal side effects that can cause giddiness. So the patient to get adjusted to medicine takes some time. So the usual dose is 300 mg, and we wait for at least 3 months for the response. And after 3 months, we can increase or reduce based on the side effects or the basic functionality of the patient. So that would be the main aim, so that the patient can do his daily work without any problems.
So this is very important.
The simple thing is that, the patient not have too much of side effects with the drug, and he should be able to do his activities of daily living without any. Exactly. You don't aim at making the tremor zero. If you try to do that by increasing the dosage, you are looking at right. If that might be a little bit of tremor, there might be a little bit of bradycardia, but if he is independent in an area, that is fine. That is your endpoint.
So that's a very important point you have mentioned, sir. Because patients' expectations are high. Sometimes they want to be normal, especially the younger the patient. So invariably, they keep coming frequently and they get over-treated to make them all the symptoms disappear. So that is one of the reasons they go early into complications, motor fluctuations. So at the start itself, we have to have the trust with the patient, tell them that it's a disease we have to treat for the next 20 years. And it is not you are being symptom-free today, which is important. So you should have a reasonable quality of life over the next couple of decades. So we have to give a realistic idea to the patient what is expected. It's not 100% normality, but to be symptom-free reasonably. And minor tremors can always be, they have to accept that many times the patient's spouse will be more worried and they'll be complaining more about these tremors. It's an embarrassment for the other relatives. So they will try to push, but we have to resist that, tell them that say 80 to 90% improvement is something which is the reasonable compromise. The next one, once we have decided to increase the dose as the disease progresses and patient continues to have symptoms, patients develop off, patient develop wearing off. So how do we go about increasing or altering the treatment?
There are two things that can be done here. One is increasing the dosage of the level to a maximum tolerated dose, or trying to change the formulation. or after trying to change the formulation of levodopa, or add the other drugs, like Dr. Vikram had earlier told, we would add dopamine agonist, or we would add now inhibitors. But all this depends upon, see, basically, the treatment of Parkinson's disease has to be individual. We cannot put a blanket treatment for it. It depends on the patient, how he is tolerating the treatment. And depending upon that, we may have to take into account all these factors and then decide on what to do next. So either we can increase the dosage, for instance, and that depends on whether he is developing some. If he is having an early wearing off, then you can increase, you can change over to the control, or you can increase the time duration between two doses. So these are the things that need to be taken into account. So for an individual, what is happening, depending on that, you can either change the dose, change the formulation, or add dopa agonist to that. Dopa agonist or novel inhibitors or COMT.
So the role of COMT inhibitors, would you start it at the onset of the time when you start levodopa, or only later when they develop wearing out?
I would generally put all patients on immediate release syndopa, levodopa, and as time goes by, if we start finding that we are starting to see what are called as wearing off phenomena, the motor fluctuations as we call it. Now we would like the levodopa to work for a little longer duration. So that's the time when actually I bring in the use of the COMT inhibitors, because by default, when you use it along, it prolongs the action of the levodopa. So I don't bring it early. There have been studies where they have tried to use it very early with the intention of whether you can keep the dose of levodopa low, but that is not found to be effective. So it's not required. People do well with immediate release levodopa, but when wearing off sets in, that's when you would bring in COMT.
That's again an important point, because in 2000, when COMT inhibitors were introduced, so the main claim was that it is going to delay the dyskinesias, it is going to reduce the complications of levodopa usage, but it never happened. Actually, it was not found to have that sort of a protective effect. So COMT inhibitors are not indicated at the onset of the disease. So only later, when they develop wearing off and other resistance relative to levodopa, we add COMT inhibitors.
Nowadays, the development is hardly
Yes.
So mostly it is entire.
So most neurologists don't use COMT inhibitors. So what about the role of amantadine in the treatment of Parkinson disease?
Amantadine can be used as a standalone, especially in very mild symptoms, or it can be added on to levodopa carbidopa. And it has been shown to reduce dyskinesias. So it has multiple mechanisms of action. One is it is this adenosine receptor antagonist. Then it also has dopaminergic activity. So because it has multiple things, it can act on various levels. And now there is also an extended release formulation that acts throughout the day. So that is a once daily dosing. So that is more helpful rather than twice, because the evening dose is shown to cause nightmares. So after 4 or 5 o'clock, we don't recommend giving amantadine. So if you give a morning dose, that will act throughout the day. And as the night progresses, the concentration will come down. So the extended release will be more helpful, I feel.
And the experiences.
Depends on the age of the, give it to an elderly patient, especially at night, it come a lot of health issues. So these things also have a different from when you start. And yes, of course, it can also cause a lot of anticoagulation side effects. So elderly persons will be at a risk of developing these problems with amantadine. So we have to be a little careful when you start with amantadine. But definitely, it's a very good drug, especially those patients who are developing dyskinesia due to the levodopa.
The two drugs that we talked about, just 2 points here. One is amantadine, as told earlier. I even now see patients having prescriptions of amantadine 100 milligram TID. And if you talk to these patients, they're all taking it at night. Then they come to us with all sorts of sleep issues and all that. So usually the last dose is before 5 in the evening. Basically before sunset, if you take it as benefits. I have not much experience with the controlled release, but that's what we do. And second is we also see a lot of patients who keep getting trihexyphenidyl even after the age of 70. And they come up with lots of problems. I think general physicians are very happy to use trihexyphenidyl. So these patients, when they're above the age of 70, will come with prostate, urine issues, confusion, visual disturbances. So I think we need to cut down the use of these drugs beyond a certain age.
So those are very good points. So anybody with Parkinson develops confusion, sleep disturbance, and hallucination, first drug to stop is trihexyphenidyl, and the next is amantadine. So what is the what's your experience with apomorphine? What is the role of apomorphine?
Is used for advanced stages, especially in those people where there is a delay in doing DBS or they are not willing for DBS. So in these cases, they have very severe motor fluctuations. And apomorphine bypasses the gut. So it is given as a subcutaneous injection. So it enters the bloodstream directly. And it is a prodrug of dopamine. So the results are miraculous, but short lasting. So the effect lasts for only for 1 to 1.5 hours. And it can be given as two methods. One is an injection that the patient can inject himself. That is like a rescue therapy. When the patient suddenly goes into off state, he can take it himself. And then he can go about his daily activities. And the other is a continuous infusion. So the drawback with the continuous infusion is the patient or the attenders have to prick themselves daily. So it is a subcutaneous IV line. So they have to prick themselves daily. And then the infusion will go on for 10 to 12 hours as the patient demands. And the side effects are very similar to dopamine. It causes postural hypotension and it can cause vomiting at higher doses. And dyskinesias can be worsened. So apomorphine is a good drug, but there are a lot of complications related to injections, and infection can occur if not properly cleaned, if the site is not properly cleaned.
Can I ask you, see, there may be some, we know we have been called to see post pre-operative cases of Parkinson's disease who are going to go and undergo a gut surgery. Okay, so they're not able to take anything orally. Can apomorphine be used in such cases?
Swallowing difficulties, patients with swallowing.
They will not be taking.
Yeah, a trial can be given. But if the swallowing is a lot involved and the patient has been decompensated or something.
Because the patient is already on a chronic Parkinson's disease on treatment with all
Yeah.
of a high dose.
Yes.
Suddenly you stop that. What is going to be the effect?
If-
You don't have any other alternative.
If he is responding to dopamine, he is likely to respond to apomorphine. But if the response to dopamine is already reduced, then he may not. Then the duodenal levodopa can be tried. But that in India is still not.
So we'll go to the next one. It's a very important one. Dopaminergic therapy induce behavioral changes and psychosis. Frequency management and alternative therapies.
Usually these problems are more common with dopa agonists and anticholinergics, though it can happen with levodopa also as a it's common with all, but most commonly with dopa agonists and as well as anticholinergics and even MAO as well as amantadine. All of them can produce behavioral disturbance. There are several types of behavioral disturbances ranging from frank psychosis to sleep, random REM sleep disorder, behavioral disorders, and hallucinations, delusions. And then they also have this funding and excessive gambling, excessive eating, hypersexuality. All these are side effects that you usually seen with most of these drugs. Now, if it's on a single drug, then the option is to change that or reduce the dosage of the drug, or you can increase the frequency of the drug or reduce the dosage of each dose, and then try giving
antipsychotic drugs. The usual antipsychotic drugs that would be useful in such cases would be either quetiapine or clozapine, not the atypical antipsychotics. So they can be given in such cases. And those with this sort of REM sleep behavior disorders, they would respond more to clonazepam given at night. So that this is very common, especially in the elderly who come with any of these drugs. Even levodopa at the later stage they can develop hallucinations. The other one thing that Dr. Vikram had highlighted earlier is we try to avoid giving or do not give these drugs after 5 in the evening. That then you can avoid this nocturnal hallucinations and sleep disturbances.
So clozapine versus quetiapine. Which one would you?
I think quetiapine is what I use maximum in practice. Clozapine is also a very good drug and I think helps a lot when there are dystonia. That's where clozapine has a role. But yeah, you have to do a lot of hematological monitoring for it. So it's quetiapine and I think one of the other drugs which is there in our Inauguration, but not yet easily available for us. That is, I think, a new drug which is recommended for at least psychosis and Parkinson.
So many don't use clozapine because of the risk of neutropenia. Usually neutropenia happened when it was used for schizophrenia, where doses of 250 to 500 milligrams were used. Usually in Parkinson, hardly 25 milligrams is used. Even in neutropenia due to high dose, the treatment is to reduce the dose. If at 500 milligrams they develop neutropenia, if you reduce to 250, it may go. So I feel clozapine is underutilized as a treatment for whatever reason. I have used a lot of clozapine and I have not seen a single patient developing neutropenia. And any experience with pimavanserin? I think it's not available in India officially, but I think unofficially it is available. It is supposed to have less motor effect than quetiapine. What is the medical management of orthostatic hypotension in PD?
First, we go to the non-medical management. These patients are these patients are the Parkinson's disease patients who are on these drugs. Any of them, again, all of these drugs, all of them can produce this effect, but most commonly with dopa agonists and MAO agonists. So these patients should be taught physical therapy to increase the muscle activity of the body. They should be taught how to get out of bed, to avoid suddenly getting up from the bed. So using things, these are the first line of treatment, and then go for drug treatment, medical management of these drugs of orthostatic hypotension, and then those drugs that are usually used are protocorticoid or midodrine. These are the two drugs which we normally use. Then we also there are also approaches where you can increase the fluid intake and salt intake. That is there as non-medical management. But the drugs usually that we use are either protocorticoid or midodrine.
So midodrine, one thing to keep in mind is not to give beyond 6 o'clock in the evening. And again, it will cause supine hypertension and it may cause complications because of it.
So the other one is patients, younger patients who need levodopa, but who have severe gastrointestinal issues. They have severe nausea, dizziness, and some people refuse to take levodopa. So what do you do in such patients?
So, we can challenge with lower doses, maybe half tablet once in the morning. And sometimes we tell them just before food also, because we usually tell to give a gap of 1 hour before food or 2 hours after food. So maybe they can take 2 hours after food or just with food, but the effect may not be as good as taking before food. But that is one of the way to balance. And we can increase very slowly, like half tablet every 1 week or 2 weeks based on the response.
I believe we have patients just those like side effects, the causes of doctor shopping is side effects. If you don't talk to them in advance, then that's what's going to happen. So go lot of patients are told that, don't mix your medicines with proteins and with food, but the effect comes down. One of the things I do is when I treat patients for the first time, I ask them to take it with food. So it gives them not as best effect, but it gives them a good effect, and the nausea is much less. And once they gradually are used to the drug, they don't complain, we gradually talk to them about spacing it out and avoiding protein use. If we tell them on day one that please take the tablet half an hour, 1 hour before breakfast, invariably they will complain about nausea and something. And I use domperidone also for some time in these patients. You can't really do it, but that's the peripheral activity, so that does work for them. So if we gradually introduce the drug, low doses, and give them these kind of suggestions, they tackle the drug much better.
So especially we see a lot of Northeast patients where this gastric problems and all are very rampant. So we start them on levodopa, they come back with increased Parkinson symptom. Then if you see the prescription, they'll be in addition on Somprazel. So we see that very, very commonly. So sometimes patients prefer to have the tremors and hypokinesia rather than the gastric symptoms. Sometimes we have to go for a compromise. And so regarding the newer treatment or prospects in PD, anything coming up?
There is a long-acting COMT inhibitor called opicapone. So that is a once daily dosing that has yet to come to India. And istradefylline is another one. That is an alternate method. It is an adenosine receptor agonist. So those two are yet to come to India. So those are awaited. And the other thing is inhaled levodopa. So that is there in the US, but still not marketed here. And the other is intestinal levodopa.
Okay, so we'll open.
I think it was very useful and informative discussion. What is the opinion on coenzyme Q? Like we see, many people using it. And so what do you feel about using coenzyme Q?
It is not proven to delay disease, but because free radicals, the research has shown that there is free radical damage. A lot of people tend to use multivitamins and then CoQ. And there is some amount of mitochondrial dysfunction also. So whatever works, I mean, they continue to use it, but it's not proven to improve the outcomes.
A lot of other drugs, though, like, not so many other drugs, vitamin E, all this, there are in some studies showing some effect, but they are not proven without beyond that they can delay the progression. Just some reports.
One more drug we used to commonly use is trivastal LA, pyribydyl. Now I think the usage has come down, but patients who were taking, they still feel good. So what is the current?
Pyribydyl is quite good against and it was recommended as an early drug that should be used in early. It's not recommended. I have not seen in recommended now. So there are some issues.
Sir, one comment here. In our forum, in our NEMANS forum, once there was a discussion about this impulse control disorder and about the pathological gambling. When it came, I started telling my patients. Till the time, though we have read in book, we have never practiced it. I'm not sure how many of us will be definitely telling our patients about this side effect. I started that trend. And within a month, one of the patients who came to me, having been treated elsewhere for about 2 years, he came to me, I told the family. I told the wife, just look at this. You have to believe this, that she went to the account in the last 1 year, he had lost 1.7 crores, not 1 or 2 money. Pathologically, he has been giving it away. And the family came to me, then we made a police complaint and they could recover, still 30-40 lakhs lost. So practical point is to tell them nowadays I have a fixed thing that, there is a fixed statement that will come. Already discussed with the family about the banking details. I tell them all the wife should check the husband's accounts every day or every week, whatever time they choose. It's important practical advice I learned from our demands forum. Thanks to them. Then the second is about nowadays there are papers about homocysteine elevation with levodopa, about B12 deficiency. What are we supposed to do about it? And the third is a comment I would like to know about this tetrahydrocannabinol. They're talking about refractory tremors being treated with that.
Data is there about homocysteine and B12. Therefore, it's recommended to supplement them with vitamin B12 supplements. Regarding the cannabinoids, I think at least whatever I have read, since now cannabinoids is coming into the country for epilepsy and all, same thing has been used even in Parkinson's, but the data says that it improves their quality of their symptoms, not Parkinsonian symptoms, non-motor, improves their sleep, improves their mood. General wellness is their feeling of well-being. So I guess that comes with any form of ganja, whichever way you want to take it. So, but if you want to use it medically, that's what it has shown right now. I don't think it has come out as a drug that works for the pure Parkinsonian symptoms, but overall improves a lot of their. And I think like recently in some of our groups, I don't know how many of you people get patients will come to you with Ayurvedic treatment and they will have Zandopa in their hands. We have so many times patients because the patients thinks Ayurvedic has no side effects. So they'll come and sit with us with Zandopa, which is a Ayurvedic preparation of Zindopa. And you realize whenever we nowadays, I have learned to ask patients if I see dyskinesias and all occurring very early, I ask them, are you on any other supplements? And very often they will say that we are taking some Ayurvedic medicines. So when they take Zandopa, which is a very easily available brand, you realize that they are actually overdosing themselves with the dopa. And that's what brings out some of these fluctuations and dyskinesias pretty early. So I think that is one thing to keep in mind. And if there is time, just 30 seconds, one small anecdote. I had a patient who was a CEO of a company who was being treated for depression, anxiety for 2 years, had developed Parkinsonian symptoms for about 6 months. And I think he was being treated for it. And already he was, I think 58, 59, there was discussions about next line of therapy, blah, blah, blah. So in the course of our discussion with him, when we talked about alternate drugs, we always talk about use of all this levosulpiride and all that, which is one of the other drugs. Please, all of us should remember, so many of our patients are using PPIs with levosulpiride, left, right, and center, and coming to us with extrapyramidal syndrome. So this patient was interesting because in the course of our conversation, when I asked him, do you have hypertension? He said, no, my BP is normal. So I said, no, are you taking any medicines for it? Then he comes out and says, yes, I am using a Ayurvedic medicine for the treatment of my blood pressure. And interestingly, that Ayurvedic medicine is called as Sarpagandha. Sarpagandha, as you know, is the Rauwolfia serpentina, which is actually how a lot of our allopathic BP drugs have developed. And I had to open Google and show him that Parkinson's and anxiety disorder is the #1 side effect of this drug. And it was very remarkable that just 3 weeks into stopping that medicine, he came walking without any features of Parkinson's at all. So I think this is another thing we need to keep in mind, associated drugs that patients are taking in the course of their illness.
Combined before, irrespective of the dose, when it's combined with the acid media like citrus, this one, the absorption will be more. The studies are there. What is your comment, individual comment upon that one? And second part is, I mean, if you want to touch anything about the juvenile Parkinson's.
Yes, citrus products will improve.
This will be the last question because we are running short of time.
Juvenile Parkinsonism.
Juvenile Parkinson's is similar. We start off with the dopamine agonist first, because the longer we give levodopa, carbidopa, the more motor fluctuations, the earlier motor fluctuations that occur. So we try with the dopamine agonists first. And sometimes we see that juvenile Parkinson has associated symptoms like dystonia. They may have ataxia. and that may be part of a syndrome. So all this will help us to find out that what is the actual syndrome. The treatment as such will not change, but it may help in making a diagnosis of what is syndrome.
Parkinson, how we may have to overcome. Usually that is 70 plus, they do come and already they are under medications.
Can you please repeat that question, sir?
Pardon?
Can you please repeat that question with the mic held here?
They are, so I mean, they are coming with all multiple antihypertensives plus BPH. And when we are giving the this one, especially combinations of this anti-Parkinson's drug, usually they go for avoidance of the urine and postural hypertension. What is the role? We have to antihypertensives, or how we have to manage it? Because usually they'll be coming with multiple
Postural hypertension is a factor that people with Parkinson's have, and therefore their blood pressure treatment needs to be optimized. And definitely all patients who have postural hypertension, which was discussed earlier, another important drug is your prostatic medications.
Yeah.
All your Urimax and combinations are one of the commonest causes of postural hypertension and micturition syncope, not only in Parkinson's, in all elderly people. So you have to have a clarity. I think one more problem in India we face is polypharmacy.
Yeah.
And it takes time to sit with a patient when they are on 10, 15 drugs and go through that. So we have to, that has to be emphasized.
So because the time has already run out, I would like to conclude with one or two things. One thing I would like to reiterate is that as clinicians, please do ask for non-motor symptoms because they are a major contributor to their quality of life. So please do make it a point to ask about constipation, sexual dysfunction, depression, hallucinations, and all this funding and gambling and hypersexuality. Please do make it a point to ask about it. They may not tell. And the other thing is still the routine things work. The general measures work. Diet, exercise, proper sleep, sleep hygiene measures, and exercise daily. So physiotherapy, these are of paramount importance still. So with these 2 points, I would like to conclude the session. Thank you.
I would like to ask the moderator and chairpersons, along with Satish Chandra sir, to come for a photograph. Thank you, sir. Next, we would like to move on to the debate part of our session. With chairpersons, I would like to invite Dr. Praveen Sharma and Dr. Sandeep Nayani to please come up on the stage. I would request Dr. Ravi Mohan sir to moderate the session. So the topic for the debate will be early versus late DBS after the onset of motor fluctuations in Parkinson's disease. And I would request Dr. Ravi Mohan sir to moderate the session and introduce our first speaker.
The first speaker in this debate is Dr. Vijay Shankar. He has an experience of over 7 years in his specialty, and he is quite well known in Chennai. He is practicing at Apollo Hospitals, Greens Road, Chennai. He has proficiency in treating a broad spectrum of neurological issues, ranging from common sleep disorders to rare movement disorders. Among the various conditions he manages, he is recognized for his expertise in treating sleep disorders like insomnia and sleep apnea. He is also interested in diagnosis and treatment of epilepsy. Beyond these issues, Dr. Vijay Shankar demonstrates skill in managing advanced neurological disorders such as dementia, multiple sclerosis, and Parkinson's disease. So I invite him to talk on early DBS for managing Parkinson's disease.
Good evening, everyone, and thanks for Bangalore Apollo Group for inviting us and giving me the opportunity to present about early versus late DBS. So what is advanced Parkinson's disease? When somebody who is having troublesome dyskinesias and off periods, at least 2 hours of off periods, and somebody who is having postural disability during the off period, dystonia with pain, and freezing of gait during the off period. In the non-motor symptoms, somebody who is having sleep time disturbances in the night and significant functional limitation in the activity of daily living. This is one of my patients who is advanced Parkinson's disease, who always used to complain that the tablets are not working, he is not able to get the proper on. So when we subjected them to go for a gastroscopy, and we found that this gentleman, even after 1.5 hours of taking the levodopa, his levodopa is still sitting in the stomach. Full tablet is just sitting in the stomach. It means the absorption of the levodopa is reduced in advanced Parkinson's disease. There are many things which can impair the absorption of levodopa. One, impaired swallowing, the dysphagia, and reduced gastric, the slow transit, which is common in very advanced Parkinson's disease. And the proteins, the high protein always impairs the absorption of levodopa, and it cannot also cross the blood-brain barrier, and the effect of the levodopa will be reduced. And also peripheral breakdown is very, very common with levodopa. And also we see lots of H. pylori can also reduces the absorption of levodopa. So because of that, you can see, yeah, patient will not get the levodopa will not work at all, no on, or sometimes dose failures, or sometimes delayed on, or lots of off periods. It's very, very common. If you look at this picture, almost only 50% of the patients can predict when they are going to become off. Because of the erratic absorption and the advanced disease, at least 40% of the patient cannot predict when they are going to become off. These sudden off or unexpected off is the troubles. They'll have fall, lots of pain, discomfort, lots of complications. This can occur very, very common in our Indian settings. So we all know that the early Parkinson's, the first few years, very nice, just a simple tremors, rigidity, mild slowness, and gait problems can occur. But when the disease advances, we all know that these patients develop urinary problems, orthostatic hypotension, dementia, difficulty in walking, gait, and falls. So when the disease progresses, like after 4 or 5 years, they will be good. Subsequently, they'll develop dyskinesias. In advanced Parkinson, the important thing is they develop the levodopa resistance symptoms, lots of gait problems and dyskinesias of periods. This is very, very troublesome, and the cognitive decline is the problem for us. When initially, first few years, they will require only 2 or 3 levodopas, they'll be really good. But subsequently, when the disease progresses, when they go for the, just go for the point. Okay, pointer is not possible. When they go for the moderate disease, when the patient feels always the tablet is not enough, when you increase the tablet, obviously they will develop the dyskinesias over here. But because of the dyskinesias, when you reduce the medication, if you reduce the medications, they will have lots of off periods here. So it is a double-edged weapon. If you increase, they'll develop dyskinesias. If you decrease, they will develop off periods. So the therapeutic window, the good time is very, very narrow for us. So we need to continue the tablet, reduce the medication, adjust the medication, keeping the patients between the narrow therapeutic window. It's pretty difficult for us. So now, when to subject the patients for advanced therapies? The Delphi criteria is very, very clear. When somebody who is on 5 tablets of levodopa, 2 hours the tablets is not working, off period. 1 hour they have troublesome dyskinesia. You can try to increase this medication. If the medication is not improving, helping him, go for advanced therapies. That's very, very clear. The criteria is clear nowadays. So what best medical therapy versus DBS? The comparison has been done almost in 2009 itself. In this article, they clearly proved that DBS is superior to the best medical therapy. DBS can improve almost 4.5 hours of on period. 4.5 hours of on period. The patient usually wakes around, like awake for almost 15 hours, something like that. In this 4 hours, 1/3 of the day is improving, means this is going to be a significant benefit for the patient. So 4.5 hours is dramatically life-changing for the patient. And also, when not only DBS plus best medical therapy, this study was done in 2010, has clearly proved that DBS plus best medical therapy is significantly better than the best medical therapy alone. It was proven almost 1.5 decades prior to now. And also, in Indian scenario, what is the best therapy, medical therapy in India? Let us see what is the statistics. In NIMANS, this study was done in 800 patients. Almost 80% of the diagnosis was diagnosed by a general practitioner and internist. It means it is difficult for them to diagnose the Parkinson's disease earlier. Especially when they have tremors, they will say senile tremors. They will not diagnose. Unless the patient becomes more tremors, then only they will diagnose and refer to a neurologist. The other way around. Look at the akinetic rigid syndrome. They are most troublesome patient. They don't know what they are having. The GP also doesn't know what is they are having. So unless otherwise the disease becomes more severe, then only they recognize this patient. At least after 3 to 4 years, only they will come to your neurologist to get the treatment. And also, if you look at this patient, 20%, even though they diagnose the patients, 20% of the patients are not on any medications. So it means even though they diagnose, they don't want to start the treatment, or patient does not want to start the treatment. So it means 20% of the patients are deprived of medications. And also, most of the patients are discontinued the medication because of short duration of illness, low socioeconomic status, and the important thing is, again and again, stressing akinetic rigid syndrome. Almost 70% of the patients are discontinuing the medication or irregular medication, poor compliance. Most of the patients in India, they will skip the medication. And even though if you ask 4 tablets, means they never want to increase the levodopa more than 3 tablets. 3 tablets, if I want to, how many of you notice that increasing the 3rd tablet to 4th tablet, you will talk to 15 minutes to convince the patient. So this is the status of the best medical therapy in India. And also, if you give 4th tablet or 5th tablet, immediately they will change the neurologist. They go to somebody else who is giving 2 tablets. That's what commonly happening in India. So this is the state of our best medical therapy. And also, most of the patient, if you ask them to take the levodopa, if you ask invariably treated by somebody else, most of the patients will take the levodopa after the food. This is routine standard practice. If you say that take the levodopa before the food, sir, nobody has told me. So how can you expect a best medical therapy in India in this scenario? So this is itself a question mark. Look at this study. So this study, yearly levodopa compared with a dopamine sparing therapy. If you look at this, see, they started the levodopa earlier. First 2 or 3 years, 2 years, they had a good benefit. After 3rd year, they required more levodopa, more levodopa, more levodopa. When they started on levodopa sparing therapy, like a dopamine agonist or rasagiline, see, first, because the effect is very mild, they don't feel the typical on and off with the levodopa. So at least 3-4 years, they will be really good. After 4 or 5 years, they require more levodopa. So they also require more medications. But the important thing is, if you treat with yearly levodopa, the cumulative disability here is less with yearly levodopa therapy. If you don't treat this patient with adequate or levodopa, the cumulative disability after 5 to 6 years is more. Coming to our point, here the diagnosis itself is delayed, and the best medical therapy is itself a question mark, 2 tablets or T tablets. So it means when somebody is on delayed diagnosis on inadequate treatment, obviously after 5 or 6 years, the cumulative disability is more. So the adequate treatment is very, very important. That too, you should start the treatment yearly. That's what very, very clear. The cumulative disability is reduced if you start the proper treatment earlier. Coming to our point of interest, yearly versus late DBS. So this study was published in 2012. See, if you do one decade ago, everybody thought that DBS is the last resort. So if you do the DBS late, still there may be at some point of time there is no rescue in symptoms, but still the motor symptoms will improve. But their psychosocial condition will not improve if you do a late DBS. If you do an early DBS, obviously their psychosocial condition as well as the motor symptoms will improve. This study was published by my mentor, Dr. Fasano, with Gunther Duschel. And then came the early STEM trial. The early STEM trial clearly showed that if you do a early DBS, the patient quality of life will significantly improve. If you look at this, compared to in the STEM trial, they told that when compared to the best medical therapy, there was almost more than 10 points of improvement in the PD index scores. And also their mobility, activity of daily living, emotional well-being, stigma, body discomfort, social support, cognition, communication, everything improved when compared to the best medical therapy. So they came to a conclusion, if you want to do a DBS, the 5 to 10 years, the mid stage is the best time to do the DBS. Don't delay. If you delay more than 10 years, DBS may not be an option at all. Don't push the DBS for an advanced stage. Do it early. That's the conclusion. Who are all the best candidates for DBS? The typical Parkinson's symptoms like tremor, rigidity, bradykinesia, freezing, motor fluctuations, off periods, troublesome dyskinesia. The important thing is age less than 70 years, Parkinson's symptom, 4 years duration, and 4 months of complication. These DBS will improve the tremor, rigidity, bradykinesia, gait, especially important. Levodopa responsive freezing will improve with DBS. Levodopa non-responsive freezing will not improve with DBS. Dyskinesia will improve. Off periods will improve. Medications can be reduced up to 70%, and the quality of life will significantly improve. DBS not only improves the motor symptom. If you look at the Neuro trial by our Ray Chaudhary, he has clearly showed that it can improve the sleep, non-motor symptoms like sleep and fatigue, mood and cognition, perceptual problems, hallucination, because we are able to reduce the medication significantly, so they can improve. The hallucination can improve. Urinary and sexual dysfunction can also improve. Let's come to the conclusion again. Yearly versus late DBS. Look at this study. Those patients who has underwent a earlier DBS show sustained improvement in activities of daily living and motor complication, never reaching the severe levels of disability reported by the late DBS patients. So significantly, they'll have a good quality of life when compared to the late DBS. And also after 8 years of follow-up, this is 8 years is almost significant in any patient. The earlier stimulated group still reported almost 29% lower impairment of activities of daily living, almost 44% lower duration of waking day because of the off period. It means it has a significant benefit even after 8 years. And also this study has compared levodopa versus DBS. Both are almost similar, but when you combine the both, they both had a best effect significantly better than the best medical therapy alone. So our aim is DBS alone is not enough, like drinking a black coffee, or just medication alone like a milk. We don't like it. Combine like a sugar, the best filter coffee. We are South Indians. We love the best filter coffees. So you should give me a best filter coffee, like a combination is the best thing. What is the 5 years outcome of early DBS? The class 2 evidence clearly shows that early DBS reduce the need of complexity of the Parkinson's medication, long-term motor benefit over the standard medical therapy. And it has a class 2 evidence implanted early stage decreases the risk of disease progression and the polypharmacy when compared to the medical therapy alone. So now European guidelines is very, very clear. If you have your advanced therapy, look at this. Just consider offering when it's eligible patient. The patient is really individual based, select the patient. If the patient is fit or cognitive is less, no freezing, no urinary impairment, look for all the probables. If there is something is there, just reject it or go for GPA. STN is not the right choice. And also early Parkinson's fluctuations can occur. So complications, many people ask about complications. Look at the LMR has done that. Like DBS induces axial symptoms like falls. LMR has looked at the study of patients after DST and DBS. After 1 year, there is no significant difference. But after 10 to 15 years, they tend to develop a gait problems. But this is because of the disease progression rather than the DBS alone. Lots of patients will have a debilitation, off periods for cognition, and the preoperative axial scores. They are all plays a multifactorial, not a DBS alone. And also, sorry, cognition mood, that's a frequent thing we always discuss about it. Even though DBS has an effect on cognition and mood, anxiety, personality, but it is safe. The most often the concept is earlier, we don't know which drug has to be reduced. The common thing, what mistake we earlier do is, before the surgery, we tend to stop all the dopamine agonists. When you stop the dopamine agonist, the patient used to develop depression after the surgery. And if you reduce fast, they'll have lots of anxiety, depression, all these things. And also, after the DBS, we can reduce the medication by 70%. Obviously, we can improve the cognition. Important thing, we can stop the trihexyphenidyl and also the dopamine agonists, so they can develop less of OCDs and they don't lose the 1.5 crores money if you do a yearly DBS. So now we are in the era of directional DBS. So earlier the mains, the speech problems, gait problems occurred because of erroneously placed the electrodes. Now with the advent of directional DBS, if we place the electrode is placed a little bit away, there is lots of side effects. Nowadays, we can turn the stimulation to the opposite side and we can avoid this type of complications easily. And also now we are having the brain sense. We look at the delta wave, beta waves. You can see if the beta waves are more, obviously the patient is having a lot of motor symptoms. If you reduce the beta waves significantly, the patient's symptoms will improve. So we are in the advanced stage. Looking at the older statistics is not going to, it's going to change. Now we are looking at the closed loop. Now we are looking at the patient's sensitive, how we are going to tailor the therapy depending upon every patient in next couple of years. And also look at this. If you do a standard, the patient will have a good honeymoon period for 3 or 4 months, like 4 years. Subsequently, they'll develop a motor complication. If you do a routine time, still the patient will have a first honeymoon and the second honeymoon period of good quality of time. Subsequently, they will develop some automatic problems. But if you do an early DBS, it is very, very clear the second honeymoon period will be prolonged. So this study was done 2 years back, and they clearly showed that there is some effect of DBS on the disease progression. If you do a classic time, there is a possibility of delaying some milestones or slightly prolonging survival because the overall motor symptoms are improving. The overall quality of life is improving. So the patient's quality of life is improving. If you do a early stim, the good quality of life will be better for this patient. They have more symptoms, better quality of life. So other therapies are not equal. Because of time, I'm just skipping it. So do you want to give this patient honeymoon, early honeymoon or late honeymoon? That's the question. If you go for a very late honeymoon, even though if you give honeymoon, they will not enjoy the effect of DBS. So don't delay, do it early. Okay? Earlier is better. Thank you.
Thank you, Dr. Vijay Shankar, for a very lucid presentation on the case for early DBS. We'll have the questions after the rebuttal by Dr. Arvind Sukumaran.
Can you just connect? Oh, fantastic. Nice. Can we take this laptop away? Can we take this?
Dr. Arvind Sukumaran is a neurosurgeon who trained from NIMANS. He's a senior consultant neurosurgeon at Apollo Proton Cancer Center. He has more than 15 years of neurosurgical experience and a large number of cases he has operated. He has special interest in pediatric neurosurgery, epilepsy surgery, functional neurosurgery, and neuro-oncology, apart from spine surgery, microvascular, and skull base. His specialty of interest includes pediatric epilepsy, functional neurosurgeries for PD, and he is one of the right choices to talk on DBS. So please go ahead, Arvind, and give your rebuttal case against early DB.
Yeah. Thanks, Dr. Roy Mohan Rao, for this gracious introduction. I thank the neurosurgical community of Bangalore for graciously hosting this event. So the advantage of talking second after Vijay Shankar is that most of the basics are already covered by him. So I don't think I need to dwell on the same thing. And I did expect that. So the basic thing is do not rush. So surgery is always the second best. If you can do something else, it's better. So it pains as a surgeon for me to say this. However, this is Dr. John Kirkland, a great cardiothoracic surgeon. When he can say that, I can also say that. So we know that DBS is greatly beneficial. So why are we even thinking about when to do, how to do, whether to do or not? It's only because of the risk of unwarranted surgery, as well as the risk of surgery, risk involved in the surgery. So this by Dishel et al. In 2013, there were 186 patients. And they just wanted to know, the first house that I say, the patient comes, I evaluate, and immediately, hey, you need surgery. Not all of them are going to accept. So 45% of them were reluctant. So they analyzed the reasons for why these 45% were reluctant. So the fear of complication was the predominant one, which was with about 74%. And of course, the cost, and about 50%. And this in the Western European nations where they have a plethora of money. So it's even more important considering the economic realities of India. So the basic fact is people are risk averse. So we will digress a bit into the prospect theories. So decisions involving risk have three components. There is a component of risk aversion, there is a risk of loss aversion, and then there is an endowment effect. So the expected value or the outcome or what you expect out of an intervention or an action that you do is basically the chance of that happening, as well as the outcome value which can be multiplied. Sometimes it can be quantified, sometimes it cannot be. So what exactly is the risk averseness? 1% chance of winning 100 rupees or a 0.1% chance of winning 1,000 or a 0.001% chance of winning a 1 lakh are exactly the same if you just calculate it as the expected value, which is almost the same as a large meningioma where there is a possibility of a cure versus the small risk of hemiparesis. So what do you think a patient is going to take? It is the same thing. If a patient is risk averse, he will not want surgery, just as that the guy who will simply take the 1% with the 100 rupees. And the next thing is the loss aversion. When I lose something, if there's a pickpocket who kind of robs me of 100,000 bucks, I will do more than that, more than my winning 100,000 by lottery. So this is sheer psychology. There is no hardcore basis for this. And then there is an endowment effect, which means you always value what you already have much more than what you could possibly have, which means you always expect a much higher selling price for your old car. Unfortunately, that never happens. So the same thing in a Parkinsonian paradigm, it's a present destination is much better than the possible post-operative deficits. So now, after having talked about so much about the risks involved, we should definitely know what are the risks involved. No surgery is without side effects. So when we looked at such a large number of trajectories, there is about almost 10,000 trajectories. The intracerebral hematoma chance per trajectory was about 1.57%. So which means whenever you're doing a bilateral DBS, the chances are about 3% for them to have a hematoma. And then, of course, the permanent or serious deficits only 0.41%. So I'm not going to dwell on each one of the complications. I'm sure all of us know that. But however, this slide is only to say that, yes, there is complications and risks involved with deep brain stimulation. So having said that, what are the factors that might influence a patient or even a doctor to decide upon something as invasive as a deep brain stimulation? First, let's come to the doctor factor, which is context framing. So when the doctor, let's just take a hypothetical example. If I'm saying that when there are 300 people who are about to die, I can say to someone who does an action or pulling the plug, I can say that you can save 100 people. He might do it. But if I say you're going to fail in 2/3 of the cases, then he might not do it. So this, I would say, is as a context framing. Then the confidence on self. Many a times, even if there might be a neurosurgeon who is not well versed with deep brain stimulation, but when someone might refer to him, he might not actually refer that patient for surgery. He might want to try various other methods, or he might even send back to the neurologist saying this might be indicated or not. So this is also confidence as well as the knowledge level of the doctor. And also the prior, especially the recent experience. If there has been a catastrophic outcome in the previous case, you're going to think twice or thrice even before embarking on the next case. So next, going to the patient factor, what are it is? It is the personality of the patient. Generally, men have a better risk-taking ability. And there are studies that say that men agree more upfront than women. And in the younger age, there is more to gain, but at the same time, there is also more to lose. So even these are the patients who might be ready to take a high risk for in favor of surgery. And of course, we're also giving them dopamine agonists, and there has been a lot of talk regarding how they can lead to pathological gambling. So when they are pathologically gambling to give away their money, there is a high chance that they're going to gamble for going through a surgery. So they will agree for surgery generally. This has not been studied though. It's my hypothesis. I mean, any large center can really take this up. So how many of the patients do even require a deep brain stimulation? So there was a multi-center cross-sectional observation study with about 2,600 patients. APDs, advanced Parkinson's disease, and the others were they were not advanced. They were either early or mild. So 51, this is at a cross-sectional level. So they were at any given time. Probably you can say that 51% of your patients fall under the advanced Parkinson disease. And DAT is nothing but device aided treatment, which means it could be anything. It could be deep brain stimulation, the levodopa pump, the gel, or focus ultrasound, any of these things. And among the advanced Parkinson disease, 66% of the patients needed the device-associated therapy, while only 10% in the non-APD group required that. However, we can also see that in the same APD, almost 11, the mean duration from diagnosis was 11 years for the advanced guys. And naturally, it would be much less, and it's only about 4.3 years in the non-APD. Mind you, this 4.3 years is the time from the diagnosis, which strictly falls in the early STIM criteria, to which we will come now. So I was sure Vijay will be talking about the first RCT that clearly elucidates the benefit of DBS. So I'm not going to go into that. But however, I'm going to go into the other pivotal study beyond which, after which we kind of shifted to a relatively early phase, an early DBS. So they randomized about 110 patients on each wing, and they calculated various parameters, and they clearly proved that early stimulation is better. So why do we consider only this study? That's because the mean duration from diagnosis was 7.5 years, and all the prior randomized control trials were about 11 to 13 years. The mean age was 52, which is much younger than the almost 60-year-old patients. And this was done even when the medicines were effective. And this was one of the best done studies. It was meticulously planned and executed. So this clearly shows that the earlier intervention is better. So why am I talking about this? So the next stage is, okay, fine. Now from 13 years, I've come to 4 years. Why don't I do it early? I'm seeing a patient. Why don't I do it immediately? So that's what is the ultra early surgery. Medications are very effective, but we are not even sure whether it's a clear case of pure PD. So this study was done by, so the previous study was basically from the Vanderbilt University, where they propagated the ultra early surgery, which was universally panned. And now considering the 6 high-powered RCTs, they've identified that there is going to be a ceiling effect of the Honan-Yar scoring. So the best improvement is seen when your HNH is about 4 or 4 and 5. However, if it is about only 2.5, you're not going to have much benefit. So why are you doing it early? You're not accruing much bang for the buck. So, okay, well, maybe there is a neuroprotection if I do it early. No, actually no. There are two studies that study radiologically as well as clinically. The first one is about the radiological. They use the PET scan, and they found that there is absolutely no difference in the early and the late stimulation. And there was also a clinical study that again clearly indicates that there is no long-term neuroprotective effect secondary to an early DBS intervention. So, okay, now we are saying, okay, fine, let's talk about the cost effectiveness. So I'm just bringing out this German economy based study only because it's very well done study. There have been multiple countries have done similar studies, including Taiwan and recently China, but there is always some kind of a cynicism. We always trust the Europeans, and therefore I'm just talking about this. So what they've identified is the incremental cost utility ratio is favorable towards surgery only when it is about $22,000, 22,000 euros. If it is going to be more than that, it just means that you're spending that much extra for DBS. Considering the fact that India's GDP is much low, the per capita is much lower, and especially the cost of medical therapy, including the medicines as well as the medical concentration fees are much lower. Probably this 22K is not will not reflect the true economic reality in India. So it's going to be much higher. So the next thing is, so what are we going to do? We cannot predict the future. Are you sure of what? Of idiopathic? Are you sure it's an idiopathic Parkinson disease? Maybe not. About 5 of 31 patients, all these 31 patients had come for poor outcome. And out of the 31 PD patients, 5 of them had other diseases. That is multisystem atrophy, PSP, PD plus, including dementia or corticobasal degeneration. And all these patients had a disease duration of more than 4 years. And 75% of them had already even seen a movement disorder specialist. Even within that often quoted the early STIM cohort, 3 of the patients were diagnosed as non-PD diseases from 15 years of onset, despite their extremely strict inclusion criteria. So what it means to say is that in the initial response, okay, you put the DBS and the patient improves immediately. That doesn't mean it is PD, and then they're going to have a long-term success. The initial response does not equate to success, and that it is also Parkinson disease. So second question is, are you sure that the motor complication make one a direct candidate for surgery? Even that is not necessary. Out of 158 patients with a 5-year follow-up, 52% had motor complication, with 49% having dyskinesia, 23% having fluctuation. And medical reversal was seen in about 47%, and fluctuation was reversed in about 37% just with medication without having to resort to deep brain stimulation. And similarly, there was a very long-term follow-up study with a 15 years follow-up of 52 patients, out of which 96% had motor complications. It's an evolution of the disease, which is not really surprising. However, 54% of the patients reported it as non-disabling, while only 12% reported it as severe. But then again, it's always said that the value of the shade is known when you're in the only when you have experienced it. Similarly, most of the patients will have normalized their suffering, and they might not know. So I wouldn't take it. This was more of a subjective statement. So we cannot take too much into it. However, 54% felt that it did not affect them. So that's why I say early deep brain stimulation has to be carefully evaluated and proceeded with. Less than 4 years, please don't even do it. And if there are less than 3 years of motor complications, please be very, very, very careful before you embark on the surgery. Thank you.
Thank you. Thank you very much, Arvind, for your very effective rebuttal. I throw the debate open. We have a short discussion time in view of the time we have to start our inauguration shortly. So I'll ask a few questions to both of you individually. Dr. Vijay Shankar, in view of treating Parkinson's plus with DBS, when you do early DBS, What is your view, in your opinion, when is the best time to do early DBS?
So when somebody who is having a clear Parkinson's phenotype, like lots of tremors, I will go for yearly DBS. When somebody who is having a akintic rigid syndrome, or somebody who has yearly falls, slump slide, cognitive impairment, confusion, or yearly urinary impairment, I'll ask them, whatever. These patients tend to come yearly. You know that the typical tremor
So
patient, they will
you
say,
wait at least 2 years.
at least wait 2 or 3 more years. Till that time, I'll sure that at least within 4 years, most of the MSA, PSP will be evident.
So
But
both of you
sometimes-
agree before 4 years, don't do DBS?
No. 4 years, beyond less than 4 years, less likely. Maybe sometimes 3.5 years, sometimes if the tremor predominant, like severe tremors, we know that surely it's PD, but less than 4 years, no.
Dr. Arvind, you talked about the risks of doing DBS. Are there any strategies? The risks are related to the number of MER electrodes passed. So do you do MER routinely for all DBS, or do you do it without MER based on anatomical targeting?
So, the anatomical targeting is clearly shown that it is not the same. The physiological subthalamic nucleus is not exactly the same as anatomical. So, yes, there have been many studies, especially from Umeå University in Sweden, where they do a sleep DBS. However, even in their series, as well as in many of series from Canada, from Toronto and everywhere, there is more than 20 to 23% chance of a misplaced electrode. Even just with even when they're doing the MER, they are not using the central trajectory. So with this insight, I'm quite uncomfortable doing non-MER DBS, especially when the subthalamic when it's an STN. That actually lends yourself to be more accurate. So why look a gift horse in its mouth? It's allowing us to check intraoperatively, make use of it. So I always prefer an MER-based one. Having said that, there is also many reports that say that the number of electrodes have an increasing hematoma. But even
The
among
number
those
of passes.
number of passes, yeah. For example, 5 times, if there are 5 electrodes, then definitely the chance of hematoma are higher than if I'm going to place only 3. So these 3 MER tracks if I'm using. So, but even in those studies, it has the amount of the number of hematoma that require a neurological intervention, or those that might actually lead to deficits, are very, very, very minimal, almost insignificant. And to be very honest, most of these studies are based on the pre-DBS era where they were doing the paridotomy. So most of these studies are based from that era. Post-DBS, the risks are even lower actually. So I would not, but of course, if a patient is on having some kind of hematological issues or those kind of
any
things,
bleeding,
I would
aspirin, clopidogrel.
Yes, in those kind of thing, I would think twice. But given a choice, it's always MER.
Dr. Vijay Shankar, which target would you prefer if you are doing early DBS based on the reduction of dyskinesias? Would you prefer STN or GBI? And what do you think the mechanism of action is these two targets in reducing dyskinesias after doing DBS?
So depending upon, most of the time, we often select the STN because we can reduce the medication up to 70%. So when you reduce the medication, obviously this dyskinesia.
So levodopa reduction results in less dyskinesia.
Less dyskinesia. But sometimes some patients, like especially on young onset Parkinson, who has a brittle dyskinesias, we know that this patient, even when you do a STN DBS, they may not respond well. Like still they tend to have a dyskinesia. Those type of brittle dyskinesia patient, I prefer to go for GPA, because GPA can have a little bit of better control over the dyskinesias, especially these type of young brittle dyskinesias.
It's said that GPI target has a anti-dyskinetic effect directly.
Yeah.
It's very interesting, early versus late DBS. Which do you think is better? Both of you can answer that. Which do you think is better you talked about the Indian situation. Both of you talked about the Indian situation. In the socioeconomic condition, if they can't afford medical treatment, do you think that they can afford DBS? That is one issue. Second, would you do early DBS in the Indian situation, or would you wait for the side effects of medicines to kick in before the DBS? Both of you can answer this.
So I would go for yearly DBS because in Indian scenario, see, most of them have say insurance nowadays.
Most of them have?
Insurance, like cities. Okay. And the other thing is insurance is covered mostly 50 to 60% it covers. The other way around is if you do for people who is not able to afford, I'll go for the non-rechargeable 5 years. So it will come around 11 lakhs up to or 12 lakhs, something like that. See, 11 lakhs, 12 lakhs is most of the, not for the, most of the patient can afford. The important thing is because of the Parkinson's, they cannot go for the work, they cannot do the work. If you can make the quality of life better, they can earn and then they can change the life. And the important thing is that 40 to 70 is for most of the people, it is the quality of life is very, very important. They are the breadwinners.
No, do you think all patients are receptive to the concept of doing early DBS, or would they like to wait?
So
In
the
your
important thing
experience?
is how we are going to explain the patient. If you explain properly, most of the patient will accept. The other thing is still in India, they will go to the primary physician, they'll go back, they'll immediately say,
Multiple
DBS,
consultations.
you will die, pa. Why do you want to go for DBS? That still we are in that era nowadays. But obviously, if you explain properly, most of the patient will accept it.
What about you, Arvind?
I have a slightly differing opinion. So even as Vijay was talking, he was talking about how if I'm going to raise the 2 tablets to 3 tablets or 3 to 4 or 4 to 5, whatever, the patients will immediately walk away to another neurologist. So imagine me as a surgeon sitting, a guy says, hey, I have a PD. And I said, okay, surgery. That's the end of my practice. I can as well go back to wherever I came from and stop my practice. So as a surgeon, I shouldn't seem to be trigger happy. So in that case, I have to think twice because whether am I doing it for the patient's benefit or my benefit? So these are all things that we have to definitely think about because this is a high stakes surgery for the patients also. And therefore, I wouldn't really jump into surgery. That's one. And secondly, talking about the Indian scenario as such, the kind of clienteles that come to Apollo or many of the centers that actually do a proper as a program doing DBS, their GDP or the per capita income as such can be compared to any of the Western European per capita. There is a huge chasm in the per capita between the poorest and the poorest and the richest. The inequality index or the Gini, it's one of the highest. It's the second highest in India, and the first is China. So with that kind of a thing, the kind of clientele that comes to us, they can very well afford it. They are even ready to say that okay, there is 60% chance. They might even say yes. But having said all this, we should be very conscious of the fact that the DBS doesn't become a golden hammer. If I have a golden hammer, I come to anything that I see is going to be a nail. So that's something that we have to be very woke to it. And
no, in
be
other
careful.
words, does DBS slow down Parkinson's disease progression, or there is no change on the disease
There's no evidence for
progression
that.
in DBS? If there is no change in disease progression, then early versus late or early versus appropriate timing, does it matter?
There is no direct evidence of change in disease progression, sir. It is very, very clear, earlier, late, or anything. DBS will not change the disease progression. But the important thing is, when you do early DBS, the patient tend to have less off periods, more on period, so they can do a good quality of exercise. Overall, if you look at the long term, those patients who done early DBS tend to fare better than the late onset because the good quality of life will be better. So it will not directly proportionately change the disease progression.
No, in
but
other
they
words,
do
when
better.
you do DBS early, do you risk having patients with who are good in motor function, but have decline in cognitive function, so-called mobile dementias? Do they increase after doing early DBS?
The dementias, there is some evidence shows that yes, ST and DBS can worsen the dementia. But overall, if you look at the long-term studies, it is because of the disease progression rather than a DBS itself. It's very, very clear, sir. DBS will not induce a dementia, maybe a little bit higher than the normal patients, but the disease progression, so I'll go for it.
I think Dr.
So you asked for why do we have to do an early DBS? I'm just going to play on his side, just one line.
Short
It
comment.
is very short. So when you're doing an early DBS, it's not, see, at any intervention surgery, the longest term follow-up is always 100% mortality. Everyone dies. And similarly in Parkinson's, everyone deteriorates. There is a cutoff point. But what we are trying to do is in that middle phase, we are trying to give a better quality of life in that interim. So if you do it early, probably they are going to have a slightly better quality of life. Ultimately, yes, it doesn't matter. But as long as it's possible, we are just trying to maximize the time when he's going to have a good quality of life, which is why, in a way, it's early. So the debate is not about early or late. It is between what is construed as early and late.
I think Dr. Surnaran Sharma is frantically indicating to me that we are nearing the inauguration time. We had a very interesting discussion on early versus late DBS. There are compelling arguments to do early DBS, and also I would say there are compelling arguments to do it at the right time in the Indian situation, which takes into fact a lot of about the patient's socioeconomic status, the patient's compliance, and affordability, etc. So many issues are there which determine the right time in our social milieu. So this is a debate which will go on, gentlemen. I think we should end it here. Thank you very much.
Can I request the organizing committee to join on the dais for a brief photo session? Next, quickly, we'll move on to the next session, the CAB for physicians. May I call upon Dr. J.B. Agadi and Dr. Satish S. To chair the session. Well, we all know physicians play a very important aspect in our lives, from the routine to the unexpected. The presence of physicians is paramount. So they are the cornerstones of our healthcare system. From routine health checks to managing chronic conditions, physicians play an indispensable role in ensuring our health and vitality. So let us begin the session. Thank you.
Good evening, everyone. So the first topic will be how to recognize movement disorders. And briefly, I'll tell about management also. So movement disorders are basically of two types. One is hypokinetic, which is typically Parkinson's disease, and the other is hyperkinetic. So why is it important is because the treatment varies, and to recognize these disorders, it is quite difficult. Okay. So Parkinson's disease mainly has three symptoms. So bradykinesia has to be there, that is slowness of movements. And usually it starts on one side and then it progresses to the other side. And any one of the other three should be there. That is tremors, rigidity, or postural instability. And nowadays the classification has slightly changed. So postural instability is not considered. So if a bradykinesia is there and tremors or rigidity are there, then we can make a diagnosis of Parkinson's. So there are some non-motor symptoms of Parkinson's that actually precede the motor symptoms. So these are constipation, hyposmia, REM sleep behavior disorder, restless leg syndrome. So they can precede Parkinson's disease motor symptoms by at least 5 to 10 years. And symptoms of Parkinson's that occur early. So these are the motor symptoms, and the non-motor symptoms are constipation, REM sleep behavior disorder, anxiety, autonomic symptoms. And the symptoms that occur very late are dementia, psychosis, and urinary incontinence. And what are the atypical Parkinsonism? So these resemble Parkinson's, at least in the early stage, but later on, after 3 years, we can clearly differentiate them from Parkinson's. So these are important to recognize because the survival is reduced. You can see Parkinson's, they can survive more than 20 years, but with limited mobility or quality of life. But multiple system atrophy, progressive supranuclear palsy, and corticobasal syndrome, survival is limited to less than 10 years. So these are some videos how to recognize these syndromes. So the first patient has typical Parkinson's. So you can see he has really prominent tremors, And you can see there is asymmetry. So the left is more than right, obviously. And he also has some amount of dystonia that can be related to his treatment. You can see there's a cervical dystonia. And we are asking him to get up from the chair, and you can see there is definite body bradykinesia. And this second patient is a patient of PSP. So what is the most prominent symptom? The eye movements are severely restricted. He's been asked to look up, and he moves the whole head. And he's been asked to look sideways, and he's moving the whole head. So the extraocular movements are paralyzed. And the other symptoms are very similar to Parkinson's. And the important thing is they'll have very early falls. And falls can occur within 3 years of onset. So the last patient in this slide has MSA, multiple system atrophy. She had a Parkinsonian type. So she had prominent Parkinson's features and less of ataxia. So in this kind of MSA, they'll have very prominent dystonia. You can see she has a tilt of the head to the left. And when she starts to walk, you'll notice that she has very severe truncal dystonia. And the other symptoms are very similar to Parkinsonism. We are checking for bradykinesia when we asked her to do that. And so these are again bradykinesia in the foot. And then asked to get up, she cannot get up by herself. Very severe dystonia of the trunk. You can see the trunk is bent to one side. It is called the Pisa sign after the Leaning Tower of Pisa. And so these are secondary causes of movement disorder that has already been described, drug-induced, especially levosulpiride, anti-vertigo medicines, and antipsychotics, especially haloperidol and promethazine. And these are all secondary hyperkinetic movement disorders. The first patient had blepharospasm that was drug-induced. You can see there is continuous blinking, and the right eye is closing more severely than the left eye. So the blepharospasm on the right side is more than the left, and sometimes she can control it to some extent, but she cannot keep the eye open for more than few seconds. The second patient had an oculogyric crisis. You can see that the eyes are deviated upwards. She cannot look down at all. She has to move the whole head to look down. And this is an oculogyric crisis. The last patient is a known case of Parkinson's, and he is on levodopa carbidopa. And you can see the movements. In the right hand, there is some athetotic movement. The left hand, there is a very stereotypic movement, which could be a drug-induced stereotypy. In the left foot, there is dystonia as well as chorioathetosis, as well as in the right foot. So these are all drug-induced hyperkinetic disorders. What a lower body Parkinsonism, these are also commonly seen. In these patients, the upper limbs, there is no bradykinesia, there are no tremors, there is no rigidity. But as soon as they start to walk, they are unable to walk. So that is called gait initiation difficulty. And when they encounter any obstacle, they'll stop. That is called gait freezing. So this was a patient of NPH. So we did the CSF tap for this patient. So this was before the CSF tap, the first video. In the second video, you can see after the CSF tap, there is definite improvement. And the number of steps reduced by more than half. And the last is after a thecoperitoneal shunt. You can see the amount of improvement. Initially, he was not able to walk even with support, and he had very severe freezing. And in the last video, you can see him walk independently without any freezing. So when are the scans useful in Parkinson's? So to differentiate the different forms of Parkinson, we need the scans. And the atypical Parkinsonisms have very definite MRI features that can differentiate from typical Parkinson's. And these are also used to diagnose vascular Parkinsonism and NPH. So these are just brief drugs and dosages, which we have already discussed. And apomorphine I've already discussed in the panel discussion. And treatment of hyperkinetic movement disorders. So chorea, tetrabenazine is the most common. The other things that we can use are clonazepam, carbamazepine, and valproate. And lesioning surgeries can be done. Dystonia, again, clonazepam, THP, baclofen, these are all muscle relaxants. And tetrabenazine, which is a dopamine antagonist. And botulinum toxin injection, which I'll come to the next slide, and deep brain stimulation surgery, which I'll show an example. And the others most important are familial tremors or essential tremors, and propranolol, primidone, DBS surgery are the treatment of choice. So this was a patient with writer's cramp. And we can see that while she's starting to write, the fingers are in the normal position, but as she continues to write, the thumb is going into extension. So now we have to target the extensor pulses. So now this is an EMG guided Botox injection. So while she is doing the movement, we'll insert the needle and we'll look for the EMG changes to confirm that the EMG needle is in place. And we can see a definite. So when we see the EMG spikes, we can be sure that the needle is in the correct place, and then we do the injection. So this is when the needle reached the muscle. So treatment, again, we have already discussed previously. So we start off with dopamine agonist initially in younger patients, and then we can add on levodopa, carbidopa as and when required. In older patients, we prefer levodopa, carbidopa and increase slowly. Pramipexole, ropinirole, again, they have risk of psychosis, memory loss, and they should be given at a lower dose, as low as possible. So this is a picture showing the progression of Parkinson. So the initial stage 1, we usually see before 5 years, and only one side of the body is affected. And then we should do mainly manage on medication. We can tell the patient about DBS, possible need of DBS in the future. But right now, the patient is not a candidate. And stage 2, the symptoms affect both sides of the body. And usually this onset varies, but usually after 5 years. And in this stage, DBS and medication are very important. And stage 3, there is some amount of balance and instability that is added on. And this usually occurs after 10 years, 10 to 15 years. And DBS is not ideal in this case, but it can still be offered if the patient doesn't have very severe instability and it responds to levodopa. And in stage 4, the patient becomes dependent. They need a walker or they may need a wheelchair. At this time, there is just medication, physiotherapy, and the other auxiliary therapies. And in the last stage, he may develop dementia also, and that requires specialized care. So deep brain stimulation, we had a very detailed discussion regarding this. So the ideal candidate is less than 70 years, better anatomical localization, better tolerability to stimulation. And they should have a very excellent response to levodopa, carbidopa. And they should not have any cognitive impairment or psychiatric symptoms or very severe autonomic dysfunction. These are not likely to respond to DBS, and they'll again bring down the quality of life, even if you do a DBS surgery. So this was the initial patient with typical Parkinson syndrome. And this is what happened when he was given a levodopa challenge. So this is a good on state, that the patient has complete improvement of its, almost near complete improvement of his symptoms. There are no tremors. He's able to walk without support, very minimal bradykinesia. And there are no dyskinesias or very minimal dyskinesias. And this is a few hours after taking the medicine. Very severe dyskinesias. Again, the dyskinesias are themselves disabling. So in this stage, DBS is recommended. So the patient cannot be managed with medicines. Even with very low dose of medicines, they'll have very severe dyskinesias, disabling dyskinesias, and they'll not be able to manage. So this is an ideal candidate for DBS surgery. So when to refer a patient for DBS? So the drug-induced dyskinesias are present for at least 3 years. and difficulty in adjusting medicine due to a very short on time, lasting less than 2 hours, with very disabling dyskinesias like the other patient had, and very prolonged disabling off periods. And they have unacceptable adverse effect with medicine like compulsive behavior, gambling, hallucinations. So this is a patient who underwent DBS for dystonia. So this patient had genetic dystonia, DYT1. So this patient, this is before surgery. You can see a very severe dystonia of the trunk, the cervical dystonia, dystonia of the limbs also. But he was able to walk without support, and he's also having dystonic spasms of the trunk intermittently. So after DBS, you can see the difference. This is 3 months after GPI DBS. The truncal dystonia has improved very significantly. The spasms have reduced. But he had already developed the scoliosis because of the dystonia. So that is not reversible. But he was independent, and even the limb dystonia is very significantly reduced. And the gait has improved significantly. What are the take-home messages? There are a category of neurological disorders very difficult to manage, very difficult to diagnose also. So they also require multiple strategies for management, medical, surgical, rehabilitation. So early recognition of symptoms, referral to a neurologist is very important. And diagnosis and counseling by a neurologist leads to better outcomes, better acceptance of the disease. Thank you.
Thank you, Dr. Praveen, for a very lucid presentation on movement disorders, recognition and early recognition especially, and when to refer these patients to a specialized center. And thank you for your talk. We can take 1 or 2 questions at this time. If there are any physicians who are likely to see these cases, any doubts anyone has, anything? Otherwise, we'll have one more opportunity at the end of the 3 talks. Thank you.
Sure. Thank you.
Inviting Dr. Suryanarayana Sharma, who needs no introduction. He's from our Bannerghatta Road Apollo, and he's a neurologist, senior neurologist with special interest in stroke, and he'll be talking on the importance of golden hour in stroke. Dr. Sharma.
Yes. Thank you. Good evening, ladies and gentlemen. Next 15 minutes, I'll be speaking about the concept of golden hour and its importance in stroke management. What do you mean by stroke? What is the WHO definition of stroke? It was first defined in 1976, then subsequently in 1988, it was remodified. It's basically rapidly developing clinical signs of focal or even global neurological deficit that results in, either it lasts longer than 24 hours or leading to death with no apparent cause other than the vascular origin. So by this definition, we rule out TIA, we rule out space occupying lesions, we rule out subdural hematomas and other structural conditions. So by definition, TIA should last for less than 24 hours. But in our experience, almost 90% of the TIAs recover in less than 1 hour. Rest 23 hours, another 10% TIAs recover. So by, for all practical purposes, rule of thumb, if there is a new onset focal neurological deficit lasting for more than 1 hour with no other apparent cause, you can actually start the stroke protocol. So what is the global epidemiology of acute stroke? If you look at the global epidemiology, around 17.5 million people are getting affected from stroke every year. And in 2019, 6.95 million people died. So India, now globally, stroke is the 2nd commonest cause of death. And in India, it's the 3rd commonest cause of death. After MI, stroke is the 2nd commonest cause of death globally. And in India, if you look at the data, which was published in Lancet 2021, this is the data, the global, regional, national burden of stroke and its risk factors, which is a 29-year-old study actually. So it showed that there is a significant increase in the, if you see that, there is almost 12.2 million, and you see the cause of death, it's almost like it is increasing by 43%. Deaths from stroke increased by 43%. New strokes have increased by 70%. So you can see that there is a paradigm shift in the incidence and prevalence of the stroke. So we need to gear up faster. So if you look at the Indian statistics, in Indian statistics, if you look at the incidence, 109 per 1 lakh population per year is the Indian, incidence. Karnataka, where we are, working, it's 9th in position with 109 acute strokes per 1 lakh population per year. So if you extrapolate the same data, you will get almost, in Bangalore, if you, which has 1.3 crore population, almost 40 acute strokes are happening every day. So which means all of us invariably come across at least one stroke per day, major hospitals. So we need to gear up our system infrastructure for acute stroke management. So that is the, concern here. And why do we insist so much on ischemic strokes? If you look at the, stroke subtype classification, ischemic stroke, hemorrhagic stroke, that is intracerebral hemorrhage, subarachnoid hemorrhage, and CVT, cerebral venous thrombosis. Ischemic stroke attributes to 75 to 87% of total strokes. So it's almost like more than 3/4. That's where we need to give a lot of priority to the stroke pathway. And if you look at the subtypes of ischemic stroke, there are 5 important stroke subtypes. One is large vessel disease, second is cardioembolic stroke, third is small vessel disease, fourth is stroke of determined etiology, then fifth is stroke of undetermined etiology. So what are the common risk factors? I think you're all aware of it. Non-modifiable, age, sex, then race, family history, and genetic causes. Modifiable risk factors, 10 risk factors contribute to 90% of acute strokes, which means hypertension, TIAs, prior stroke, atrial fibrillation, cardiac disease, diabetes, dyslipidemia, sedentary lifestyle. Sitting is the new smoking, alcohol consumption, smoking, and elevated homocysteine. So the classification of the stroke is made to make a correct diagnosis, to identify the specific stroke subtypes, and to have a common plan for treatment, then predict the future stroke risk for clinical trials and for the genetic analysis. So these are all, as I said, the TOAST classification. I mentioned the 5 major subtypes: large artery occlusion or large vessel disease, cardioembolic stroke, small vessel disease, and the stroke of determined and undetermined etiology. So why stroke has a time sensitive treatment? Now, if you look at the, the concept of stroke, if you see, this is the infarct. This is the infarct. Infarct, there is a irreversible damage which has already happened. So if the normal cerebral blood flow is 60 to 80 ml per, 60 to 80 ml, if it drops less than 20, then the tissue starts, starving, or it starts dying. So if it crosses a critical value of less than 12, then there is a irreversible damage if you see the cerebral blood flow. So if you have the core is, once it is dead, it is dead. But the penumbra and the ischemic area can be reversed. Once you restore the circulation, once you do the revascularization, most of the penumbra can be saved. That is the concept of golden hour in acute stroke management. So this is where this is a study from 2006 where Jeffrey and et al. Have done the study where they mentioned that every hour after stroke, around 120 million, 1.9 million neurons are dying per minute after acute stroke. So which means as soon as you identify the stroke symptom, you need to act fast and you need to start the treatment. So this is how the size of the infarct increases. There is a, if you see the like a 0 after the immediately after the ictus, there may be a very small core, but a large penumbra which is dying. But as the timeline goes, the core and penumbra will be merged together. There is no penumbra left over. So whatever the intervention, either TPA or mechanical thrombectomy, will not help this patient. So identify stroke symptoms early, refer to either a primary stroke center or a secondary stroke center at the earliest. So when the stroke thrombolysis therapy was started, first 3 hours was considered as the golden hour. which means within 3 hours, if the patient reaches the hospital, you give the IVTPA and, patient has a higher chance of survival. Subsequently, the guidelines changed. Now, first 4.5 hours is called the golden hour after acute stroke. But it doesn't end there. If you have a large vessel occlusion, which means large vessel means carotid arteries, middle cerebral arteries, vertebral arteries, basilar artery. If there is a stroke in that area because of a acute thrombus, it can be taken out even up to 24 hours. Now there are studies to prove this fact. So, and even the mechanical thrombectomy, even in thrombolysis, in wake-up stroke and all, we have done up to 9 hours, up to 12 hours if there is a patient is rapidly worsening. So if you identify a stroke symptom, a sizable neurological deficit, please don't delay in shifting to MRI, shifting to CT somewhere and all. Please refer to a stroke-ready hospital. So this is the, highlight. This slide highlights the importance of early intervention in acute stroke. If you see the same, I'm trying to stress the same point again and again, that if you treat early and the damage to the penumbra will be less, and the core, the infarct core size will shrink, and many a time the patient recovers much early. So this is how you recognize the stroke symptom. Simple: be fast. B stands for balance, loss of balance. E stands for eye signs. It can be loss of vision. It can be diplopia. It can be hemianopia. F stands for facial deviation to one side. A stands for arm drift or even arm paralysis. S stands for speech difficulties. Speech is either they can have total aphasia, they can have comprehension difficulty, they can have motor aphasia, or a combination. Then T stands for time of onset. So at what time patient was seen last as normal, or you can see time to call the medical help, ambulance. So if you recognize this be fast symptom, 90% of the strokes you can identify with this simple formula. So in case of any difficulty, you can always recommend to a higher center. So what is the emergency response? It starts from the home. So stroke can happen anywhere. So if you have a stroke patient in a hospital or in a mall or in a hotel or in a public place, you can, if you identify a stroke symptom, call immediately 108 ambulance. So as soon as the patient comes, you have to have a priority, which means the door to needle time has to be less than 60 minutes. As soon as the ambulance enters the hospital, the clock starts ticking in. So the patient will enter the hospital within 10 minutes, the physician assesses, within 15 minutes, the neurology team assesses, within 25 minutes, the CT or MRI is done. Within 45 minutes, you have got all the reports in hand, and within 1 hour, you should have thrombolized these patients in eligible patients. This is how, the timeline works. And this has shown a lot of benefit. If you look at the data, this is our own paper, 97 patients, IV thrombolysis and the recovery. This was published way back in 2017. And as soon as the patient comes, it's a teamwork, basically. A neurologist, ambulance driver is as important as a neurologist in this, chain of events. He has to identify, he has to inform the hospital, the neurologist should be ready, the radiologist should be ready, the lab, technician should give the reports on time, and the ICU nurse, neurosurgeons, everybody should be on, on board. So immediately stabilize the patient, do ABC, do a quick physical examination. This is what we do. NIHSS stroke scale. This has a maximum of 42 points. Anything less than 5 is a mild stroke. 6 to 16 moderate, anything above 16 is severe stroke. But if they have an isolated deficit or a disabling deficit, suppose if they have aphasia, NIHS is only 3, but still you are going to do a thrombolysis. If they have only right upper limb weakness, they, irrespective of the NIHS score in such situation, you need to act fast. And once patient comes to the hospital, inform the stroke ICU, raise a stroke code. Most of the comprehensive stroke centers in Apollo group have code stroke. The moment the patient comes to emergency, they announce the code stroke, then alert goes to all the stakeholders in the team. Do a quick sugar. That is the most important thing. Hypoglycemia is the biggest stroke mimic. If the sugar is less than 50, do correction and then redo the, reassess neurologically. And then only you are going to take action. Otherwise, if sugar is normal or even high, you can, still go ahead and do the basic investigation. Imaging is very important. Here, what we are doing is rule out a bleed. Do a CT, rule out a bleed, and you can go ahead with thrombolysis. And other stroke mimics, there are many other stroke mimics which, like hypoglycemia, seizures, and in wake-up stroke, you don't know what time patient had a stroke. So in such situation, MRI is beneficial. This is a non-contrast CT wherein it shows the gray-white differential, loss of gray-white differentiation is seen in the first slide. Second slide shows a hyperdense MCS sign, and third slide shows a clot in the M2. And this is a large stroke. We do aspect score. Aspect full is 10. 10 means it's a normal study. If there is an infarct, you reduce 1 by 1 point. Aspect 0 means it's a large stroke which has affected the whole hemisphere. So MRI is done in select patients, wherein the advantage of MRI is it rules out the stroke mimic. Sometimes it helps in identifying the time of onset. Time of onset means if there is a diffusion flare mismatch. In diffusion sequence, there is a stroke. In flare sequence, there is no stroke. Then probably there is a candidate for thrombolysis. So this is how, I'll show you one sequence. There is an acute stroke. As you can see, the white patch here with a corresponding ADC. The ADC map shows black. This is an acute stroke. Suppose if in the flare sequence, this is not seen, it is most likely that this patient has had a stroke in last 4.5 hours, within 4.5 hours. So you need to act fast. This is called diffusion flare mismatch. So for the want of time, I'll just skip some of the slides. And now we have two major medications which are available for thrombolysis, the clot busting medication. The first one is, which is almost being used since 1995, the TPA or Altiplase. And second one has received DCJ approval 4 years back, that is tenecteplase. Both can be given in less than 4.5 hours. So usually we give Actylize the RTPA as 0.9 mg per kg, 10% as a bolus, and the rest 95% as a 1 hour infusion. If you see tenecteplase, it's a single shot, 0.2 mg per kg, it's a IV push. So many a times the advantage with tenecteplase is you can give even in the MRI console. Now, actually, after 3 years of pushing, the Karnataka government has made the stroke thrombolysis free in government hospitals. This is the collective effort of all neurologists of Karnataka. And thrombolysis, please remember hypertension. This is the most important thing. If BP is high, your results are not. I'll just take another 1 minute. If hypertension is there, your results are not going to be good. Just because you have a patient, you have diagnosed a stroke, you have thrombolyzed, don't be happy. Next 24 to 48 hours, how you are going to manage or how you are going to control of the blood pressure of this patient indicates or dictates the clinical outcome after 1 week or after 3 months. So first 48 hours, you should have a tight BP control. Systolic blood pressure, always ensure that 130 to 150 is you keep that in mind. And also don't drastically drop the blood pressure. If you give, NTG, don't avoid nitroglycerin, NTG. And if you give any of the, medication to abruptly drop the blood pressure, the infarct size may increase. Stroke may paradoxically worsen. So keep a track, keep a BP monitor, and in case of difficulty, consult the neurologist. So there are many, I think I'll skip some of the slides. So only thing I want to highlight is monitor all these patients after stroke. A stroke patient admitted in your hospital, if he worsens, there are only 4 or 5 important conditions. The stroke size, the stroke volume would have increased. Second thing, patient would have had a MI with stroke, MI would have been missed, or he would have had another cardiac arrhythmia for which, it would have reverted to sinus rhythm, patient would have worsened. Third most important thing is aspiration pneumonia. Keep the patient propped up. Don't give feeds unless you are very clear that this patient doesn't have any swallowing difficulty. Then fourth thing is DVT. If the patient is, bedridden for 48 hours or 72 hours for a stroke, give a DVT prophylaxis either in the form of low molecular heparin or DVT stockings, BP, sugar monitoring, and control the infection. So with this, definitely, you are going to do good to your patient. Refer early to the stroke ready, centers, and, do good to your patient. So remember, time is brain, act fast. In resource poor areas, do a plain CT. If you have confidence that the patient has a major neurological deficit, you can use the telestroke facility and you can thrombolize the patient. So with this is my book on stroke in Kannada, which got the best Kannada literature award 2 years back. And with this, I conclude this session. Thank you very much.
Thank you, Dr. Sharma. For want of time, I think we should proceed. I now invite Dr. Gurucharan for his talk on approach to epilepsy. He is a consultant neurologist at Apollo Hospital, Banerghatta. I should say that he is a rising star in the field of neurology. I've been seeing him from his DM days at Vaidehi Institute of Medical Sciences. So I present Dr. Gurucharan to you for his talk on approach to epilepsy. Dr. Gurucharan.
Thank you, sir. Thank you very much. Good evening, everybody. We are in the slog overs. I'm the last batsman of the day. Let me be really quick. The whole purpose of this talk is for our physician colleagues to make certain terminologies more familiar and the do's and don'ts in epilepsy. It will be a very quick and a short talk. So what is a seizure? Seizure is defined as an epileptic seizure is defined conceptually as a transient occurrence of signs and or symptoms due to abnormal, excessive or synchronous neuronal activity in the brain. So when a patient comes to us and asks what exactly is epilepsy, I have developed this one phrase that I tell them. It's like a short circuit in the brain. And that's exactly what we should tell our physician colleagues also should tell the patient, the cause of which only time will tell and investigations will tell. So it's basically an electrical imbalance in the brain. Some more terminologies. Firstly, what is an unprovoked seizure? An unprovoked seizure is an occurring seizure in the absence of a precipitating cause and may be caused by a static or a progressive injury, which at that point of time may not be obvious. Acute symptomatic seizures. I think more physicians see acute symptomatic seizures than neurologists. So what are acute symptomatic seizures? They are the seizures which occur in close temporal association with the transient central nervous system or systemic insult, presumed to be an acute manifestation of this insult. For example, hyponatremia, hypoglycemia, there could be hypoxemia, carbon dioxide narcosis, and the list goes on. So these are basically with a provocation, unlike in an unprovoked seizure. Focal seizures, the initially onset originates within one cerebral hemisphere. Generalized seizure is obviously a bihemispherical origin. Can we label them as epileptic? Not really. Epilepsy exists when someone has an epileptic seizure and their brain demonstrates a pathological and an enduring tendency to have recurrent seizures. So this is a hypothesis we neurologists make, whether the patient is going to have further seizures in life, and only then we label them as epileptics. So more specifically, epilepsy is diagnosed when an individual has, number one, at least 2 unprovoked seizures over 24 hours apart. So many times we receive calls from our physician colleagues saying patient has had 5 seizures, 8 seizures in the last 1 hour, 2 hours. Practically, it could be the same seizure, it could be the prodrome of the seizure, or it could be the post-seizure phenomenon that we may be seeing, but it may be wrongly interpreted as multiple seizures. Hence, ILA has made it very clear. Patient should have 2 seizures at least 24 hours apart. Number 2, 1 unprovoked or reflex seizure and a probability of having another seizure similar to the general recurrence risk after 2 unprovoked seizures over the next 10 years. Thirdly, if the patient falls into an epileptic syndrome, invariably we can call him or her as an epileptic. This is exactly what I told right now. So this is a simpler classification of ILA epilepsy in 2017. The focal onset means it is originating from one cerebral hemisphere, one particular lobe, which we can make out by the patient's clinical semiology or by electroencephalographic studies. Further, focal seizures can be classified as with awareness or with impaired awareness, whether it could be motor or non-motor. Secondly, generalized onset seizures. Generalized onset is obviously bihemispherical, where we cannot pinpoint a particular lobe of origin. This could be motor or non-motor. Non-motor are classically the absence epilepsy. The third entity, which is a large entity actually, is unknown onset. Unknown onset most of the times could be seizures which are not witnessed, or there could be seizures which normally happen in the night. But over time, these unknown onset seizures can finally get classified into one of these focal onset or generalized onset. This is the further expanded version of it. Just want to make a few points on this, especially with automatisms. Automatisms are phenomenon which are motor in onset. These are things which normally get missed. It may be confused to be hysteric, psychogenic, but automatisms are really important, especially when we subclassify epilepsy. And this expanded version gives us a very nice understanding of from which lobe the epilepsy is originating. So etiologically, it could be, most importantly, we should always look for a structural lesion. A tumor, an infarct, a hemorrhage is very common. But more importantly, with advanced neuroimaging, we can make out dysplasias, FCDs, and other minor structural changes which can otherwise go missed. Genetic epilepsies, infectious origin, metabolic, immune-mediated, and finally, the entity of cryptogenic or idiopathic epilepsies. We always face this question. Patients keep asking us, am I been cured of epilepsy? Finally, ILA came up with a definition of epilepsy being resolved. So we say epilepsy is considered to be now resolved for individuals who had an age-dependent epilepsy syndrome, but are now past that applicable age, or those who have remained seizure-free for at least 10 years with no seizure medication for at least 5 years. This is a very important definition in patient education, which helps us to make them understand that they're probably epilepsy resolved. But this underlying statement is again very important. Avoiding preconceptions associated with words cure and remission. We never say you're cured of epilepsy. We say it's probably resolved. Resolved has a connotation of no longer present, but it does not guarantee that epilepsy will never come back. This is a very important statement that we feel that physicians and all of us should tell the patient. We feel that your epilepsy is possibly resolved, but there's no way we can say you're cured of it. So the cure terminology should not be used. So how do we manage the first unprovoked seizure? Adults with unprovoked seizure should be informed that seizure recurrence is greatest within the first 2 years based on level A evidence. And these are the factors which could make them more vulnerable for further seizures. Number one, a prior brain insult, an epileptiform EEG, and abnormal neuroimaging, and nocturnal seizures. Nocturnal seizures are mostly unprovoked, and nocturnal seizures have a tendency to become actual epilepsies. Immediate anti-epileptic therapies as compared with the delay of treatment pending a second seizure is likely to reduce the seizure recurrence in the first 2 years. Clinical recommendations whether to initiate immediate anti-epileptic treatment after the first seizure should be based on individual assessment and the hypothesis that we make whether the patient is going to have further seizures or not, and also keeping the anti-epileptic side effects in mind. These are acute symptomatic seizures. They are not epilepsy because there is a small risk of a seizure in the absence of a precipitating factor. Febrile seizures, 0.5 to 6 years of age, we don't call them as epileptics. Alcohol withdrawal seizures, metabolic seizures like I just mentioned, toxic seizures, convulsive syncope or a syncopal seizure, and seizures occurring within the first week of a brain trauma, infection, or stroke. So what's the ILA definition of acute symptomatic epilepsy? Acute symptomatic seizures are events occurring in close temporal relation with an acute CNS insult, which may be metabolic, toxic, structural, infectious, or inflammatory. The interval between the insult and the seizure may vary due to the underlying condition. If you ask us what is the time frame between the insult and the seizure, it actually varies, but we still say 1 week is the most acceptable time in between the insult and the seizure. Then we call it as acute symptomatic seizures. These are the same things that I just mentioned. The seizures occurring within 1 week of stroke, traumatic brain injury, anoxic encephalopathy, brain surgery, SDH, and so many other provocative causes, including neuroinfections. So history plays a very important role in all of us to understand whether the patient is really having a seizure. When did you experience the first seizure in life? These are a battery of questions that we can ask them. This could only make us sure that seizure is actually not a mimic. It is actually a seizure, and it probably follows this semiology, and it's probably originating from this lobe. What are the phases of seizure? The initial prodrome phase, like for any infection, the subtle discomfort that the patient feels. Then the auras. Auras could be somatosensory, it could be visual, it could be autonomic, it could be auditory, olfactory, gustatory, abdominal sensation, psyche auras. And then we have the actual ictal phase, wherein the patient has either a blank episode, a behavior arrest, a speech arrest, a motor symptom, drop attacks. All of this qualify into the ictal phase. And finally, the post-ictal phase. And this plays an important role in understanding whether we are dealing with an actual seizure or something else, because post-ictal phases more often than not define the primary generalized epilepsies. This is a large, this is a slide wherein just making you understand that there are different types of auras, different types of seizure semiologies is available on net, just to make you understand that auras have to be taken very seriously, and we can categorize the epilepsy and the origin of seizures based on the auras as well. This is the motor signs in epilepsy. It could be, it need not be always generalized tonic-clonic. It could be dystonic. It could be a negative epilepsy wherein the patient just has a limb drop. It could be facial alterations. It could be eye versions. It can be automatisms like nose wiping. It could be, sometimes even genital handlings. There are many, many types of auras and also ictal phases. This slide just is to illustrate that the multitude varieties of seizure that actually occurs. And based on all of this, we finally classify them as focal with retained awareness, or focal with altered awareness, generalized epilepsy, and unknown onset of epilepsy. Differential. So this is a very important slide that I thought I should tell my physician friends. The first thing in childhood would be stereotypies. We see so many of young parents coming to us with some videos saying, probably my son or daughter is having an epilepsy. But these could be just mannerisms. It could be habitual, self-stimulatory behavior. Sometimes a vertigo with a fall can be mistaken as epilepsy. Cyclical vomiting in kids, initially thought to be functional. Then someone said it could be a part of the migraine. But many of the parents come to us saying that the cyclical vomiting is happening, and sometimes the baby even falls. Is it epilepsy? Answer is no, it is a mimic. Daydreaming. We've all gotten scolded in school for daydreaming, but it could be absence epilepsy as well. But many of the times in kids, we should first rule out a small entity called daydreaming, and it need not be epilepsy per se. Parasomnias and also sleep-related other movement disorders may be mistaken for epilepsy. Hence, they form a large entity of epilepsy mimic in the childhood. In the adult population, syncope. Many times we see patients with syncope receiving levetiracetam in our emergency. The syncope is a #1 differential or an epilepsy mimic. TIAs. POTS. What is POTS? Postural orthostatic tachycardia syndromes, panic attack, sleep disorders, periodic leg movements in sleep, narcolepsy, migraines, psychogenic non-epileptic cells, tics, and other movement disorders can be epilepsy mimics. A few points to differentiate the syncope from a seizure. In a syncope, the triggers are frequent. We have multiple triggers, like somebody goes for a blood test, there is a prick, and then the patient drops down. Such many triggers can be there in syncope, whereas seizures, the triggers can be there, but more often than not, in primary generalized epilepsies, the triggers are rare. Preceding symptoms in syncope, they can be nausea, visual blurring, epigastric sensation, headache, tinnitus. In seizure, again, the auras can be there. Patient has a feeling of fading in a syncope, wherein there is an abrupt drop, an abrupt disconnection to the external is there in a seizure. The ictus in a syncope is just a flaccid drop faint attack, whereas in a seizure, there are multiple types like we know, and if it is tonic-clonic, obviously it is very clearly seen. The duration of a syncope is less than 10 to 15 seconds, but seizures we know can vary. And post-ictally syncope, they hardly have any kind of a drowsiness. They may at the most have headache or vomiting, but post-ictal status can be ranging anywhere between a few minutes to up to an hour in case of seizures. Well, this is a same slide to just demonstrate the differential diagnosis. So what investigations do we do? The most important one, do the diagnosis, do the test wherein we rule out acute symptomatic seizures. We do the blood test of sodium, we do calcium, magnesium, sugars and other things. Imaging, ideally would be an MRI epilepsy protocol, and then EEG, and then lumbar puncture, obviously, if indicated, to rule out neuroinfections. So this is a crowded slide just to understand the evaluation of a new onset seizure. So basically, an individual with a probable new onset seizure comes to us. in this event descriptive or suggestive of a seizure? If the answer is yes, please go for urgent evaluation, which is again more important to do metabolic workup and neuroimaging. Later perform tests like EEG. We in Apollo have EEG both in our ICU, we have it in our ER as well. So it is easy for us to monitor. And then we decide on the first line of drug based on whether we're convinced whether this is an acute symptomatic seizure or this is an actual epilepsy syndrome. Before we conclude, a couple of slides on status epilepticus, which forms a very important neuro emergency. So ILE has defined status epilepticus with convulsive status epilepticus as a time after which, if the seizure does not terminate, patient is considered to be in status epilepticus for about 5 minutes. In focal status epilepticus with impaired consciousness, the time frame is thought to be 10 minutes. In absence epilepsy, it is 10 to 15 minutes. Two other terminologies were established status epilepticus and refractory, and also super refractory status epilepticus.
Gurusharan, I think we need to vacate this stage for the inaugural ceremony. Quickly, please finish it off.
We have just one slide left with Dr. Sujit and team performing great job in Sheshadripuram with refractory epilepsy. I just want to define the refractory status, refractory epilepsy or a drug-resistant epilepsy as a failure of adequate trial of two tolerated, appropriately chosen and used anti-epileptic drugs to achieve sustainable seizure freedom. If the patient fits into this criteria, they have to be worked up further with a video EEG, with an MRI functional PET and a fusion or MEG, and then have to be worked up for epilepsy surgery. For the want of time, I'm just giving a brief outlook of how we approach epilepsy and some terminologies. And I conclude my talk and I thank Dr. Satish Chandra and team for this great opportunity to present before you. Thank you.
Thank you, Dr. Gurusharan. If there are any questions, you can corner him. We have a half an hour break. On behalf of my co-chair, I thank all the speakers for having finished on time. And I thank the organizers of the Apollo Conclave for having given us an opportunity to chair this particular session. Thank you so much.
Thank you, chairpersons and my co-speakers for interacting in this physician CME. So at 6:30, we are going to have an inauguration ceremony here. So I request all of you to have a cup of coffee and reassemble here at 6:30 sharp. It will begin. And the much awaited event of the day, oration by Padma Bhushan Sri Chris Gopalakrishnan will be held during the inauguration ceremony. I request everyone to reassemble in another 15 minutes so that we can start on 6:30. Thank you very much.
Pradeep? Hello? Pradeep? Hello, Pradeep?
Hello, Shabri. Hello, testing.
Yes, Pradeep. You can able to hear me clearly?
Can you hear?
Yes, I can able to hear you clearly.
Yeah. Your voice also clear.
Okay. Clear, right? Very clear, right? Sorry, Pradeep?
Shift ಮಾಡ್ತೀಯ sir, ಇಲ್ಲಿಗೆ shift ಮಾಡ್ತಾ ಇದ್ದಾರೆ.
Check about our view and camera. How does it looks for madam, please?
Yeah.
Camera, they're connecting. ಕೊಡಿ.
Yeah, camera already connected, Pradeep. Camera is connected already.
Can you see us? I mean.
Yeah, I can't able to see you. The black screen is there.
1 minute, 2 minutes, 2 minutes.
Okay.
We can see you.
Okay, fine.
2 minutes, be online. We'll just. Hello, da. Camera, they're fixing on second. Audio is fine, right? Audio.
Yes. Audio is very clear, Pradeep.
Okay.
My audio is clear, right?
Yeah, your voice is clear. Madam is coming there only, right?
Yes. Here only, madam, is going to see.
Okay.
Madam name only we have created this.
Okay.
Inauguration invitation.
ಇನ್ನ ಬಂದಿಲ್ಲ.
ಸರ್ ಇನ್ವಿಟೇಷನ್ ಫಿಸಿಕಲ್ ಪ್ರಿಂಟ್ ಬಂತಲ್ಲ ರಿಜಿಸ್ಟರ್
ಇಲ್ಲಿ ಸೆಟ್ಟಿಂಗ್ಸ್ ಏನ್ ಮಾಡ್ಬೇಕಾ ಕ್ಯಾಮ್ರಾದು? ಸೇಮ್ USB ವಿಡಿಯೋನೇ ಅಲ್ವಾ? ಅದೇನ್ ಮಾಡೋದು ಬೇಡ ಅಲ್ಲ? ವಿಡಿಯೋ ದೇ ಟೆಸ್ಟಿಂಗ್ 1 ಸೆಕೆಂಡ್. ಯಾವುದೇ ಮೈಕಲ್ಲಿ ಮಾತಾಡಿದ್ರು ಓಕೆನಾ? ಇದೊಂದೇ ಮೈಕ್ ಮಾತಾಡೋದು ಯಾವ್ದಾರ ವಿಡಿಯೋ ನಾವು now, Shabri, now?
Yes, Pradeep, I can able to
You can
see
see
the stage.
Okay, okay. We will just rotate one
Yeah.
side. Camera rotate ಮಾಡಿ ಆ ಕಡೆಗೆ. Rotate ಮಾಡಿ. Audience ಕಡೆ ಮಾಡಿ.
Yeah, audience also I can able to see audience seat.
Off ಆಯ್ತು, off ಆಯ್ತು. Okay.
Okay, fine, Pradeep. You are speaking from the podium or you are speaking in the different mic?
Different mic. ಈ ಕಡೆ camera
Oh.
Yeah, I am speaking with different mic.
Okay, fine. You are in console, right?
Any podium, any mic, it will work, I think.
Yeah, sure, Pradeep.
Okay, okay. Thanks.
Okay, Pradeep. Thank you.
We will be connected only. We will not disconnect. We'll just
Hey,
mute.
no, I will not disconnect. I just put the audio and video is mute.
Okay, okay.
Madam
Fine.
will come, I will on.
Okay. What time? Any idea what time?
6:30, madam maximum will be there.
Then
I will text you. I'll text you.
Okay, 6:20 again we will retest once.
Okay. I'm here only.
Okay, okay, Shabri. Okay. Thanks.
Okay. Thank you.
ಈಗ ಎಲ್ಲ ಓಕೆ 6:30 ಬರ್ತಾರೆ 6:20ಗೆ ಇನ್ನೊಂದ್ಸರಿ ಟೆಸ್ಟಿಂಗ್ ಮಾಡ್ಕೊಳ್ಳೋದು. Hello, testing. Hello.
Yeah.
Hello, Shabri.
Yes, Pradeep.
Yeah,
You can able to hear me clearly?
yeah, it's clear, it's clear.
It's clear, right? Okay. My audio and video is clear, right?
Screen ಅಲ್ಲಿ ಬರ್ಬೇಕಿತ್ತು. Ah. Okay.
Yeah, Pradeep.
Yeah, now fine. Now it's fine.
Yeah, sure. Okay.
Our audio video both are fine, right?
Yes, your audio is very clear.
Okay.
Crystal clear is there.
Okay. Thanks.
Thank you, Pradeep. Thank you.
Senior Consultant Neurologist and Epileptologist, Apollo Hospital, Sheshadripuram, to take the proceedings forward. Thank you.
Good evening, honored guests, senior teachers, dear colleagues and friends. I'll start with Sir William Osler's immortal words: to study the phenomena of disease without books is to sail an uncharted sea. But to study books without patients is not to go to sea at all. This is the sentiment embodying the conduct of continuing medical education programs all over the country by Apollo hospitals. So to enlighten people who participate. I have the great honor of calling Professor Satish Chandra sir to accompany our honored guest for today, Padma Bhushan, Dr. Krish Gopalakrishnan, who was the former he was the CEO and MD of Infosys Technologies and one of the co-founders and currently the chairman of SLR Ventures. May I request Satish Chandra sir to accompany Dr. Krish Gopalakrishnan to the dais. It is my proud privilege to request Dr. Ravi Mohan Rao to accompany Dr. Harshad Reddy, who is the Director of Oncology and International Relations, onto the dais. Dr. Harshad Reddy, sir, we thank you for coming here despite your busy schedule. Dr. Ravi Mohan Rao, sir, will accompany Dr. Harshad Reddy, sir, to the stage. Thank you. I would like to request Dr. Satish S., our senior neurosurgeon and head of neurosurgery at Bannerghatta Road, to accompany our chief strategy officer, Dr. Madhu Shashidhar, onto the stage. Thank you, sir. I would like to request Dr. Suryanarayan Sharma, senior neurologist and stroke specialist at Apollo Bannerghatta Road, to invite Dr. Manish Mattu, sir, our beloved CEO, onto the dais. The famous poet Alfred Lord Tennyson once said, "More things are wrought by prayer than the world dreams of." So I would like to invoke the blessings of Lord Ganesha in a rendition by Dr. Chaitra, who is a senior consultant radiologist. Dr. Chaitra, please.
शरणु सिद्धि विनायका शरणु विद्या प्रदायका शरणु पार्वती तनय मूर्ति शरणु मूषिक वाहना शरणु सिद्धि विनायका निटिल नेत्रन देवी सुतने नागभूषण प्रियने निटिल नेत्रन देवी सुतने नागभूषण प्रियने तटिलतांकित कोमलांगने तटिलतांकित कोमलांगने कर्णकुण्डलधारणे शरणु सिद्धि विनायका शरणु विद्या प्रदायका शरणु पार्वती तनय मूर्ति शरणु मूषिक वाहना शरणु सिद्धि विनायका कुक्षि महालंबोधरने इक्षुचापन ಗೆಲಿದನೆ कुक्षि महालंबोधरने इक्षुचापन ಗೆಲಿದನೆ पक्षिवाहन सिरि पुरंदर पक्षिवाहन ಸಿರಿ ಪುರಂದರ ವಿಠಲನ ನಿಜದಾಸನೆ ಶರಣು ಸಿದ್ಧಿ ವಿನಾಯಕ ಶರಣು ವಿದ್ಯ ಪ್ರದಾಯಕ ಶರಣು ಪಾರ್ವತಿ ತನಯ ಮೂರುತಿ ಶರಣು ಮೂಷಿಕ ವಾಹನ ಶರಣು ಸಿದ್ಧಿ ವಿನಾಯಕ ವಿನಾಯಕ Vinayaka. Thank you.
Thank you, Dr. Chaitra, for that soulful invocation. A good teacher teaches, but a great teacher inspires. Dr. Satish Chandra, sir, has inspired generations of neurologists all over the country. It is my honor to call Professor Satish Chandra to deliver the welcome address.
ಗುಡ್ ಈವ್ನಿಂಗ್. ತಮ್ಮೆಲ್ಲರಿಗೂ ಆದರದ ಸ್ವಾಗತ. Madam Preeta Reddy, Vice Executive Chairperson, Apollo Group of Institutions. She'll be joining us virtually. Padma Bhushan Chris Gopalakrishnan, Padma Vibhushan Pratap C. Reddy's first orator in neuroscience. Mr. Harshad Reddy, Dr. Madhu Shashidhar, Chief Strategy Officer, Hospital Division, Dr. Manish Mattu, CEO, Karnataka Division, invited guest faculty who have traveled from different parts of the country, accepting our invitation, invited guests, delegates, staff, and students, the print and electronic media, and ladies and gentlemen. Epidemiological studies have reported that the neurological disorders constitute anywhere between 14 to 20% of all disorders, which increases as the age advances. As India is graying, these disorders are expected to increase significantly to 30% by 2050. There is a rapid advancement in the field of neurology and neurosurgery in precise diagnosis and management of number of neurological disorders in the last 2 to 3 decades. Neurogenetics and neuroimmunology, with focus on personalized medicine, has changed the concept in the management of number of disorders. Various non-treatable disorders, such as Duchenne muscular dystrophy, or it is even anterior horn cell disease, have now found a newer method of treatment thanks to the frontline researchers. Apollo Hospital, the pioneer of private healthcare in India and the foremost integrated healthcare conglomerate in Asia, has had a profound impact on the lives of over 200 million individuals from more than 140 countries since its establishment in 1983. With a mission to provide affordable healthcare of international standards to the common man, it has more than 10,000 beds, 75 hospitals, and 6,000 pharmacies. Of these 75 hospitals, 38 major hospitals across India has a neuro workforce with state-of-art technology combined with highly trained experts, giving an excellent outcome to the patients. Apollo also has extensive student training program with more than 1,000 trainees in 45 specialties, including neuroscience, across many centers in India, providing a trained manpower to the community at large. Apollo Neuro Conclave began in the modest way in 2023 in Hyderabad and has evolved into a bigger conclave attended by nearly 150 neurologists, neurosurgeons, neurointerventionists, and neurocritical care experts all over the India and in Bangalore. The main theme of this year's conclave is recent advances in neuroscience. This conclave, apart from including didactic lectures, also has interesting debates on common controversial topics and also has panel discussion with the panelists discussing common neurological topics. This was started in the morning and we already had epilepsy and movement disorders in this line. Also has specially designed 1 hour session for practicing physicians on common neurological disorders just now concluded. These physicians are our backbone in referring these cases to us. We also have e-poster session, encouraging our students to present their research paper tomorrow morning. Highlight of this year's conclave is the oration instituted in the name of our chairman, Padma Vibhushan, Dr. Pratap C. Reddy's first oration in neuroscience. This is to honor our visionary chairman who has worked tirelessly since 40 years to build such a wonderful institution all across the country. This oration will be delivered by another technological visionary, Padma Bhushan Chris Gopalakrishnan. I consider my privilege and honor to introduce our legendary chairman, Pratap C. Reddy. Renowned as the architect of modern healthcare, founder chairman of the Apollo Hospitals Group, stands as a towering figure in the realm of the global healthcare. His journey began in small village in Chittoor in 1983 with the establishment of the Apollo Hospitals, marking the inception of Indian private healthcare sector. This bold move not only transformed the healthcare landscape in India, but also set precedent that inspired the emergence of over 300 large-scale hospitals, dramatically enhancing the quality and accessibility of healthcare at a fraction of the global cost. His efforts have been globally recognized, earning him India's second highest civilian award, Padma Vibhushan. He is a visionary, role model, inspiring future generations to carry on the pursuit of health and happiness for all. Unfortunately, he could not be here today because of his prior commitments. Madam Preeta Reddy, the Executive Vice Chairperson of the Apollo Hospitals Enterprise Limited and a member of its founding family, collaborates in introducing contemporary protocols to continuously enhance the clinical outcomes. She takes the lead in promoting quality improvement processes, striving to achieve the highest standards in patient satisfaction. Additionally, she serves as a managing trustee for overseeing the educational endeavors of this group. Furthermore, Dr. Preeta Reddy actively engages with industry bodies and Government of India to influence the healthcare policy decision. In recognition of her remarkable service to the humanity, Madam Preeta Reddy was honored with the prestigious Sir Jahangir Gandhi Medal for Industrial and Social Peace by the Xavier School of Management in 2022. Additionally, for Apollo Hospital's outstanding contributions in managing the COVID-19 pandemic, she received the Economic Times Businesswoman of the Year award. She'll be joining virtually. I think she has already joined there virtually from Chennai because of her last minute official commitment. Madam, I welcome you all. Welcome you to this Apollo Conclave. Padma Bhushan Shri Chris Gopalakrishnan, Chairman of the Acceler Ventures and co-founder of the Infosys. He is delivering the Padma Vibhushan Dr. Pratap C. Reddy's first oration in neuroscience. He will be introduced later by my colleague K.N. Krishna. On behalf of the organizing committee of the Apollo Neuro Conclave, I welcome you, sir. Dr. Harshad Reddy, young dynamic leader. He is the Director, Group Oncology and International Business. He did his Bachelor of Engineering from University of Warwick in September 2006. Later completed MSc Management from University of London. He joined as a Director of Apollo Home Care Health Limited in January 2016. He was instrumental in supporting 70,000 families annually with better home health care. He then became Director, Group Oncology and International Business in 2017. He has kindly consented to be with us within a very short notice. So on behalf of the organizing committee, I welcome you, sir. Dr. Madhu Shashidhar is the Chief Strategy Officer of Apollo Hospitals. Dr. Shashidhar is a practicing physician with US board certification in internal medicine, pulmonary, and critical care medicine. He completed his medical education at JIPMER, Pondicherry. And he said that his classmates are all here, including Dr. J.R.K. Sharma, the neurologist. So he is He has completed following that a residency in internal medicine at St. Luke's Roosevelt Hospital in New York City. He completed his fellowship in pulmonary and critical care medicine at Yale University, New Haven, USA. Dr. Shashidhar served as president of Cleveland Clinic Tradition Hospital. Before that, he was a chief medical officer at Cleveland Clinic, Abu Dhabi, and enterprise section head for respiratory care for the Cleveland Clinic Health System. Dr. Shashidhar has published a number of book chapters, journals, peer-reviewed articles, and abstracts. He has joined recently the Apollo Group of Hospitals as a Chief Strategy Officer. I welcome you, sir, on behalf of the organizing committee. I consider my privilege to welcome our own Dr. Manish Mattu, CEO of Karnataka Division, who is guiding spirit for conducting this conclave. On behalf of the organizing committee of Apollo Conclave 2024, I welcome you, sir. In the audience with us, we have Professor G.N. Narayana Reddy, former director of NIMHANS and my teacher and mentor. In spite of his age, he was able to come and be with us and inspiring the next generations of neurosurgeons here. Professor Chandramukhi, professor and head of the Department of Neuromicrobiology from NIMHANS. And then I think I will be soon joined by Professor Vijayalakshmi Ravindranath, who is also a former director of NBRC Manesar, and Dr. H.V. Srinivas will be joining us. I think he is just entering the hall. Dr. H.V. Srinivas, he is the senior most consultant neurologist in Bangalore today, and he is our teacher also. Dr. Srinivas, sir, I welcome you here. I welcome all the faculty from Apollo hospitals who have traveled from different parts of India and spending time with us. I also welcome unit head of all the 3 Apollo hospitals in Bangalore who are with us today, and their support made this successful. Fellow senior consultants from other departments who have respected our invitation, who are with us, office bearers of Bangalore Neurological Society, Stroke and Neuro Group, Karnataka Neuroscience Academy, KNA, and many of the practicing physicians are with us. The students who are not only attending but presenting their scientific work are with us. There are invited guests, staff, media, print and electronic, and who have come here to cover this important event of the conclave. And ladies and gentlemen, I wish that this Neuro Conclave will become an annual feature and will be organized year after year, not only in metros, but also in other Tier 2 cities in the years to come. Further, we discussed this morning that this should pave the way for the institutional multicentric research and also optimal utilization of the resources, including expensive technology amongst us. And I think this will pave the way now in the years to come. All of us join together to do the further research and also take it to the patient. And that is what was the vision of our visionary chairman. Thank you very much.
Thank you, sir, for the wonderful welcome address. It is my privilege to invite all the august dignitaries on the dais for the lamp lighting to inaugurate the CME. I would also like to invite all the Apollo organizing core committee members also to come onto the dais. Thank you. No matter what people tell you, words and ideas can still change the world. These were words of wisdom by the famous actor Sir Robin Williams. Our Vice Chairperson, Dr. Preetha Reddy Madam, has transformed Apollo hospitals over the years in the pursuit of excellence and made a unique group of hospitals at the forefront of technology and medical care. I can say with confidence now that Apollo hospitals, the services provided are on par with any other hospital, providing world-class facilities for healthcare. It is my great pride and privilege to invite Madam to enlighten us with her wisdom. Madam.
Namaste. It's such an honor to be amongst stalwarts of industry, those who run hospitals, and more than anything else, the fabulous clinicians within the Apollo system and throughout the globe. My special thanks to Mr. Chris Gopalakrishnan, who I've known for a long time, but I've admired closely and from a distance. As a co-founder of Infosys, I think he co-built one of the best companies, not only in India, but globally, and had really at that time set India on the global map. But what is dearer to our heart is the fact that Mr. Gopal Krishnan today is the only person I know who has invested so much in the area of neurosciences. And for that, all of us, Chris, feel very privileged with your presence. And thank you for accepting to speak to all of us. I know and I understand that, while we see a group of stalwarts in the field of neurosciences in the gathering, the number of people who have logged on to hear you and to this event, I think is quite a phenomenal number. While we have 400 neurologists, neurosurgeons among our group, there's so many more within the country and overseas who've logged on to this Neuro Conclave. And for that, I really want to thank and congratulate Dr. Satish Chandra for the amazing work you have done in this field, Dr. Satish Chandra. Thank you for the invitation and thank you for making the effort to do this, because this is a space where everyone comes together, exchanges ideas, and learns. And that, for me, I think the learning, raising the bar constantly on how we deliver healthcare, how we make literally the world a better place to live in, is the most important part of the work which we do day in and day out. We have focused over the years, Apollo started 40 years ago because Chairman was so upset and bothered that we couldn't bring healthcare for a patient in the area of cardiology. So we started off with a vision to be a hospital for cardiology, but it's grown over the years. And we've done, I think, reasonably well in the area of cardiology, multiple other areas, a great focus on oncology, which all of you know. But I think the brain is probably one of the most complex areas. It is literally the organ of destiny. It is even today an uncharted territory. We probably know about 10 to 15% of actually the functions of the brain. And whatever we do as a group to invest our time, effort, energy in learning more, in doing more, I think the time is right. It is important. And I hope we can say that it's a job well done. And that's really what we're looking forward to. So when I'm saying that the brain is an uncharted territory, it is probably the last bastion of the future. And it's an area where we have to think through and overcome. We all know that the disease related to neurological disorders is on the rise. It's because primary cause is the aging population, but it's also a younger generation who's suddenly being faced with a whole host of these issues. So for us, I think we have to come together and see in different aspects of neurosciences, whether it's neurology or neurosurgery, surgery, or epilepsy, Alzheimer's, Parkinson's, and more than anything else, genetic the makeup and disorders. So I think what we need to do, there's a whole lot to be done. And that is why I feel that this is the next area for us to focus. And when I'm saying that, I would like to mention that over the past year, we have also signed an MOU with the Barrow Institute in the US for exchange of ideas, for processes on joint research, for us to see how can we train some of our faculty here, for some of our young doctors who are the stars of the future, if they can go and spend some time there. And if that faculty can come and interact with all our senior faculty there. And over in the near short term, not too long, is that can we do joint research together? And I think that is the aspiration, that is the goal for the Center of Excellence, which is many centers of excellence across the country, which are being set up. And we're going to have a very strong focus in the area of neurosciences. So I would really like to thank all of you for coming together to do this. I want to go back and mention that Mr. Gopal Krishnan and his wife, from their family's philanthropy, have made a significant contribution to brain research. And, we have been watching the kind of work which is happening at, especially at IIT Chennai. And I think it takes vision for a family to do that, and definitely for him to focus on doing this. And that's why I think that foresight is really not about predicting the future, but preparing for it. And this investment in research, this investment in seeing how the future is going to pan out, is going to really impact mankind in a large way. And it's not only for people of India, but ultimately it will be for the rest of the world. And I think that will make us as Indians proud. So again, Chris, thank you from the bottom of my heart for being with us today, for accepting to be there. But more than anything else, being so generous of your time, effort, capital and energy to invest into the future of neurosciences, because I know for sure that nobody in this part of the world has been so generous. So thank you for that. And I'm sure that all the faculty will see that together, if we can work, help out in any of the things which you're doing and make the future a better place for our children, it will be an amazing thing to do. And I'd like to say that everybody from the Apollo team, Madhu, Manish is sitting there, Harshad is there among the team, and so many others from the supporting team, not only in Bangalore, but throughout the country. Thank you all for being such an amazing team, that while our clinicians work so hard and produce such fabulous results, it's the support system which really, helps them perform so much better, so that they don't have to worry about, everything else, and they just have to serve the patients. So for the whole support team who is there in the gathering, thank you all for being so amazing. I'm really looking forward to fantastic interactions. I've, seen and heard a bit of it already. But I think what will come out of this is going to impact the way healthcare is being delivered in the country, and especially in the area of neurosciences. So thank you all again for coming together, doing this. And I wish the program phenomenal success. And I'm sure that there will be a lot of take-home messages for all of you to go back and practice in all your locations. Thank you, and Jai Hind.
Thank you, madam. Despite your busy schedule, you've been able to take some time off and give us your words of wisdom.
I feel disappointed I'm not there with all of you, really disappointed.
I think I can speak for the whole gathering. We are also extremely disappointed, ma'am. We would have loved for you to be here with us. Thank you so much. The father of medicine, Hippocrates, once said that there are two things, science and opinion. Science begets knowledge and opinion begets ignorance. So our beloved CEO, Dr. Manish Mattu, has been a beacon of light, illuminating all three aspects of science: clinical practice, research, as well as teaching and learning. So I would like to invite Sir, who has always helped and guided us in these activities, to address the gathering.
Thank you, Dr. Sajid, for the gracious introduction. Good evening, everyone. Mr. Chris Gopalakrishnan, Mr. Harshad Reddy, Dr. Satish Chandra, Dr. Madhu Sashidhar, senior clinicians who are in the gathering today, especially faculty from NIMHANS, my esteemed colleagues, friends from the media, and friends, it's my pleasure and honor to welcome you all to the second Apollo Neuro Conclave being hosted by Apollo Hospitals, Bangalore. The first one was hosted in Hyderabad last year, and it was a resounding success. And given the way the turnout has happened here, the discussions have happened here, we're very glad that the tradition has been carried on. In this session, in this conclave, the second edition of this conclave spread over 2 days, we will be having about 40 interesting scientific sessions. Some of them have finished today, and the rest will be on tomorrow. About 60 speakers, about 150 delegates coming together for an enriching discussion around 4 subspecialties. One is epilepsy, the other is neurointervention, movement disorders, and neurosurgery. In fact, some of the latest advances in ZAPEX will be discussed tomorrow. As you know, ZAPEX is a new technology that we introduced at Apollo Hospitals, Delhi last week, and it was unveiled by our founder chairman, Dr. Pratap Reddy, and the first such installation in South Asia. Driven by our visionary chairman, Dr. Pratap Reddy, Apollo has always been a pioneer in the realm of neurosciences. It's always endeavored to get the best clinical talent on board. You know, as a number, if you see among so we have about 4,000 neurologists in the country today. Dr. Satish Chandra and I were discussing it today, and 10% of that number is actually with the Apollo group. It just goes on to show the focus that Apollo has in this space. So not just having the best clinicians on board, but also investing in really cutting-edge technology, working towards clinical research, publishing papers, and great outcomes. That's been our philosophy over the last 4 decades, and that we will continue to do so. India is entering a very challenging decade ahead. We have rising ailments, rising neurological ailments that Dr. Satish Chandra alluded to earlier. We have a growing disease burden of non-communicable diseases. We also have a big aging population of about 15 crores, and as a cohort in absolute numbers is the largest group of senior citizens in the globe today. And those factors will complicate and make our job difficult in the years ahead to provide better care. So platforms like these are very important as far as discussions are concerned, sharing best practices are concerned, sharing of clinical ideas are concerned, because the idea is really to come up with better solutions to these challenges and provide a great quality of life to patients in the years ahead. So I'd like to end again by welcoming you all to this conclave, and again thanking the organizing committee for putting up a fabulous show. Thank you so much.
Thank you, sir, for your words of encouragement. There is nothing impossible for they who will do. These were words spoken by a person who had conquered more than half the known world by the age of 30. Yes, I'm talking about Alexander the Great. This is, in essence, what Apollo stands for, providing the finest care to all over India. And we have in our midst Dr. Madhu Sashidhar, a distinguished clinician himself, a pulmonologist and critical care specialist trained at Roosevelt Hospital and Yale University, and who is poised to take us to the next level of care. I would like to invite Dr. Madhu Sashidhar to speak a few words. Thank you, sir.
Thank you for that introduction. First, I want to thank Padma Bhushan, Dr. Gopal Krishnan for giving us his time. It's incredible, your commitment and the courage of your vision for research. So I very much look forward to your talk today. Let me first of all thank the organizers for inviting me. I want to extend my heartfelt gratitude to the organizing committee, especially Dr. Satish Chandra, Dr. Ravi Mohan, and Dr. Surya Narayana. They've really curated an exceptional event, an event filled with high quality clinical content. So thank you for your dedication, and you've truly made this a great event. I also want to express my sincere appreciation to Dr. Manish, Dr. Yatish, and everybody who's helped to organize this event and for having all the guests here in Bangalore. We've really brought together a large group of medical professions from various parts of India to this event. And again, all the esteemed speakers and invited guests, thank you for coming here. Thank you for sharing your wisdom. I've really missed this kind of scientific event almost for a long time, since COVID. So it's great to get together. The hallway conversations are great. We learned so much. As a clinician and as somebody who has spent quite a bit of time within administration, I'm really impressed. We are really living in unprecedented times in healthcare. The advances that are being made regularly in healthcare, when you think about it, these are truly unprecedented times. Just within the past few decades, Dr. Mason Soames accidentally injected the coronary artery. That was the first coronary angiogram. It was not supposed to happen. It was an accident. But then he also discovered that you could actually image the coronary artery. Since then, we have perfected the technique. We can now image. We fixed the coronary artery. We've saved countless lives. It is the most commonly performed procedure on the planet. That was the pace of medical innovation then. But today, what we are seeing is a convergence of our ability to sequence the entire genome, understand tumor genomics, tumor biology, the relationship of cancer with the immune system. The convergence of AI, robotics, miniaturization of our instruments, radiosurgery, as Dr. Manish said. These are all coming together at incredible speed and making our patients, returning our patients to health faster and with less morbidity. And nowhere is as true as it is in neurosciences, because as Ms. Preeta said, the brain truly is the last frontier. We have truly not understood the physiology of the brain and the neurological system, as well as we have done with other organ systems. So I'm grateful to the committee for organizing an event like this. We need to bring together the best minds to understand these rapid and immense progress that is being made in neurosciences. But I should also point out that while we have made tremendous progress and all of these incredible technological advances are coming into healthcare, if you look across the planet, a big segment of humanity does not have access to healthcare. A big segment of humanity does not even have access to basic healthcare. So I think as we talk about all of these incredible technological and other advances, we should also keep in mind, how do we make healthcare accessible? In our country, how do we make it accessible to the large segment of population that we should be serving? Here at Apollo, we are getting prepared for this incredible technological change that is coming our way. We have invested a lot into IT. We are implementing AI models. We have invested in the best of technology, the Zapex radiosurgical instrument, as Dr. Manish said, several other technological and other innovations that we've invested in and are bringing into Apollo to get prepared for the next generation of care. Apollo has constantly, at all times, focused on clinical care, bringing the best care to patients in India. But I think as we go forward, we will also continue to focus on research, especially research that is relevant to the context of our patients, as well as education of those who serve our patients. Beyond these core tenets, I will leave you with 3 other priorities that we have as we look into the next few years. First is the cost of care. I think this is going to increasingly become a focus, and we must, as practitioners, think of the cost of care and look at how we can eliminate wastage. Because only through elimination of wastage and increasing our efficiency will we make the care that is available to us, that we have available to a larger segment of our population. The second is preventive care. You can see the tremendous morbidity that stroke imposes on patients, and yet most stroke cases are preventable if hypertension and metabolic diseases are managed early enough. As specialists, your word goes a long way. For every patient that you see with stroke, if you can counsel their family members and their near ones to participate in preventive care, to get the ProHealth check, you will save lives. You will change the course of the life for many, many other individuals who you come into contact with. And the last thing is within our practice, within the practices in Apollo, I would ask that we look at how we can effectively create teams for care. Because as teams, we deliver better care and we are much more effective in the care we provide. One of the greatest privileges in my life was when, as a fellow in pulmonary and critical care medicine for 4 years, my second home was a Harvey Cushing Library. The Harvey Cushing Library in New Haven, Connecticut, has over 2,200 specimens, slides, case notes that were curated and prepared by Dr. Harvey Cushing, because early in his practice, somebody lost one of his specimens and he was not happy after that. There are over 15,000 photographs, photomicrographs that are preserved in the library. But one of the most prized possessions in that library is the first anesthesia record. Because the remarkable neurosurgeon, a pioneer of his times, knew that good outcomes in neurosurgery required safe anesthesia care. He knew then what we must do now, which is effective team-based care. And at Apollo, we have all the elements for effective team-based care, from cradle to grave, bringing together our pharmacy, our home care, our diagnostics, our clinics, our hospitals where we give complex acute care, connecting them seamlessly through technology to give our patients a connected single source of care. So I urge you to participate in this new vision for healthcare. Together, we will elevate healthcare. We will transform the lives of millions. Thank you all. Thank you to the organizing committee.
Thank you, sir, for your words of wisdom. I'll quote Sir Winston Churchill: "Success is not final. Failure is not fatal. However, it is the courage to continue that matters." Oncology is one such final frontier. We have with us today Dr. Harshad Reddy, who's the Director of Oncology and International. I would like to request sir, who has spared time from his busy schedule to be with us, to address the gathering. Dr. Harshad Reddy, sir.
Thank you so much, Doctor, for the wonderful introduction. Our respected clinicians gathered here for the Apollo Neuro Conclave 2024. Mr. Chris Gopalkrishnan and dignitaries on and off the dais and guests, very good evening to one and all. It is my deep privilege to be here amidst an august gathering of luminaries in the field of neurosciences who have come together for the Apollo Neuro Conclave, steered by Dr. Satish Chandra and a passionate organizing committee at Apollo Hospitals. This conclave stands as a testament to our resolute determination to keep pushing the boundaries and to strive harder and to raise the bar in clinical excellence. In the scientific session, it is commendable that there will be a concerted focus spanning pivotal subjects such as epilepsy, movement disorders, strokes, neuro-oncology, neurosurgery, and neurointervention. Clearly, this two-day conference promises to be a melting pot of ideas, fostering a comprehensive exploration at the forefront of neuroscientific advancements. It is, therefore, our privilege to witness the convergence of esteemed professionals from neuroscientists, neurologists, neurosurgeons, and interventional neurologists from across our ecosystem and the world. Likewise, we are honored and immensely grateful that Mr. Chris Gopalakrishnan, an esteemed figure in the global business and technology realm, is delivering the inaugural Dr. Pratap C. Reddy oration. Thank you, sir. It is particularly special because of his profound commitment to philanthropy, especially in brain research, which is inspirational. I had the personal privilege of visiting the Sudha Gopalakrishnan Brain Center at IIT Madras, a multidisciplinary research and development center focused purely on brain research. This center represents a unique amalgamation of diverse disciplines, including medicine, neuroscience, and engineering. Established by Mr. Chris, a distinguished alumnus of IIT Madras, the center underscores his commitment to the greater good, which is key to nurturing inclusion and sustainability. Thank you once again, sir. Taking a moment on the amalgamation of science and technology, it would be amiss for me to not reiterate my deep fascination for two cutting-edge technologies introduced by Apollo hospitals over the last few years. Proton therapy, now available at the Apollo Proton Cancer Center in Chennai, has delivered treatment to over 1,000 plus patients now, over 1,000 plus patients in record time. And a significant number of cases have been in the realm of neurosciences. Similarly launched just a few days ago in our Apollo Indraprastha, the ZapX represents a leap forward in non-invasive neurological treatments. With its gyroscopic linear accelerator design, it allows for precision-targeted radiation therapy, minimizing the impact on healthy brain tissue and promises game-changing outcomes. Put simply, proton therapy and ZapX epitomizes the innovative spirit that we are here to celebrate. And I invite each and every one of you to harness them for your patients. As I conclude, I am reminded of the words of the great Marie Curie, who said, "One never notices what has been done. One can only see what remains to be done." So over these 2 days, as we explore the depths of neurological sciences, share advancements, and celebrate the union of technology and medicine, let us bear in mind that our journey is far from over. This is so as the path ahead will only be illuminated only when we embrace the inestimable power of shared knowledge and collaborative spirit in the pursuit of a healthier, brighter future for all. Thank you, and my best wishes for a successful conclave.
Thank you, sir, for your encouraging words. I have one small announcement to make. This entire scientific program, as well as inauguration, is being transmitted live on YouTube, and so that people all over the country from other Apollos can watch. Out of a mountain of despair, sometimes rises a stone of hope. These were words by Martin Luther King Jr. And similarly, from a plethora of diseases and disorders arose the Apollo group of hospitals, marking an illuminating standard in international quality of medical care. This was the dream of an inspirational leader, our beloved chairman, Padma Vibhushan, Dr. Pratap C. Reddy sir's dream. And this dream was not restricted to medical care alone. It extended to research and teaching as well, as today we stand as one of the biggest institutes in the private setup, producing a large number of research papers and training the largest number of DNB candidates. It is my proud privilege today Although our chairman, Dr. Pratap C. Reddy could not be with us, he has left a message for us, and it is my proud privilege to invite sir to share that message.
During this conference, and more importantly, to enable the latest adaptation of technology in tackling these various neuro problems, which are troubling not the nation, the world. And I think India today is now gearing up itself to become, according to the Prime Minister, heal India, heal by India. According to me, it is, India should become global healthcare destination. And the neurologist plays a very important role. A major part of the disease pattern in the world is neurological problems. I'm happy that the organizing committee has brought out various topics of great interest in dealing in the diagnostic and the treatment aspects of the various neurological problems. I must also express my sincere thanks and greeting to Padma Bhushan.
Good evening, everyone. We seem to be having a slight technical problem with our beloved chairman's message. So I would like to invite Dr. K.N. Krishna, Senior Neurosurgeon and Head of Neurosurgery at Apollo Hospitals, Jayanagar, to introduce our chief guest, Dr. Krish Gopalakrishnan. Over to you, Dr. Krishna. I would also like to request, as we are going to have the oration now, the dignitaries on the dais to kindly take the seats down so that we can have the oration after this. Thank you very much.
Good evening, one and all. I consider it my proud privilege to introduce the orator of the very first Padma Vibhushan Dr. Pratap C. Reddy Neurosciences oration. What an apt situation to have today. One giant delivering the oration in honor of another giant in their respective fields. Both are visionaries, entrepreneurs, and are looking forward to the future for the merger of human intelligence with its own creation, the artificial intelligence, to enhance understanding of human biology and delivering the best of healthcare. To do the honors, we have none other than Padma Bhushan Sri Senapati Krish Gopal Krishnan. Who doesn't know him in this audience? Introducing him is customary, but both easy as everyone knows him, as well as difficult due to the time constraint, as his contributions keep adding up every other day. Still, I'll make the customary introduction. Sri Senapati Krish Gopalakrishnan had his initial education in his hometown, Thiruvananthapuram, and moved on to IIT Madras, where he took his master's in science and also master's in computer science and technology. From there was no looking backwards. The whole world of IT technology and entrepreneurship was his stage. As we know, he is one of the co-founders of Infosys, the pride of Bangalore and India. During his tenure at Infosys, he held various leadership positions and he proved his mantle as a technology thought leader, visionary, and an able administrator. His excellence was globally recognized. He was voted as top CEO IT services amongst the Asia's top executives. He was recognized as the top Asian corporate director by Corporate Governance Asia. He was elected president of the prestigious position of Chamber of Commerce of Indian Industries. Served as one of the co-chairs, a very rare occasion of World Economic Forums at Davos. To top it all, the government of India conferred on him the third highest civilian award, the Padma Bhushan, in the year 2011. Having achieved all this and more, he decided to extend his expertise to much broader field by relinquishing his executive vice chairman's post from Infosys. He has funded many institutions and continued to drive them as chairman. To name a few, the Axelar Ventures is the flagship company, an accelerator that helps startups to build their business. The initiative is close to $3 billion as per the Forbes 2023. The Itihasa Research and Digital, very innovative platform, wherein he started the initiative of bringing out the research and history of related to Indian IT and digital world. He himself has co-authored the book Against All Odds, the IT Story of India. He holds many key posts as the chairman, advisor, and member of boards of a number of governmental and corporate bodies and industries that promote technology, entrepreneurship, data governance, and vision in the field of IT. Apart from these, his philanthropic contributions to the society by promoting research and entrepreneurship in India is exemplary. To mention a few major contributions, Sri Krish is the single largest donor of philanthropic gift to IISc Bangalore to the tune of 235 crore rupees to develop the Center for Brain Research, one of its kind, first in Asia. He has contributed in a large way to the neuro computing and data science centers at IISc Bangalore and IIT Madras, his alma mater. Sri Krish Family Trust, the Pratiksha, has created Sudha Gopalakrishnan Brain Center in his wife's name for cellular level brain imaging and mapping at IIT Madras. It's a really futuristic research center. Has funded independently to further the aging research in India to Genome India and Srinivaspura community research projects and the kinds of like that. Sri Krish is chairing the governing board of India's 3,660 crore national mission on cyber, physical systems and technologies. And the list goes on. His contribution to neurosciences, brain research is unparalleled. Why is he investing so much in brain research? We are all wondering. Ladies and gentlemen, let us hear from the horse's mouth today. Sir Krish, may I invite you to the podium to deliver the oration. Ladies and gentlemen, let's give him a big
Thank you very much, Dr. Krishna, for that kind introduction. It's an honor and privilege for me to be invited to be the first orator for the Dr. Pratap Reddy series. So let me start by saluting Dr. Pratap Reddy and the Apollo Hospital Group. It's the pride of the country. It's unprecedented in terms of the volume of patients that it handles, the amount of data that it has, and speaker after speaker mentioned the innovation and the latest in technology that they're bringing to India at an affordable price. So I want to place on record my admiration for the group, and I wish the group, its founders, the family, all the very best. And it's an honor and privilege for me to be invited to this event. Let me also compliment the organizers of the conclave on neuroscience. Clearly, it's timely. I feel that, we in India must contribute, and I will talk more about this. This is the theme that you will see running through my presentation. It's very heartening for me to actually be present here today and appreciate the kind of focus on research that happens here. We know that in India we are overwhelmed with the patient load, but we need to find time to do research also, so that we don't just leverage technology from outside, leverage data from outside, leverage techniques and technology from outside, but we also create the technology the rest of the world uses. I strongly want to advocate this, and I'll talk about it more. Before I proceed, now I want to remind Dr. Satish Chandra, one of the first person I met after I stepped down from Infosys and decided on supporting research was actually Dr. Satish Chandra. At that time, he was at NIMHANS, and I was very impressed with the kind of talent that I found at NIMHANS, and it was reassuring to me to see that we have such talent. And one of the reasons why I decided to support neuroscience, and which gave me the confidence to do this, is Dr. Satish Chandra and the people that I found at NIMHANS. So I stepped down from Infosys in 2014. About 32 years of being an operating person, being running an executive, playing an executive leadership role at Infosys, building a world-class company, building a world-class industry, creating a leader in the field, in the world, in India. Multiple messages there. The belief that we can do world-class things, we can do things at scale, we can create an impact not just in India but across the world. And I felt that confidence we need to show in transitioning India from a user of technology, primarily user of products, to a producer, to creating knowledge, to creating products and technology. Now, creating knowledge is not just enough. We need to monetize that. The monetization step is the transition to creating products and technology from India, which the world uses. Today, if you use a mobile phone, and billions of Indians are using mobile phones, what happens is the market cap of companies like Google, Apple, etc. grow. Right? We don't see the benefit accruing to India. It accrues to somewhere else. And of late, of course, 2 days back, you saw the announcement of setting up the large semiconductor plant in Gujarat, right? So we need to create, manufacture, develop technologies. And I firmly believe that this is a transition that we need to make if we want to transition to a developed economy. And of course, from a doer, I will transition to an orchestrator. Somebody will fund, support, cheerlead, become a catalyst, etc. And I want to, share my expertise and experience of building world-class organization, world-class industry here in India. And of course, last but not the least, I firmly believe that none of us should retire. We have to continue to contribute in any way we can and be productive as long as we can and play different roles so that that's one of the ways you can actually stay active and stay young. Now, I'm just starting with a quote from Steve Jobs, which says that, all the things that we use, and I talked about mobile phone, all the procedures, all the panels that you create, that you use in diagnostics, in healthcare, etc., all of those things were created by people like us. It's no different. They are not smarter or they are not extraordinary individuals. They are like you and me. And hence, I firmly believe in the talent in the country. Firmly believe in the talent in the country. I believe that if we give them the right direction, if we give them the right support, if we give them the right funding, if we create the environment that is required, with the talent that we have, we can be world leaders in many fields. And we should. So that's why I felt that I will pick an area. So again, just context, we need to transition to a $30 trillion economy by 2047. I firmly believe that this is achievable. Per capita income going to about $18,000 from right now about $2,500. Now, this transition can only happen if we actually transition to becoming a product nation. Somebody who creates technology, etc. That acceleration of per capita income cannot happen if we just look at a services-based, per individual-based value creation. We need to look at per individual plus on top of that value addition through the technology and the IP that we create. This is the reason why US has become the most developed or largest nation in terms of GDP. I said no, when 1 billion people in India use mobile phones, the market cap of companies are going up by $1 trillion. Just look at NVIDIA. People started using the NVIDIA GPU chips around the world, and their market cap is today like the GDP of India, right? And that's the power of technology. We need to do that, not just as a nation, as businesses also. And I feel that, if I may, when I look at the Apollo group, I think you have to carve out some part of your efforts, etc., to look at research, to look at products and technology that the rest of the world will use. The returns will not happen in the short term, but returns will definitely happen. And when it happens, you will see that you will go disproportionate to the number of people that you have. Today, mostly your revenue is proportionate to the number of people you have. But if you want to create a discontinuity, this transition is very much required as businesses, as companies, as nation itself. And this is a transition which needs to happen. And that's the reason why, the starting point of that is to invest in research. We have to invest in research to create not just knowledge, commercialization of the knowledge through products and technology. Now, when we look at research, we have to think about the capacity to do large programs. So when I looked into research itself, I found that Indians are doing a lot of research. Look at ISC, look at NIMHANS, etc. But it's research in small size. One individual, a professor, a principal investigator with 1 or 2 PhD students, with a budget of, you will be surprised to know that 90% of, well, almost 100% of the proposals that go to Government of India for research funding is 50 lakhs or less. 100% is 50 lakhs or less. Now, when you look at, the research that's happening outside the country, you see budgets of $1 billion, right? Multiple $1 billion. And here it's not even, 50 lakhs would translate to probably less than $1 million. Well, if my math is right? So this is, how do you expect to create big impact? You will produce a paper, you will produce a PhD, and you will move on. Everybody is happy, but we need to think differently. And that's why I said we have to create capacity for large programs. Can we think of cure for Alzheimer's? Can we figure out, the different cancers? And can we look at diagnostic capabilities, new appliances or new machines for use in healthcare and things like that? So we need to identify these white spaces, take some bold bets, strategic areas, national interest, and think about from India to the world. It's no more about actually just use in India, but India to the world. And this transition, and I'm very glad that the Prime Minister is leading from the front in terms of this vision. He is painting a vision for Viksit Bharat and India's leadership in this transition. And we have an opportunity because every industry, including healthcare, is transitioning right now. With new technology coming in, the treatment protocols are changing, the ability to diagnose is changing, the transition about prevention, from cure to prevention, disease management to health management. All of these transitions are allowing us to create new leadership opportunity. And this is the time that we need to take advantage of, and we can create multiple $100 to $300 billion industry. The reason I take that number is I was part of creating the $220 billion IT services industry. It's possible. It's world-class. It's a world leader. Now, we can create multiple of these $300 billion industries. And we will do that if we think big, if you put together large teams working on unique problems. Some of us will have to take these huge bets. Now, I decided that, rather than just talking about it, I'll put the money where the mouth is. And that's why I decided to make this investment in research. And of course, in supporting entrepreneurs, supporting startups, etc. We have to build this in existing institutions and maybe in new organizations also. India has tremendous advantage. Largest talent pool in the world. It's global in training. If I look around the room and many of you will admit that all of you have exposure to training outside. You've worked outside. You are all global. It just happens that you decided to actually now practice here in India and contribute to India's growth. But the talent here is world class. We have access to the latest knowledge, technology, and equipment. That's something now we have. India represents 20% of the world's population in terms of consumers, in terms of data, in terms of diversity, in terms of many things. India has the capacity to consume as well as produce for the rest of the world because we represent 20% of the world's population. People are desperate to get access to this consumer base and data, right? When they want to test their solutions, if they do not test their solutions in India, they can't say it's complete. They can't say it will work in the entire world because it has not been tested in 20% of the world's population. It's a large market, lower cost. It's very, very important to realize that research in India typically costs 1/5 because the people costs are 1/5 and bulk of the expense, except for the capital, is actually people costs. And we have talent and at a lower cost. And there is an opportunity to create new models in everything that we do. I won't spend too much time, just give you an example. The transition to a sustainable model for mobility, right? Alternate fuels, sustainable non-fossil fuel, etc., electric vehicles, hydrogen fuels. Every industry is going through transition. I talked about the transition healthcare. That creates a new opportunity for leadership, new solutions, new models, and new models for rest of the world. We can export that to our other countries. And last but not the least, just an example of the UPI. Study the UPI story. It is amazing that India created for the world the UPI, which is with just knowing the telephone number of a person, I can transfer money instantaneous, real time, zero cost, almost zero cost. It's our envy of the rest of the world. And we did it. And it also improved inclusivity. About 15-20% of Indians own debit cards or credit cards, but 80% of the Indians can do digital transaction, can do e-commerce and things like that. Why? Because of UPI. So a technology solution which completely transforms an industry and a society is what is possible. And more than anything in healthcare, this is something that we can do. If we need to get quality healthcare to the last person in the country, in the remotest area, it will not happen without use of technology, without leveraging our talent and our expertise in doing this, because nobody else in the world is interested. When the vaccine cost came to $20, they stopped because that's affordable, let's say in the US or UK. In India, it's still not affordable. Imagine, 2 doses, 1 billion people, 2 billion doses at $30 versus what India did is at less than $3 because we manufactured this in India. Actually, we became the supplier of vaccines for the rest of the world, not the developed world, but the 90% of the world. We became the supplier. So when India produces a solution, the entire 8 billion people benefit rather than the 1 billion at the top. This is something that we need to make happen. The rest of the world is looking at India to make it happen. And that's the opportunity that I see. And this is why I'm so passionate about this. Now, coming to area of brain sciences. As I said, I wanted to support research. I wanted to support knowledge creation. I wanted to support producing technology, producing products out of India. But, I could be doing it in anything. But I picked brain sciences because it's closer to computing. And it also addresses a very important problem many speakers before me talked about, which is aging society. Entire world is actually aging, and neurodegenerative diseases which yet don't have any cures. We can probably manage them, but we cannot cure them. So we still need better models of computing and better models of computing will happen by better understanding of the brain, because the most advanced computer that we can think of, which nature has created, nature as an engineer, we need to think about that. the most sophisticated computer in the entire universe that we know of is the human brain, the brain or the human brain actually. 20 watts of power, about 2 pounds or something like that in, weight. It's a small thing, the volume is very small. And that's the most sophisticated computer. We have always wondered about how the brain functions, and that has created the models for computing. Von Neumann came up with the von Neumann architecture, which said that there are separate, he actually imagined that there are postulated that separate area in the brain for storage and processing. And that's the von Neumann model, which created the basic computer architecture. The separate areas in the computer for storage as well as processing. You have a CPU and you have memory. That's the von Neumann architecture. It's a fundamental principle in computing, that digital computing, that enabled digital computing to happen. Second, George Boole postulated that we are logical people, logical animals, and hence brain must be a logical machine. And he came out with the Boolean algebra. Now, all of you know both of them are wrong. But that created the industry. So we have always wondered about how brain works. And that's how we created new models of computing. And all the advances in computing happened because of our wondering about the brain. Similarly, the whole space of AI, machine learning, etc., is because we believe that the brain is a deep learning machine. Successive layers process information, fine-tune it, refine it, and we come to an inference. And that's the machine learning model that's driving the AI revolution today. So every advance in computing happened because of our wondering about the brain. We still do not know how exactly it happens. These are postulates. But what is interesting about human ingenuity is that we throw the power of machine at the problem and come up with a solution. So today, the deep learning machines consume enormous amount of computing processing power, billions of cycles, and huge amount of memory. It requires large amount of data for training and things like that. But that's a brute force way of doing things. And we've always done that. It's not that, so we wondered about flying, right? And when we created a machine for flying, we didn't copy nature. We didn't create flapping wings. We said fixed wings. And we used propulsion technology to propel it forward. But we did much better than nature. If you look at the A380, it can carry 600, 700 people at almost the speed of sound, right? And we can transport. So we always wonder about nature, create machines which mimic nature, but we do much better. You can move from place A to place B faster than nature has created capabilities in us, right? Running, the fastest runner can't compete with the plane or something like that. Very, very similar. A machine can do billions of transactions today, whereas human beings probably will be able to do transactions per second, probably do 300 calculations per second or something like that. But we have other capabilities, and we still need to understand how the brain works. So I said I'm going to support computing and new developments in computing. And second, in the area of clinical neuroscience, to understand one area again, which is the aging-related neurodegeneration, which is a problem that's facing India. We will transition to an aging society in another 30 years. Today, we are proud that we are a young society. The number of people below age of 35 is the maximum in the world as a percentage. But in 30 years, we will also become an aging society, and the number of people above the age of 65 or 60 will be the largest percentage of population. And that is a scary thing today, because in our society, we don't have social security to actually support these people and make sure that as they age, towards the end of their life, they don't face challenges, they don't feel left out, or there is nobody to look after them. It's a huge problem. And when I choose these areas, I have chosen them where we are on par with the rest of the world. The rest of the world is also trying to find solutions, right? There is no cure. We still are wondering about, diseases like Alzheimer's, etc. What is causing? It's probably a multidimensional problem, multiple causes for this, etc. But we still do not have solutions for this. So India can actively contribute to the solution, and that's why these are the two areas that I've picked. On this, say again, I don't go into this without some thought to try and see whether we can actually create something different, new, etc. So on the brains, the computational side, what I did was, how can we accelerate creation of this field? So we created 3 chairs at Indian Institute of Science and 3 chairs at IIT Madras. Each of these chairs is occupied by a leader in the field from outside the country, primarily from the US. And around these scientists, we build teams in India. And we begin creating that field here in India. And I'll tell you one example here. So these scientists are expected to spend 1 to 2 months in India. But today, with technology, they are always connected. So even though they only spend 1 to 2 months, once they have established a relationship with people at IISc or IIT Madras, they're constantly in touch, either on research programs or publishing or coming up with new proposals for support and things like that. And we create collaborative research. It also accelerates our ability to enter a new area or a new field, creates a pool of talent of young faculty, young PhD students who will help create this field. Now, one example is, you must have read about Elon Musk Neuralink, right? Now, Indian Institute of Science has come up with a brain co-processor proposal, which they hope to actually start trialing over the next 2-3 years, which is a implant for epilepsy and things like that, a microchip, which they will implant in the brain. So we have this capability. I'm telling you, we have this capability. We just need to, I push them to create larger teams. Now, this team is, the part of the people are in the US, IIT Kanpur, Indian Institute of Science, NIMHANS, all these people are collaborating. I talked about large teams, right? This is just one example of what research can be done, can happen. There is no guarantee that every one of them will succeed, but we have to try. And if we try 20 things, maybe 5 will succeed, 3 will succeed, but we have to try. So this is on the computational side. Now I'll take you to on the clinical side and take you through this data where I'm going to show you is about 6 months old. Deliberately, I've taken an older piece of data. Much more work has been done. It is for me to demonstrate to you the work that is being done. I'm not the scientist. I said I'm an orchestrator, but I just want to share with you the type of work that's happening. And more importantly, I want people to think about such work. I want you to think about collaborating with these organizations and these research teams, and maybe replicating these in your organization. So we set up the Center for Brain Research at Indian Institute of Science. There was a mention of Dr. Vijayalakshmi Ravindranath. It's a brainchild of Dr. Vijayalakshmi Ravindranath. Actually, she's the founding director of this center. And the work that is happening, there are 3 streams of work. One is a cohort study. The Center for Brain Research, Srinivasapura Aging, Neurosense Enhancement and Cognition Study, which is one of the largest longitudinal studies on rural aging population, first of its kind in India. It's a tracking of 10,000 people around 45 years old again, collaboration with NIMHANS here, and tracking them, how they age over the next 15, 20 years. Already about 5,000 people's data have been collected. This is very, very comprehensive. Basic health parameter, cognition, tests, X-ray, imaging, MRI, DNA sequencing. The samples are kept for future research, stem cell research and things like that. And to understand the India's unique diversity and genetic susceptibility, socioeconomic characteristics. Again, I come back to this. Every test that we use today, not every, let me correct that. Many of the tests that we use today in India uses data from developed countries. And we don't know whether it's relevant, applicable, how relevant, how applicable these are. And this is an attempt to create a database for research, for diagnostics, for further work to be done. Now, looking at risk factors, protective factors. So we consume a lot of turmeric and other, other unique Indian food habits we have. So are they beneficial? Are they going to create a positive impact on aging or cognition? Then the genetic basis for neurodegeneration. Are we more susceptible, less susceptible? Is the rural population more susceptible? Is nutrition a factor? Literacy a factor? Because here in India, we can look at literate and illiterate. We can look at malnourishment. We can look at all kinds of parameters, multilingual versus single language capabilities, and formulate public health guidelines to minimize the burden of neurodegeneration. So there are multiple objectives for this. The work is going on. Similarly, there is a Tata longitudinal study of aging. This is supported by Tata Trust, which is happening. A lot of people are volunteered. I don't know whether there are volunteers in this group here, but a lot of people in the city have volunteered. About 1,000 people who actually every year come to get tested at the center, and we collect the data. Again, the same parameters, health parameters, we test the cognition, X-ray, MRI, DNA sequencing, etc. And this will give us an ability to compare and contrast between rural and urban. And urban is typically slightly older, highly literate, multilingual, reasonably well fed because they're upper middle class, and it's a good way to compare and contrast these two populations. And again, this data will be available for further research. And one of the things I've recommended is all the data be available in an open format for researchers. So yes, all the researchers want to get the first right to publish, but after that, this data is open for others to use. And there are a lot of projects already working with IAC on the data already. Genome India is a program that IAC did with, so Center for Brain Research was the anchor institute, did with Government of India. It's a Department of Biotechnology-led program. For the first time, we decided to pool the data. And this is something, again, I recommend. See, if we want to use artificial intelligence tools today, we need large amounts of data. And I found that every lab is subscale. They have data points of 500 subjects, 300 subjects, 200 subjects. So we said, why don't we pool together? And at least now we have 10,000 data points. You saw the announcement just about a month back saying that we have now completed full DNA sequencing for 10,000 subjects. We can now think about a GWAS chip, genome-wide, I don't know what AS stands for, right? So we can create a GWAS chip which reduces the cost of now testing, right? So we need to think about intelligent ways, smarter ways to work together. So we were able to bring together 20 labs across 15 states. It also brings in the diversity of population, north, south, east, west, etc. And the results are going to be announced pretty soon because they expect the first paper to be published in the near future. So the data is now available. And after that, this data, I'm told, will also be available for researchers to use across the country. So the Center for Brain Research's dream is about creating a hub for neurodegenerative diseases. It's collaborative. It works with NIMHANS, it works with NCBS, it works with the Transdisciplinary University on some of the Ayurveda treatment protocols and things like that. So, and they're also looking at interventions like yoga, meditation, music therapy, you know, what effect it has and things like that. We want to be a leader in cataloging and reporting data on the prevalence of dementia. I think the initial results show that 6% of the people are showing neurodegeneration. 6% of the people, both in the rural and urban cohort. We want to look at a think tank, becoming a think tank to formulate public health interventions, etc. So, you know, just giving you a glimpse of what work happens in CBR. If you are interested, I advise you to, or recommend you to actually visit the center, interact with people, think about opportunities for collaboration, etc. Now, let me come to the IIT Madras Center. You know, it happened just purely by accident. You know, they were actually looking at one of the projects they were doing was to map mouse brain. Suddenly the question happened, why not just jump to human brain? They said impossible, too complex, can't be done. And don't even attempt it, actually. But this center has now become the world leader in creating a human brain atlas. Okay, so to date, there are no high quality human brain histological data atlases at cellular resolution. Nowhere in the world at cellular resolution. And so this lab is attempting to do at 1 micron resolution data on human brain. And this could only be done at a place like IIT Madras because they have created an engineering pipeline. It's really an engineering challenge. It's not a medical challenge. From the partners that they have in the healthcare community, they're able to get brains of dead people, cadaver brains. Of course, there is a protocol within 8 hours. They would like to have an MRI of the subject taken before death and things like that. And it's preserved. I won't go into the details. There's a complete protocol they have created. Now, this protocol itself is actually of a contribution actually to the field itself, how to go about doing this. You know, a large adult brain is cut into 10,000 sections at about 20 micron thickness and 0.5 micron resolution. Images are taken. Now imagine each image is such a huge amount of data, and a human brain creates petabytes of data. Now, this challenged the computer scientists actually. How do you store? How do you retrieve? You know, they're able to process now 3 brains. They want to process 10 brains per month. So you need faster computers. They're stretching the limits of computing itself. So this is actually advancing the fields, not just in healthcare, but in computer science, in engineering. You know, how do you look at mechanically slicing without destroying human tissue at this thickness, at precisely this thickness, right? And imaging them, capturing that image into a digital image into the computer, assembling it back to create a 3D image of human brain. Now you can actually go into the computer and traverse through this. More importantly, they have longitudinal data. They have a brain of a neonatal brain conception. So different stages. Child's brain, 1, 2, 3 years old. Adult brain, older brains, diseased brain, Alzheimer's brain, rabies brain, Parkinson's brain. Now, this data is amazing. This is like the first time human genome was sequenced. This is the first time we are going to get a physical image at this resolution of human brain. This is anywhere in the world. Already 20 different labs across the world are collaborating with them. There are visiting professors who are coming into IIT Madras. The queries are coming in. We want to work with IIT Madras. We want to be a visiting professor. We want to spend 1 or 2 months at this laboratory. Because this is truly world-class. Here the results are actually very quick. Within the next 2 years, already we are far ahead of anybody else. 50 brains have been already captured, right? The best in the world is about 15 they have been able to do. We have already crossed 50. We want to do 130 so that nobody can even catch up with us in the near future, right? And we will have the most comprehensive atlas, digital atlas of human brain under various conditions. You can look at what happens when the growth happens. We can look at what happens when disease strikes. We can look at differences in different regions and things like that. All kinds of things are possible. Technology platform has been created. A pipeline process has been created. Globally first cell resolution, volume of whole developing human brain, all kinds of things. I will not go into this. We can also look at advanced disease diagnosis and things like that. And for the neurophysicians and surgeons, hopefully this atlas will be used to train people also in the future. This will be the atlas that will be used to train people in the future. And we are on par with the rest of the world. The rest of the world is talking about a human brain project. One of the objectives was to create an atlas, and we have actually advanced far ahead of others already in doing these things. So let me conclude by saying that we are able to do world-class research here. We must do this. There are mechanisms to do this. I talked to global philanthropists who are supporting brain research anywhere in the world and told them that if you're not including India in your research research program, then you're missing out a big advantage that India provides in terms of subjects, in terms of data, but more importantly, in terms of cost. We have the same talent. They're all trained in the same machines, same equipment, same hospital. Leverage them. And we can do it at 1/5 of the cost. So it's a huge advantage that we have. Support visiting professors, postdoctoral fellows. I'm also telling people of Indian origin anywhere else, spend 1 month here. Create a research collaboration. Everybody will benefit. And that's again a strength that India has. Our people are all over the world. And we need to leverage them to do work, not just for India. This is for the world. This is for the world. So joint PhD programs. So with NIMHANS and University of Liverpool, we just kicked off joint postdoctoral programs and PhD programs, again in the area of neuroscience actually, all to encourage collaborative research, to encourage leveraging Indian talent, Indian subjects, Indian data with world-class researchers, to bring India on par with the rest of the world as quickly as possible, to create products and technology out of India. And I feel that if in healthcare, we can kick off 20 large programs, right? I will leave it to you to imagine. My endeavor was to look at neurodegeneration and create a research effort in India in neurodegeneration. We have seen some early success. But I hope that we can talk about this in a much bigger way in the future, in times to come. But more efforts are required, and that's my purpose for speaking to you today with the Apollo Group's reach, its scale. You already have probably the world's largest database of subjects and patients, etc. You have one of the largest pool of resources and talent. Of course, money is always limited, but we need to find the money to do this work in India. And I feel that it will also create a non-linear revenue stream for you in the future. So thank you all very much. I hope this was something very interesting for all of you. Thank you very much.
Thank you, sir, for an amazing oration. We all go back today wiser. While I say wiser, we've also had a great scientific program today. We could interact with a lot of neurologists from Apollo, neurosurgeons, neuroradiologists all over the country. Felicitation.
We're very happy that the organizing committee has done a great selection for the various neuro and neurosurgical problems to be discussed during the
We'll go ahead with a felicitation for our honored dignitaries on stage. I would like to request Dr. Harshad Reddy, sir, to felicitate our chief guest of today, Dr. Krish Gopalakrishnan. A round of applause for Dr. Gopalakrishnan. I would like to request our and Dr. Satish Chandra sir to kindly facilitate Dr. Harshad Reddy. Our Director of Oncology and International Relations. Very happy. I would like to request Dr. K.N. Krishna, Senior Neurosurgeon and Head of Neurosurgery in Gynaecology Apollo, to felicitate Dr. Madhu Shashidhar. Dr. Madhu Shashidhar is our Chief Strategy Officer, Apollo. I would like to request Dr. Satish S. to come forward, please, sir. I would like to request Dr. Satish S., Senior Neurosurgeon and Head of Neurosurgery, Apollo Banarghatta Road, to kindly felicitate Dr. Manish Mattu, our CEO. Thank you very much. We've had a very eventful inauguration ceremony. Thank you to all the dignitaries. I'd like to call Dr. Ravi Mohan Rao, Senior Neurosurgeon and Head of Neurosciences. Please be seated, sirs, to render the vote of thanks.
Thank you, Dr. Sujit. Ladies and gentlemen, what a wonderful night it has been today. I am honored to be giving the vote of thanks. I profusely thank our beloved Chairman Padma Vibhushan Pratap C. Reddy, Vice Chairperson Dr. Preeta Reddy, Joint Managing Director Dr. Sangeeta Reddy for being our perennial source of inspiration and encouragement. Mr. Harshad Reddy, Director of Group Oncology and International Relations, has taken off from his busy schedule to be with us. I thank him thank you, sir, from the bottom of my heart. I thank Padma Bhushan Chris Gopalakrishnan, who is widely admired all over the world, for his gracious presence tonight and wonderful thought-provoking oration on brain research. I'm reminded, Chris Gopalakrishnan sir, when I heard your lecture, something which can only parallel this on what you're trying to do is in astronomy. The known universe has trillions of galaxies, and each galaxy has billions of stars, which have so many worlds rotating around that, and which we know possibly a fraction of what's happening outside our solar system. And the way you described your project, it rivals that. Thank you very much. I wish to acknowledge Dr. Madhu Shashidhar, Chief Strategy Officer, for his presence today in this August gathering. Thank you, sir. I'm grateful to Dr. Manish Mattu, CEO, Dr. Yatish, and Mr. Uday Davda for their continuous support in conducting this program. Very importantly, I want to acknowledge the hard work of the operations and marketing team of the region, including Ashwini, Aishwarya, Preeti, Gopi, Sunil, Ravi, and their teams for making this event a successful one. I also want to thank Dr. Kalpana for her coordinating efforts. Very important, I want to thank Professor Satish Chandra and his organizing committee, who have done a wonderful job of holding this conclave. Thank you very much, sir. I've seen him work day and night to make this conference a successful reality. Most importantly, the speakers, the delegates, and postgraduate students who have come from afar and participated actively in lively discussions today and will do so tomorrow, are making this conclave a huge success in trying to build up collaborative work between different Apollos in the coming future. I want to thank Professor G.N. Narayana Reddy, Professor Chandramukhi, Professor H.V. Srinivas, and Professor Pushpa Srinivas for being here tonight among us and enlivening the program. I thank the folks of Sun Pharma for their generous contribution and efforts in making this conclave a huge success. As we reflect on the knowledge gained and connections made during this conclave, let us carry forward the spirit of collaboration and innovation in our continued efforts to improve neurological care. Thank you once again for being part of this incredible journey. Here's to a future filled with advancements in neurology and better outcomes for patients worldwide. Thank you so much.
As we come to the end of the day, I request all present here to stand for the national anthem.
जय भारत भाग्य विधाता पंजाब सिंध गुजरात गंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष तुम्हारे गाए तव जय गाथा जय गण मंगल जय हे भारत भाग्य विधाता जय हिंद जय हिंद जय हिंद जय 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 जय
Thank you very much for gracing the inauguration ceremony. May I request all the guests and delegates to move to 4th floor terrace. We have a banquet, cocktail and dinner arranged. So I request everyone to